before going into the meeting. Thank you.
Thank you very much, Chief Austin, for the introduction. I am Oguche Iberi Deborah Ike. I am the Francophone Regional Manager of the Global TB Caucus, and I'm also in charge of Nigeria. You're very much welcome to this meeting, and thank you so much for finding time in the midst of your schedules to be part of this meeting today, which is themed Achieving the Africa TB UNHLM Commitment Targets, I beg your pardon, by enhancing CSOs and communities' engagement in the region, lessons learned and the opportunities for the future. Like Chief Austin,
can you speak slowly because of the translation?
Okay, so for the sake of time, like Chief Austin mentioned earlier, please use the chat box to introduce yourself, use the chat box to introduce your organization. I'd like to send a very warm and special welcome to all panelists, all CFCS implementers and their collaborators, and to all participants in general. The aim of this workshop is to enhance TB CSOs and communities' access to relevant information on the global, regional, and national TB responses, including the Global Fund processes, WHO, and Stop TB Partnership, as well as engaging in relevant policy dialogues related to the UNHLM targets. The meeting is targeted towards empowering CSOs and communities to enable effective engagement in advocacy, in activism, and decision-making processes relating to the TB responses. And this meeting today is set to address 5 core objectives. These objectives include sharing of experiences and taking stock of CSOs and community engagement in the CFCS grants, to introduce community-led monitoring, to support civil society and communities' preparedness for effective TB CRG assessment, to develop regional advocacy priorities and plan on how civil society and community groups will meaningfully be engaged. The final objective is to increase the understanding of CSOs and community-based groups in global fund processes. We have a very rich agenda with very interesting sessions. And I like to mention that for implementing partners, that their names, the names of their organization did not reflect on the agenda. You have the opportunity to introduce yourselves during your presentation. Thank you very much, everyone. And I wish each and every one of us a fruitful meeting today. Thank you. Over to you, Chief Austin.
Thank you, Deborah, for that wonderful introduction and objectives of the meeting. This is really good. And I'm happy to see lots of faces and new faces as well, not just only the usual suspects, participating. I also want to acknowledge that WHO joined the meeting very much more early, which shows a lot of commitment, and also from Global Fund and USAID. This is very, very well welcome. I think we'll be moving straight to our welcome note. I will be inviting Carol, but before I invite Carol, I think what I should do is actually to invite the chair of the section, which is Olive Mumba, who will be in charge of this section, the welcome notes, and also the section 1. Olive, you have the floor now to share all the sections. Thank you.
Thank you so much, Chief Austin, and a big welcome to everyone for joining us in this call. And it's going to be, the next 3 days is going to be action-filled and a lot of discussions around TB. And we are looking forward to getting your views and also learning quite a lot and sharing our experiences. The next round, getting to know and getting to hear from our leaders with the community. And this includes Ms. Carol Kachenga Nawina Nyirenda from Zambia. I'm welcoming you to Tanzania, but Carol is one of the founding members of ACT Africa, and she has played a very vital role in ensuring that TB is the agenda. Carol Kachenga Nawina Nyirenda is the executive director of CITAM Plus, which is an organization working with HIV, TB. I would want to welcome in Carol. Immediately after Carol comes in, then we will have keynote addresses from Peter Sanz and Luchika Ditu. I will them later.
Olive, 1 second. I think I'm getting feedback from Bertrand that the translation is giving them a little bit problem. I don't know whether ask them whether it's fine now before we can call in Carol.
Okay.
Bertrand, can you confirm that the translation is okay now?
CIA. Wow, CIA.
Bertrand, can you confirm that the translation is okay? I'm also acknowledging the presence of Dr. Luchika Ditu.
If you was in Lagos, at the center of that, you could have heard this one.
Bertrand, can we move on if the French translation is fine now?
No, we still need to fix it because there is some issue.
Rodrick, can you check the translation, please?
Check if it's okay.
It's okay?
Probably. Rodrick, can you explain what people have to do for the translation? What do they need to do?
Rodrick, can you repeat the logistics on translation so that it can actually...
Okay. Hello, on the screen they will see where it is written in French. So they just click. There's a French button. Can everyone see that? French?
Hello? It's actually under the interpretation icon. So if you click the interpretation icon, you will see French and English.
French.
Rodrick, can you make the announcement once again before we continue?
I'm saying under interpretation, there's French and English. So they'll just select like French, and then that's all that's supposed to be done.
Bertrand, confirm, please. We do not want to leave anyone behind. Can you confirm, please? Bertrand, ça va chez toi? C'est bon maintenant?
Oui, chez moi c'est très bien maintenant.
D'accord, merci beaucoup.
Ok, merci. J'espère que les francophones aussi, ça va pour eux. Parce que chez moi, j'ai réussi à capter le channel en français, c'est bon.
D'accord, merci beaucoup. Olive, please, you can continue. Sorry for that interruption.
Thank you very much. You know, but what I realized, Austin, is when we were giving the instructions, we are giving them in English and we are not giving them in French. So probably someone who is French speaking can give those instructions in French.
Okay, let me do that.
Yes.
Bonjour à tous. Je vous prie de bien vouloir vous transférer à la chaîne d'interprétation pour entendre la réunion en français. S'il vous plaît, cliquez sur l'icône d'interprétation pour choisir la langue française. Merci.
Thank you very much. Thank you so much. Now we are moving on to the next session, which is the welcome note, keynote address and remarks. And as I introduce, our next speaker is Ms. Carol Nawina Kachenga, who is the Executive Director of CITAM Plus, an organization that works in HIV/TB in Zambia. Carol Nyirenda is one of the founding members of ACT Africa. So I will briefly introduce Carol to come in, and then I will introduce the next speakers as when Carol finishes. Carol, over to you.
Thank you very much, Olive. And thank you very much, everyone. I'd like to welcome you to this call. It's really great to see so many people joining this call, especially that we are all still grappling with the new normal, with this issue of having virtual calls. We are struggling, but it's really great to see that most of you have joined this session. As Olive has indicated, I'm one of the founder members of ACT Africa, which was initially set up in 2012 and then revived in 2016, around 2016, 2017, with a new steering committee that was led by Austin and other members, including Olive and others. A team that I'd really like to thank for all the work that you've done in the past few years. And one of the reasons why we set up ACT was to really give a chance to voices to the TB survivors so that they can also be able to be heard, but also to see how civil society and affected communities who, I mean, we are the recipients of care, can take part not only in the management of our illnesses, but also to actively participate in the response to ensure that we meet the ambitious targets which we set of ending TB by 2030, but also to be part of the response by helping to find the missing 40% cases globally. So just a quick, I thought I should just share a quick snapshot of what has been achieved in the last few years ever since ACT was revived. I think around 2017 and 19, ACT supported 6 countries through the Global Fund CRG funding, again, to find the missing cases. And the countries that were involved were Nigeria, DRC Congo, Kenya, Tanzania, South Africa, and Mozambique. And so much work was done in that. And then to ensure that civil society are also around the table in decision-making bodies. We also supported Global Fund communities in the Global Fund processes. So they were supported, countries that were supported again were Nigeria, Cameroon, Kenya, Burkina Faso, Ethiopia, Ghana, and Eswatini. And under the challenge facility, we are also working to support Anglophone African countries, as well as building the capacity of our partners in the Anglophone countries through draft TB. So the next steps as we go forward to still do our work, we are working again with support through the Global Fund to build the capacity and strengthen national TB networks and regional advocacy, and also come up with a hub for TB, civil society and community networks. This is really our work in the African region to bring our efforts together. So just as I conclude for this meeting, for me, I'm really excited. I think we've always wanted to have a meeting of this magnitude. And kudos to the team, especially with Chief Austin. Thank you for all your great work. The first 2 days, as we have heard from the first presenter, are sort of really learning and sharing from each other. But for me, what is really exciting, which I hope most people will join, was the last day when we are going to have a workshop on community-led monitoring, a skill that we really need right now, if we really want to have our voices heard, and also so that our partners can also respect the work that we are doing. Because in most cases as civil society, we do so much work, but we're not very good at documenting or showing the right data. Because for the community-led monitoring, this is a skill that we as civil society really need to gather quantitative, but especially qualitative data and observation, so that we can assess the availability, accessibility, equity, and quality of services that we receive as we go to the health facilities. And then with this information, once we get it ourselves, we can use the same information to hold our service providers and the decision makers accountable. So this is a timely workshop. Thank you, team. We really need that. And I hope a lot of people will stay on. I know 3 days can be a long time, but it will be a very important workshop. So for this, I'd just like to also thank our partners who are on board, Luchika, WHO, everybody else. Thank you for joining us and all the support that you've been there all along. CRG, Global Fund, everybody else, thank you very much for all your support. So for now, I'd like to welcome us all and wish us all a fruitful 3 days. Thank you.
Thank you so much, Carol. Thanks for the remarks. And the next two speakers will be giving us their keynote addresses. I just want to say that the Global Fund has been a very key partner to civil society and communities. We have seen since the inception of the Global Fund how engagement of the key affected communities has been high on its agenda, not only at global level within the board, but also at country level as community representatives on this country coordinating mechanisms, but also as implementers. And it is with great joy, I would like to also welcome the Global Fund, who is Peter Sands, the Executive Director of the Global Fund. I am not sure whether Peter is here, so if I can just be guided there. Okay.
Hello, everyone. Hi, hello everyone. This is Gilles Cesari at the Global Fund CRG department. Just a note to say that Peter will join us at 10:05, I think. So if we can slightly reorganize the order of the first speakers, that would be great.
Thank you so much, Gilles, for informing us, and that has been noted. So we'll all be hearing from Peter at 10:05. Thank you so much. So with that, I would also want to move on to our next keynote address speaker, which is Dr. Luchika Ditu. Dr. Luchika is the Executive Director of Stop TB Partnership, and she has been a very good friend to communities and civil society, as we have seen in terms of the engagement of communities in the TB response coming higher and much stronger. Communities have been able to now greatly understand why TB is one of the key elements where they also need to engage so that we bring TB to a stop. Not only that, she's also been able to bring partners on board so that we are able to have the resources, both technical and financial, to do the things that we need to do within our communities. So it is with great pleasure I would want to invite and welcome Dr. Luchika to give us her opening remarks, the keynote address. Thank you.
So thank you so much, everybody. And first of all, it's really a great honor and pleasure to be here with all of you. And I'm really happy to see you all. And I want to start by saying, first of all, that thank you very much for all of you working to make this happen. Chief Austin, Deborah, Carol, Olive, and all of you. And I'm sorry if I forget or I don't mention names, Bertrand and so on. You know, it's the number of people attending is growing. So we are now, as I see, at 66, and I hope we will go to even a bigger number. It's a great opportunity to have a 3 days event like this. And as I think you, Olive, said, and Carol, actually, you said, sometimes we think about this and we say it would be good to have such an opportunity to take stock of where we are and where we should go, but without necessarily rushing and running through things. And I also add my voice to the one of Carol in saying, try and enjoy the last day about community-led monitoring, because it will be very important, the discussion around that. And I'll go back to this. So I want to, as I said, thank you for the organizers. Thank you for the agenda. And thank you all for taking the time to join, because I know that, and we all know that it's not easy, not only the daily lives and the complications of the daily lives, but all that COVID brought in front of us with all this unprecedented scale of not necessarily lockdown, but impact on our daily lives, on our families and friends, but also implications for the way we work and for the way we interact. And thank you for actually being able to navigate this and still maintain the work going. We come from a long way indeed. And this is, we should all be happy where we are. It's not that we are out of the weeds, it's actually a long way to go. But as you recall, for a long time, when it was about, when it was a conversation about TB communities and engagement of civil society, very often people were saying, oh, but there is nobody that is caring about TB. And we are now in such a situation that we actually have networks in countries. We have networks at regional level. We have networks that are really able to push the agenda and make the voice of people with TB heard. This is not, we pushed a lot from the Stop TB Partnership side, because as you all know, I feel very obliged to deliver, because the reason that we exist as Stop TB Partnership, and there's a lot of organizations, is the fact that we have to serve people that are affected by TB and are less lucky than we are to have a voice or to have a position or to have a place to be able to get what they actually deserve. So I always, and I will remain fully committed on the empowering, but not just empowering, but actually creating the entire environment in which civil societies, communities, everyone that is affected and everyone that represents the civil society should have a space, but should be engaged properly in planning, implementation, and more than important, in the monitoring of the efforts. This was not done by us, obviously, alone. We are grateful because, to be very honest, we had, as you mentioned already, and Peter will be here, a Global Fund who supported a lot this work and hopefully will continue. But also, and I know that some colleagues from USAID will join. Also, as you know, USAID is a big champion of supporting civil society, affected populations, vulnerable groups, and also through their TB accelerator, supporting the grassroots and the organizations that are coming from countries. As you know, I think we have a bit of background noise. That's normal, but mute will be probably easier. As you know, very often the grassroots organizations are not able to become either recipients of the Global Fund or recipients of big donors because of many reasons, including, you know, when you apply somewhere, the lack of experience or the lack of rolling big amounts of money. So that's why I think that the way in which USAID pushed the fact that small organizations should be funded, and we, through challenge facilities, started gradually providing smaller funding, then a bit grow bigger, because otherwise we will never raise the capacity of organizations if we will always fund just the big ones. So funding the ones that are from the grassroots, the ones that are in the cities or in the villages that know much better the environment in which we are, in which they know much better what's happening and how to find and serve their people, is extremely important. The point that I want to make Somebody will need to stop me because I can speak a lot like this, because now I want to move to the fact that we are all faced with COVID, okay? And Olive, you wave to me and you say, stop, madam. You are holding us all together here. There are some people still speaking about la version française parce qu'elle marche pas très bien, je crois. But what I wanted to say is that we are faced now with COVID. We need to do two things with absolutely no hesitation. First, flag every time there is an impact in the TB services, in access, in people not being able to access their services, to access the quality services, being pushed away, either because they are with other diseases, either because of their vulnerabilities, either because simply things don't exist. And we need to demand that there is absolutely no interruption in these services, and that more than that, the TB services are not actually moved away from TB doing just COVID. Is not just about TB services. You will hear that also financing is in some places moved away from TB to cover COVID. This we should not allow to happen. But more than that, because sometimes it's like, okay, it's very easy, you guys say, don't take the money, but we have no other option. The options should be created by being smart and trying to see, can we do TB and COVID in the same time? Can be done much more into the communities in such a way that we can serve both TB, COVID, and HIV and malaria. Why not? So the faith-based organization, the volunteers, any type of CSO that is at grassroots, and must continue their work and must be well prepared to face what they will see in their communities. My parents have COVID, both of them in a village in Romania. And it's a mess because nobody prepared the community and even the very young health workers that are there. So everyone is paralyzed and scared. So people need to be trained, need to be empowered, and need to be funded. And there will be funds enough, especially coming from COVID, to be able to address TB and COVID as well. We constructed a lot of platforms in TB, in which they can very well be used for COVID as well, including people which are very well trained. But as you know, all the tools that we have for active case finding, for going into the communities and being able to diagnose, to find people, to take their sputum, to make an X-ray, this can very easily be used for COVID and TB as well. The only challenge we will have will be the financing. So ensuring that there are also no diversion of the resources from TB to COVID, it's absolutely essential. The Global Fund strategy starts being developed. It's in the full swing on that. As a TB community, collectively, all of us, irrespective of being civil society or technicians or donors, we need to come with one voice that we ensure that in the strategy we have the right space as TB, but especially the civil societies, the gender aspects, the rights aspects, the work on stigma will be extremely important to be there and not to be forgotten. The last point that I want to say is this. Community monitoring is extremely important, and Carol mentioned it, and Olive as well, and you will have the third day devoted to this. It will not be easy because there will always be a sort of friction between the government and the national program and the communities coming to monitor what is happening. But we need to have that conversation, and the NTPs should be happy to use and to serve the communities, but also the communities to serve the NTP to understand which are the issues. There will be nobody more honest, more empathic on what is happening in a community than the people from the community in explaining if the services are available, if the quality of the services is there, if the drugs are there, the diagnostics, if you are a vulnerable group, are you well received or not? So that's why paying attention to this. We have some tools, but I think we should even start next year in looking and taking some country examples and doing it and seeing what it means and how what the findings are will be put in function. I think that will be extremely important. So it's a very rich agenda. I am happy you have a good lineup of speakers. And I am really very honored that you invited me here, as well as I'm very honored for all the support you provided to Stop TB and me along the years. We remain shoulder to shoulder because it's a long business to finish this. And because we are, in a way, at least I feel myself, I'm staying here in Geneva, obliged to continue to deliver for people that in 2020 die of tuberculosis, and that should not happen. But we are all together, and I think we can address this. So thank you so much, and I'm staying here with you for the next hour or so. Thank you.
Thank you so much, Luchika. And I forgot that I'm using my phone because of challenges on my laptop. So I was seeing a message coming in. So I wanted to respond to it, and I think I moved myself closer. So I hope I didn't switch you off or stop you in the way. Okay, thank you very much. Thank you for reminding us about COVID as a barrier, but also COVID as an opportunity for us to even look at strengthening the response to TB, especially as communities using the already existing structures. Thank you so much for also mentioning and reminding us about the Global Fund strategy as an opportunity for us to engage and ensure that the issues around TB are included. And mainly around community-led monitoring, community-based monitoring, that we have the voice. It is a tool which provides us a platform to also voice out our concerns. So with that, I would like to just mention that Sherry Vincent of USID, who is based in the US, will be joining us a bit later. We know that this is too early for her to join us. So she'll be coming in session 2. So with that, I would want to skip her. And then also Peter Sands has mentioned that we've been told that he'll be coming in a bit later. Now, I would want us to move over to Africa, and we would want to hear from Dr. Benjamin. I don't want to I can't pronounce the second name. So Dr. Benjamin, you have to forgive me for not being able to mention your second name. But Dr. Benjamin is the head of the Policy, Health, Diplomacy, and Communications division within the Africa Union, CDC. Dr. Benjamin has been a very strong partner for civil society, and we have always been working in close collaboration. Can I give you the space to just present and give us your remarks? Over to you, Dr. Benjamin. Austin, I want to confirm, is Dr. Benjamin on? Yes, thank you.
Ladies and gentlemen, it is indeed an honor and privilege for me to address this very important and timely gathering under the theme, Achieving the Africa Tuberculosis UNHLM Targets by Enhancing CSO and Community Engagement in Region, Lessons Learned and Opportunities for the Future. I hope that this meeting will galvanize coordinated response to the increasing social and economic burden caused by tuberculosis, especially during the ongoing COVID-19 pandemic. As a curable disease, tuberculosis belongs to the past, but it is still very much part of our modern world. COVID-19 has further aggravated the incidence due to the interruption of services, but we can keep the fight strong by leveraging on the power of community participation and involvement. Historically, we have seen that home or community-based tuberculosis testing and care is very effective and cost-effective, especially in the rural areas. We should therefore continue to advocate for community-oriented health promotion. We should also remember to address the key linkages to TB and HIV care, which is a core facet of substantially reducing disease burden and associated mortality in Africa. One of the goals of the catalytic framework to end AIDS, tuberculosis, and eliminate malaria in Africa by 2030 is to empower African Union member states to strengthen community-driven systems to expand health services delivery in particularly hard-to-reach areas in the context of leaving no one behind. The catalytic framework also calls on member states to empower communities as agents of change for their own health. I encourage member states to leverage on the strategic pillars indicated in the framework and implement effectively as it was developed with keen attention to the continental context. I invite partners in this meeting today to extend support to member states to integrate and mainstream community health system into the national system so we can collaboratively meet the UN HLM targets. The Commission and Africa CDC will continue to engage member states and stakeholders to increase their commitments and investment in our determination to combat tuberculosis. I wish you fruitful deliberation. Thank you.
Thank you very much. Those were remarks from Dr. Benjamin from the Africa Union CDC. We are now going to be moving on, but before I move on, I would like to explain in terms of the French translation. If we are connected, we will have a place where see it's written language interpretation. There we will have the option of English and French. For those that are speaking in French, those that will be speaking in French and we are in English at that time, we will press the English button. But when we want to understand the French, we will have to press the French button. I would like to request one of our colleagues who speaks French, if we can also explain this to our colleagues who are from Francophone and cannot understand what I just said. Please, if someone can explain that.
Yeah, I will try to explain. The issue is that at the same time, when you use the French channel, you listen at the same time the main presenter and the French language. So maybe the host can try to fix this because this is only a technical issue. And I tried to raise this issue since the beginning of the meeting, but we don't have any solution. So maybe we can take 5 minutes and try to fix this, to make sure that all the French speaking have the opportunity to listen what she's saying.
Yeah.
I'm very sorry that the French.
Bertrand, I think what you usually do is that you have to mute original language. When you choose the language, you mute original language before the translation can move on.
OK, donc vous devez fermer, quand vous êtes sur le volet interprétation, vous devez fermer le son original pour laisser passer uniquement le son en la langue de traduction que vous souhaitez, donc en l'occurrence le français. Donc, ce qu'on peut faire, c'est qu'on peut tester un peu ça pendant 5 minutes, parce que même dans ce contexte-là, parfois l'interprétation en français arrive avec une voix trop faible. Donc, essayons de tester un peu ça pendant 5 minutes pour voir si ça marche. Et là, on aurait besoin du feedback des francophones qui sont connectés pour voir si ça marche.
Can we try, maybe if there is any feedback right now, can people still hear the feedback or has it improved?
No, pas du tout. Not really, Olive. Sorry that I jumped. I just did this. I muted the original. So Olive was speaking. J'ai fermé l'original, mais je peux pas entendu le français. I didn't hear the French. When I muted, then I couldn't hear anything. Neither French, neither English. So the French seems really not to work. Maybe we try again. Can you speak in English, Olive? Can you just go ahead?
Okay. So far within our program, we have heard Caro Nawina provide us with welcome notes, and then we moved on to the keynote address. We've heard from Dr. Luchika Ditu, and Peter Sands will be joining us at 12:05, and then for Sherry Vincent from USID, she will be joining us later in session 2. We have also heard remarks from Dr. Benjamin from the Africa CDC, and right now we should be moving on to Dr. Andre, who is the regional focal person for TB within the WHO office. Could you hear me?
Non, on a donné qu'aujourd'hui. On a donné RSZ qu'aujourd'hui. Mais les docteurs ont fait venir.
Il faut donner seulement pour demain. Aujourd'hui et demain, non? Il a pris aujourd'hui.
Fermez vos micros quand vous ne parlez pas. Fermez vos micros, s'il vous plaît.
Tout tard demain. On n'a pas pensé ça le matin. Ils vont partir demain.
Basse, fermez vos micros quand vous n'avez pas la parole.
Thank you, Olive, giving me the floor.
I'm sorry, Dr. Andre, just give me 1 minute. I just want to know whether it's okay before you move on, because we don't want people to miss what you're going to say. Very important. I'm going back to Bertrand. Bertrand, is it okay right now?
No, it's not working. Maybe Rodrick can help us with some advice because it's not working.
Okay.
Right. I think when you choose, if you choose French, then you go on to mute original audio. When after choosing the language you want, then you mute the original audio. When you choose French, you mute original audio.
Yes, thank you. Franck, tu peux aussi donner ton feedback en anglais, comme tu parles français et anglais.
You mute original audio.
Ne marche pas toujours, hein? It's not working.
It's not Austin. At least not for me.
I'm from
I did what you said.
Je
faisais exactement ce que tu as dit. J'ai choisi French. I've choose French et puis j'ai mute original, mais le French marche pas. The French didn't work. Allez-y, madame.
Si je parle en français, est-ce que la version anglaise, la traduction en anglais n'a pas de problème? Je peux parler en français, c'est ça.
So Dr. Andre is proposing that he speaks in French, and I think let us continue. And then probably we have a break at a certain point, and then we try to see whether we can solve this situation. So Dr. Andre, can I introduce you once more? I apologize. Dr. Andre is the regional focal person for TB within the WHO World Health Organization Afro office. He will be also providing us with remarks on the position of TB within the WHO. Thank you so much. And please, if you can give us your remarks.
Merci beaucoup pour cette opportunité que vous nous donnez pour cette importante réunion. Vous avez connu Dr Nkoma Wilfried, qui est retraité. Et là, je suis en train d'assumer son intérim pour la tuberculose dans la région Afro. Et comme a dit Luchika, la communauté, la société civile était peu impliquée les années passées dans la lutte contre la tuberculose. Et là, c'est une grande joie d'avoir ce mouvement de la société civile impliquée dans la lutte contre la tuberculose. Et comme vous savez, on a des cibles ambitieuses pour mettre fin à la tuberculose d'ici 2030. Et c'est des cibles qui ont été fixées par les Nations Unies. Et vous savez aussi que l'OMS a mis en place un cadre avec des objectifs spécifiques pour réduire l'incidence et la mortalité. Et des cibles ont été fixées pour différentes périodes, 2020, 2025, 2030. Et comme vous savez, d'ici 2020, donc d'ici cette année, nous devions réduire l'incidence de 20% et de réduire le nombre de décès de 35%. Comme vous savez aussi qu'il y a eu la réunion de dirigeants, de chefs de gouvernement aux Nations Unies. Et là aussi, ils ont décidé de fixer certaines cibles et qui concourent à l'atteinte de la stratégie NTB. Et comme vous savez, la cible était d'atteindre 40 millions de personnes et les traiter d'ici 2022, 30 millions de personnes avec le traitement préventif à l'isoniazide pendant la même période, mobiliser 13 milliards par an d'ici 2022 et combler le déficit qu'on a en matière de recherche de 2 milliards de dollars. Et comme vous savez, les chefs d'État, de gouvernement ont pris des engagements pour atteindre ces cibles. Et comme vous savez, au moins ce mois, la réunion des Nations Unies, plutôt le secrétariat des Nations, le secrétaire général des Nations Unies a fait le progrès de l'évolution de ces indicateurs, de ces cibles lors de la fois passée, et l'OMS a publié cela dans son rapport de 2020. Et comme vous pouvez constater aussi que le COVID, comme disait Luchika, vient perturber l'évolution de progrès. Alors nous sommes contents, comme je disais, puisque la société civile est fortement impliquée dans la lutte contre la tuberculose. Et nous voyons que, par exemple, pour la région afro, malgré tout ce qui se passe, on fait quand même de petits progrès. Nous allons voir ça quand on va discuter des données. Alors aussi, la semaine passée, du 19 au 20, il y a eu le sommet de 30 pays à haute charge de la tuberculose du monde entier, dont 16 sont des pays africains. Et dans ce sommet, la société civile était représentée et ils ont fortement, les chefs de programme qui participaient à cette réunion ont fortement impliqué, plutôt fortement recommandé que la société civile puisse faire le plaidoyer pour la mobilisation de fonds domestiques. Ils ont aussi fortement impliqué que la société civile contribue au développement cadre multisectoriel dans le pays. Alors, les défis de lutte contre la tuberculose sont énormes, mais nous croyons qu'ensemble, avec la société civile, nous pouvons faire d'énormes progrès. Tout en nous souhaitant une fructueuse réunion, nous vous souhaitons plein succès et souhaitons aussi que cette collaboration va continuer et beaucoup de choses seront faites dans la lutte contre la tuberculose. Je vous remercie.
Thank you so much, Dr. Andre, for your remarks. It also seems like those who are English speakers could not hear your remarks, but we will request the translator if he can just say in short what you have said. And then I know that Peter Sands is supposed to be joining us shortly, and most likely he's already online. So if we can just have the translator come in, just say some few points from Dr. Andre, and then we'll move on to Peter Sands. Thank you so much. Austin, can you help me with the translation? The translator, if you can come in, please.
Hello, Mrs. Augustine. Can you speak so that we know?
Yes, we can hear you.
Yes, we can hear you.
We are requesting for the translator to provide us with the remarks from Dr. Andre. Mr. Augustus, maybe you are on mute. Okay. Because
yes.
Yes, is that? Yes, please. If you can just give us.
Yeah, you are loud and clear. On.
Ça là, c'est une rupture totale. Hein?
We can hear you.
On n'a pas été livré. Moi, je cours dans la ville depuis 3, 4, 5 jours. Ah, ça là, il faut les référer.
Hello, we can hear you. Speak on.
Okay, maybe because of time, let us move on. I know that we are going to miss out, but I would like to request someone, Peter Sands is going to... Sorry, Mr. BASSE, can you mute yourself? Can the host mute Dr. BASSE?
Yeah. The host can mute Mr. Dr. BASSE, please.
Il y a un centre de diagnostic de traitement à cours du village. Il n'a qu'à partir là-bas. Il faut faire le papier vite, voir la sécurité de la cour du village. C'est que moi, hier, on m'a appelé, j'ai dit, ça là, c'est trop compliqué. J'ai dit seulement de m'appeler, mais il n'y a pas un médicament d'aide.
S'il vous plaît, il y a quelqu'un qui parle. Est-ce que vous pouvez... Quelqu'un parle là, pouvez mettre votre...
On va le suivre là-bas, on va le suivre de l'autre côté.
BASSE, est-ce que vous pouvez éteindre votre micro, s'il vous plaît?
Okay, so we are now going to be joined by Peter Sands, who is the Executive Director of the Global Fund. He will speak in English, and I am requesting the translator that he keeps note of what of these remarks of the address. And immediately after Peter Sands finishes giving us his remarks, if we can hear from the translator in French. So over to you, Peter Sands from the Global Fund.
Very much, Olive. Keep my comments short so that it is easy for the translator. First of all, I want to congratulate you on holding this meeting. I think it is a very timely meeting given the urgency of mobilizing civil societies and communities across the Global Fund footprint to step up the fight against TB. The reality is that although we have made good progress on tuberculosis, and particularly actually have made good progress in the African region, we are not on track, and we were not on track even before COVID struck. We need to find ways of accelerating progress, both in identifying cases of people with TB and ensuring they get treatment, and in improving the treatment of people with multi-drug resistant TB, and in getting greater coverage of preventative treatment. The COVID has accentuated the challenges we faced. We were off track before, and now we are undoubtedly further off track. The impact of COVID has varied from country to country, but in almost all countries, we have seen reductions in the pace of TB case identification and enrollment onto treatment. And in some cases, we have seen significant disruption to treatment programs for people already on treatment. So now is a time for the entire community engaged in fighting TB to step up the fight together, to work together to see how we can first get back on track, and second, mitigate the negative impact of COVID on the fight. The Global Fund has invested about $7.2 billion in programs to prevent and treat TB as of June 2020. And we will be increasing the amount we spend every year by over 20% for the next grant cycle. The Global Fund represents over 70% of total international funding for TB, which represents about $1 billion a year. So the Global Fund is funding about 700 million or so of that. And of that total, roughly 12% of our current funding goes to local NGOs, civil society organizations, and communities. If you include, so that represents about $200 million over the 3-year period. And if you include TB HIV, that figure doubles to about 400 million. We are very keen as we enter the next grant cycle to ensure the effective engagement of civil society organizations and communities in every aspect of the fight against TB, including outreach to the most vulnerable populations and community-led monitoring and community health workers. I know we have selected a consortium to provide long-term capacity strengthening of community networks and organizations of people.
I wanted to know.
And we are also very good on the role of community and civil society organizations in addressing barriers to accessing health services, including human rights and gender-related barriers. So, as I say, I think this is a very important and face significant challenges in the fight against TB, and you, as leaders of civil society organizations, represent
from this side. I can see you are online.
Response to this challenge.
From this side, it says you have not joined.
And wish you very good and productive discussions. Thank you.
Thank you so much, Peter, and thanks for all the remarks, and especially around the support you and the Global Fund is providing to communities and civil society. We appreciate, especially during the COVID period, I think what the Global Fund has done is very remarkable. So we appreciate all that and putting civil society and communities in the forefront. At this juncture, I would like to request the translator to just give us the Peterson's remarks in French so that everyone is on the same point. So Mrs. Augustine, if you can come in, please.
And Olive, before she does, just my apologies, but I'm going to have to leave to another meeting. As I say, I wish you all a very productive discussion today. Thank you.
Thank you very much, Peter, and we wish you all the best. Thank you very much. So can I request Mrs. Augustine, the translator, to help us?
It works. Yes, it works. D'accord, allez-y.
So Luchika, thanks for saying that. So which means that whatever Peter said, the participants were able to hear him. Or we still need to translate it.
Sorry, this is Gilles Cesari again from the Global Fund. Since I helped Peter putting his talking points together, if you want, I can do a quick summary in French.
Thank you so much, Gilles.
Donc, je vais parler en français. Peter a félicité les organisateurs et tous les partenaires pour l'organisation de cette réunion sur les prochains jours et a dit que c'était vraiment le très bon moment pour organiser cette réunion puisque nous sommes en pleine crise sanitaire mondiale et le rôle des communautés n'est plus à démontrer pour nous sortir de cette crise. Je parle bien sûr de la Covid-19. Mais aussi parce que, comme vous le savez, le Fonds mondial va commencer avec tous ses partenaires à élaborer la prochaine stratégie et l'implication de la société civile et de communautés est aussi très important dans ce domaine-là pour les prochaines années. Il a mentionné que, bon, malheureusement, on a fait beaucoup de progrès au niveau de la lutte contre la tuberculose, on le sait tous, et en particulier sur le continent africain, mais que même avant, en réalité, la crise avec la Covid-19, on n'est encore pas dans les clous pour atteindre nos cibles d'ici 2030. Donc, on a encore beaucoup à faire et le Fonds mondial est convaincu qu'on ne pourra pas atteindre ces cibles si l'on ne renforce pas les systèmes communautaires, les systèmes de santé au niveau de la société civile et communautaire. Peter a mentionné aussi que depuis le début donc de la création du Fonds mondial, environ 7 milliards de dollars ont été dépensés dans la lutte contre la tuberculose et que le Fonds mondial représente le plus gros financeur extérieur en termes de tuberculose jusqu'à présent. Et que sur ces financements-là, pour la tuberculose, environ 12% des subventions tuberculose allaient donc vers des acteurs de la société civile locaux. On ne parle pas ici des organisations internationales, des ONG internationales, mais vraiment des associations et organisations nationales et donc de société civile ou communautaire, ce qui représente environ 200 millions de dollars sur l'allocation en cours qui se termine là à la fin de l'année dans la plupart des pays. Et si l'on rajoute le financement qui vient des subventions TB-VIH, qui vont aussi donc également à la société civile nationale locale, on rajoute encore 200 millions de dollars sur le cycle en cours. Donc, ça fait 400 millions en tout. Ça paraît beaucoup, mais on est conscient qu'on doit encore aussi, de notre côté, avec le soutien des partenaires, augmenter ce montant-là qui va à la société civile locale. Et il a également mentionné que donc il fallait travailler sur des, alors je ne sais pas comment on dit en français, les catch-up plans, les plans de rattrapage. Donc il fallait mettre l'accent sur des plans de rattrapage. En ce moment, donc, il y a des guidances qui ont été publiées sur le site du Fonds mondial et avec l'ensemble des partenaires, l'OMS, Top TV Partnership et d'autres. Le Fonds mondial travaille avec les programmes nationaux et la société civile dans certains pays pour vraiment mettre en œuvre des plans de rattrapage suite au retard qu'on a connu avec la Covid-19. Et pour finir, dans ces plans de rattrapage, on a justement des activités clés qui sont proposées et qui doivent être mises en œuvre par la société civile et les communautés, comme par exemple tout ce qui est monitorage par les communautés, au niveau communautaire, par exemple. Et tout ça est mentionné donc, dans ces plans que le Fonds mondial souhaite mettre en avant. Voilà, je pense que j'ai résumé à peu près. J'espère que ça a été. Et donc, il a terminé, évidemment, en vous souhaitant à tous un très bon atelier et de bonnes discussions. Et que nous allons prendre note de tout ce qui est dit qui sera aussi donc qui devra faire partie de la nouvelle stratégie du Fonds mondial. Merci.
Oliver, are you there? I think Giz has finished.
Oh, okay. Thank you so much. I think I had lost network. Thanks for that, Austin. So thanks, Gilles, for coming and translating for us what Peter Sands had said. So we have now finished our first session, which was around welcome note, keynote address, and remarks. We will still hear from Sherry later in session 2. But right now, we can now move on to the session 1. And session 1 is where we are going to ask ourselves key questions on where are we? What have we been able to achieve? What has been, where are we coming from and what have we been able to achieve? We'll be looking at the TB epidemic in sub-Saharan Africa amongst COVID-19, and we will also look at what responses have been there. We are going to hear from 5 key people, from WHO, from the CDC, from Africa Union, from Global Fund, and Stop TB Partnership. And I will open up again to invite Dr. Andre, who is from WHO Afro TB unit, and is going to give us information around the epidemiological data on TB in Africa and the TB status in Africa. Before I move on to Dr. Andre, I would like to request that we all mute. I am, is it Pastor Paul? If you can mute yourself, please. Pastor Paul, if you can mute yourself, thank you very much. And there's someone else called Family Tatao. That's the interpreter. Okay, that's the interpreter. That's okay. So let us now hear from Dr. Andre around TB in Africa. Thank you.
Thank you, Madam Chair. Let me share my screen.
Thank you. Dr. Andre, are you able to share the screen? Share your screen?
Let me try again. I have some technical issue. Let me try again.
Yeah, we can see it now. We can see you're connecting. Yeah.
Okay. If you allow me, I can speak in French. So, if no problem.
Yes, please proceed in French.
OK. Pour présenter la situation épidémiologique de la tuberculose pour l'Afrique, l'impact du Covid aussi, quelques tendances clés. Et comme vous le savez, la tuberculose est parmi les maladies qui tuent en Afrique et dans le monde. Et quand vous regardez les données du monde entier, c'est 1 million de morts, de personnes qui sont décédées de la tuberculose. Et à droite, vous avez la situation pour la région africaine. Donc, demi-million qui sont décédés de la tuberculose. Alors, quand nous faisons un petit calcul, nous voyons que 4 personnes sur 10 dans le monde sont mortes de la tuberculose en Afrique. Donc, c'est pour dire que le fardeau, il est important en Afrique et beaucoup de gens meurent puisqu'ils viennent en retard. Et nous pensons que la société civile a un rôle à jouer pour cela. En ce qui concerne les malades, en 2019, 10 millions de personnes, de malades ont été estimés dans le monde entier. Et 7 millions ont été reportés et presque 3 millions n'ont pas été diagnostiqués. Et en Afrique, nous avons 2,5 millions de personnes malades estimées. 1,4 million ont été reportés. Et comme vous pouvez le voir là, 1,1 million n'ont pas été diagnostiqués. Donc, plus de 40% de personnes manquant. C'est dire aussi que là, ce sont des personnes qui n'ont pas accès aux services de santé ou, pour une raison ou une autre, ne vont pas aux services de santé. Donc, 40% de personnes manquant. Donc, c'est un gros défi pour la lutte contre la tuberculose, puisque ces personnes vont continuer à transmettre la maladie. Pour la résistance, ici je vais signaler que le collègue de GLC n'a pas été informé à temps. Je vais donner quelques éléments à travers cette dia. Dans le monde, nous voyons que c'est demi-million de personnes, mais nous avons mis sous traitement 38%. En Afrique, c'est pareil. Nous avons pu diagnostiquer environ 30 000, 29 000 et 38% seulement ont été mis sous traitement. Et ils ont été mis sous traitement, mais 64% seulement ont été traités avec succès. Là, nous faisons mieux que la moyenne mondiale, donc il y a un peu d'effort. Nous sommes à 64%, nous devons atteindre 90%. Et nous pensons que si tous les pays utilisent le traitement entièrement oral et remplacer les injections, ça va augmenter l'accès au traitement, ça va augmenter l'adhérence au traitement. Et nous pensons qu'on va sauver beaucoup de vies. Aussi, quand nous considérons la co-infection.
Hello, Dr. Andre, can you open their presentation?
Yes, Austin.
We're only seeing your laptop screen. You are shared the screen, but the presentation is not open.
Okay, let me. What do you suggest?
You need to click on the presentation and open it. We can see your screen.
But the slides are not moving.
The slides are not moving. We are not seeing the slides.
Alors, on a un problème. Le seul problème, c'est que lors de sa présentation, on n'arrive pas à voir les schémas donc, pour pouvoir poursuivre et visualiser les chiffres qu'il est en train de donner.
Pourtant, chez moi, ça défile. Je vais essayer. Let me try again.
OK, il va essayer encore.
Is it okay? Do you see my screen?
Perfect.
OK. Là, maintenant, c'est visible. It's okay. People can see.
C'est bon? Do you see the next slide?
Okay.
TB is the top infectious killer in the world. Do you see the screen, the slide?
Yes, we do, Dr. Andre.
No?
Thank you so much. We do now.
Est parmi les premiers tueurs infectieux dans le monde. Donc, comme vous voyez à l'image,
Je disais tout à l'heure que
personnes meurent de la tuberculose en Afrique, y compris les 169 000 personnes qui sont infectées par le VIH-Sida. Donc, en résumé, environ 4 personnes sur 10 meurent en Afrique de tuberculose. Or, nous pensons que si nous arrivons à toucher ces personnes,
Dr. Andre, we can see the screen, but we can't hear you.
Nous pouvons sauver des vies.
Okay, so I said that in Africa we have almost 500,000 people dying from TB, and 4 people out of 10 are in Africa region and are missing or are dying. So we need to do many efforts to reach people and prevent death. About diagnosis and treatment,
Alors,
I said
pour ce
that
qui est du
almost
diagnostic et du traitement,
10 million of people are dying, were estimated to be with TB.
environ 10 personnes, 10 millions de personnes meurent à cause de la tuberculose. Dans ces 10 millions,
Not dying, they are suffering from TB. Suffering from
okay,
TB.
10 millions de personnes souffrent de la tuberculose. Voilà.
And during the last year, 7 million people were reported to healthcare treated.
Tout au long de l'année dernière, environ 7 millions de personnes ont été reportées comme ayant accès au traitement et aux soins.
On the right side, you see in Africa, we
À droite, nous voyons qu'en Afrique, environ 2,5 millions de personnes contractent la tuberculose.
Only 1.4 million were reported to access TB care.
De ces 2,5 millions de personnes infectées, juste 1,4 million de personnes ont pu avoir accès au traitement de la tuberculose.
And you can see that 1.1 million were missing. People were missing.
Et dans ces statistiques, il y a 1,1 million de personnes qui n'ont pas été diagnostiquées.
Thank you, Dr. Andre, if you can
reportés.
try to quicken up your presentation because of time. So if you can just try to just...
plus de 40% de personnes n'arrivent pas à avoir accès aux soins de santé de qualité de la tuberculose.
Okay, for drug resistance, 500,000 of people are suffering from this kind of TB, but only 38% were tested and treated.
Alors, pour ceux qui sont résistants, alors on peut dire qu'environ 1 demi-million de personnes ont contracté la tuberculose qui est résistante. Et dans ces demi-million de personnes, juste 38% ont accès au traitement.
In Afro region, we have almost 30,000 people with drug resistance, and only 38% were treated.
C'est ça. Donc 30%.
When you compare
quand nous faisons une comparaison,
the outcome of the treatment at the global level,
ou les résultats du traitement à un niveau global.
But we did better in Africa. So we had 64% of people were treated successfully.
Alors, nous remarquons qu'environ 64% des malades ont été traités avec succès.
Fully oral treatment regimen to
avec un traitement oral complet. Donc, en ce moment-là, nous tirons comme conclusion que l'Organisation mondiale de la santé recommande le traitement oral pour ce qui est de la tuberculose. Donc, environ 50% des personnes vivant avec le VIH/SIDA et à la tuberculose, ils n'arrivent pas à avoir accès aux soins.
As you know, Africa region is the most part of the world affected by HIV.
Nous savons tous que l'Afrique est la plus grande région affectée par la tuberculose et le HIV.
But only 53% of them were diagnosed.
Seulement 53% de ces personnes suspectées ont été diagnostiquées avec le VIH et la tuberculose. Alors, le dernier tableau nous rappelle que un enfant sur 2 avec la tuberculose n'arrive pas à avoir un traitement de qualité, courant le risque d'être plus malade.
Dr. Andre, can I request that you continue translating and you continue the presentation and the translator will be catching up on you. So you don't need to wait for the translator so that we can move faster. Thank you.
Okay. Yes, I put this slide to remind you the milestone we have on NTB strategy. As you can see, in 2020, reduction of incidence, the number of deaths is reduced 35% compared to
réduction dans le nombre des morts de la tuberculose de 35%. En 2025, nous souhaitons atteindre 115%. Pour ce qui est de l'incidence du taux de la tuberculose par rapport à 2015, en 2020, nous sommes à 20%.
The target is 0.
Les familles affectées doivent être à 0%. Alors ici, nous avons une vue globale du d'atteindre les objectifs globaux. Alors,
the target is 20%, but we reach 9%.
Le but était de réduire de 20% entre 2015 et 2020, mais en réalité, nous avons atteint 9% seulement. Pour ce qui est des morts, l'objectif était de réduire de 35%. Mais nous avons effectivement atteint le but de 14%. Alors, pour ce qui est du coût catastrophique, l'objectif était de 0, mais malheureusement, jusqu'aujourd'hui, 49% de personnes auront à faire face encore à cette
Let's see the trend of incidence in Afro region. When we compare
tendance dans les pays africains pour ce qui est de l'incidence de la tuberculose.
We see in green, incidence is
Alors, en Afrique,
reducing progressively, but when you see the curve in black is the notification, our effort to diagnose.
OK. La courbe en noir représente nos efforts. Le but, c'est la courbe en vert.
But there is a gap between notification and incidence. So the gap is
Nous
due
voyons bien qu'il y a un gouffre entre les notifications et l'incidence.
Let's see the situation in some country in the region.
Alors, la situation dans certains pays de la région.
The first line,
dans la première ligne,
South Africa part,
en Afrique du Sud,
country South Africa part, Zambia, Zimbabwe, South Africa, Lesotho, Namibia, Tanzania, Lesotho. You see that the trend is decreasing, good trend, and many of them are reaching the target.
Nous voyons que la tendance est décroissante et la plupart d'entre ces pays-là sont en voie d'atteinte de leurs objectifs.
When you see Ethiopia and Kenya, eastern part of Africa, they are also performing very well. But when you see West African countries, Central African countries, central part, there are no progress.
Alors, lorsque nous regardons les pays de la région ouest africaine, nous constatons qu'il n'y a pas de progrès. Hein? On dirait même qu'il y a une régression. Alors,
as we have in this meeting, people of east part and south part of Africa, I think we need to
ceux de l'Afrique du Sud et ceux de l'Afrique de l'Est,
and see what are they doing in this part.
Nous aiderons à voir ce que eux ils font et nous pourrons en tirer des leçons.
So, West and Central Africa have many efforts to do to reduce incidence.
Donc, l'Afrique de l'Ouest et l'Afrique centrale ont encore beaucoup d'efforts à faire.
I have put some reason which.
Alors, ici, c'est quelques raisons que j'ai pu relever pour expliquer les résultats que nous voyons.
Incidence is not reducing. There are missing cases. The stigma is important.
Des cas que nous n'arrivons pas à avoir connaissance. Et en plus, la stigmatisation est encore très présente dans les communautés. Ensuite, les défis et l'accessibilité aux services de la lutte contre la tuberculose. Comme recommandation, je suggère qu'on puisse intensifier la détection de la tuberculose et ensuite d'identifier les cas.
Dr. Amber, can I give you 2 more minutes? 2 more minutes for you to finalize your slides, please? 2 more minutes.
Yes, yes. So for mortality, almost the same trend in
les tendances pour ce qui est de la mortalité, le taux de mortalité dans les 30 pays les plus élevés pour ce qui est de la tuberculose. Alors, nous avons le Congo,
Eastern country and Southern country, the trend is decreasing.
Okay. Dont la tendance est décroissante.
Impact of COVID, as you know, COVID has a negative impact on essential TV services, including the location of human, financial, and other resources.
Il faut allouer de nouveau des ressources humaines, financières
et autres
que la tuberculose vers le COVID afin de faciliter la réponse par rapport à ces deux pandémies.
The notification, we try to follow notification for some countries.
Alors, on a essayé
from
de
January to June.
C'est-à-dire de suivre de bout en bout
many of them
7 pays
had a reduction of number of TB cases.
Alors, on a vu la réduction des nombres de cas de tuberculose. Alors, pour ce qui est d'atteindre les objectifs, alors, quels sont les progrès?
Regarding TB treatment, the target was to treat 4 million people, but we reached 14 million.
Soigner 40 millions, mais nous avons juste pu atteindre 14 millions.
30 million on preventive treatment.
Venir avec des traitements préventifs, nous voulions toucher 30 millions de personnes, mais nous avons pu toucher effectivement 6,3 millions de personnes uniquement.
Regarding access to TB prevention, diagnosis, treatment and care, the target
Pour ce qui est de la
was
prévention de la tuberculose, du diagnostic, du traitement et des soins, l'objectif, c'était d'allouer 13 milliards
and about the research,
à l'horizon 2022.
the target was to have 2 billion annually.
Le but pour ce qui est de la recherche était d'avoir à disposition 2 milliards de 2018 à 2020.
We reached 900 million.
Dans les recommandations prioritaires du secrétaire général de l'UN des Nations Unies pour ce qui est du rapport 2020 pour la tuberculose,
I will share the presentation when we read the recommendation.
À faire
But we need to have money
dans la poursuite de nos
to address
objectifs globaux. Alors, il fallait déjà.
So money, we have few money to combat TB. That's all. Thank you, Madam
Alors,
Chair.
merci pour le dernier. Donc, il fallait.
Thank you very much, Dr. Andre, and my apologies for pushing you to move faster, but we really appreciate your presentation, and thanks for sharing the slides, which will be shared with the other with all the participants on
les gens
this
avec la
discussion.
tuberculose aient accès
Thank you for
à des soins de
providing us
santé
with
de
a snapshot
qualité,
of where the position is in terms of TB in sub-Saharan Africa.
Alors, il fallait regarder.
Right now, I would want first of all to acknowledge that Dr. Benjamin is personally connected to the call. So just to say thank you so much, Dr. Benjamin. We did listen to your presentation, the video that you took. So, but just to say thank you for just taking time to be on the call as well. We are now moving on to the next speaker, who is Dr. Sheila Tamara Shawa, who is the TB focal person within the Africa Union CDC. I will request for you, Dr. Sheila, if you can keep your intervention for around 7 to 8 hours. So minutes, sorry, not hours, minutes. Thank you very much. Over to you, Dr. Sheila.
Dr. Sheila pour 7 ou 10 minutes.
It looks like Dr. Sheila, I think, is having some problems with her internet because she was on, but I see that she's no longer online. So probably we can now move on to the next speaker. We were supposed to have Dr. Norbert Njeka from the WHO Drug Resistant Commission, and unfortunately is not able to join us today, but probably we'll give him time to speak to us probably tomorrow. Let me move on to Dr. Eliud Wandwalo, who is the head of the TB Technical and Partnership Department within the Global Fund in Geneva. Please, Dr. Eliud Wandwalo, he will be giving us more information on what the Global Fund has been doing in terms of responding to TB amongst other diseases. Over to you, Dr. Eliud.
Thank you, Olivia. Thank you, the organizers. Can you hear me? Can you hear me, please? Yeah.
Dr. Eliud, we can't hear you. If you can unmute yourself.
have a meet. Can you hear me now?
Yes, yes, we can hear you.
Okay, great. Thank you. So thank you, Olivia, and thank you, the organizers.
Dr. Eliud, we still cannot hear you. Probably, I don't know what it is. On our side, we can't hear you.
Alors, il y en a qui n'arrivent pas à l'écouter.
Yeah, can you hear me?
Yeah.
Oh, you can hear Dr. Eliud. Okay.
Yes,
let's proceed.
Yes, we can hear him.
Okay.
Thank you. So thank you, the organizers, for inviting me. Thank you, Austin and Olivia, for that introduction. As I was introduced, my name is Eliud Wandwalo. I'm the head of tuberculosis at the Global Fund.
I think there is a technical problem. It is not only me who can't hear you, Dr. Eliud.
It's not a technical problem. I think it's from, we need everybody who is listening to English, please choose English and mute original language. It's not.
But we can hear it.
Yes. Yeah. If you want English, choose English. Please, from the translation, from the interpretation, you choose English. If you are listening to French, choose French in the mute original language. Thank you.
Thank you so much, Austin. Sorry, Dr. Eliud.
Okay. Thank you very much. So I just want to highlight a few issues from the Global Fund when it comes to tuberculosis. First of all, I would like to thank everyone for supporting Global Fund, especially supporting countries on submitting their funding request. As you know, we have now received 3 waves of the funding request. And we have reviewed almost 3/4 of all TB requests. I think it was difficult to do that in the current context of COVID, but I think I'm happy to say that even the quality of the funding request we have seen, especially for tuberculosis, has been very good. And this is really due to the effort of all of you and the countries and other partners who are supporting countries on that. Global Fund is proud also to be supporting challenge facility funding together with USAID through Stop TB partnership. We have supported this challenge facility for civil society through strategic initiative from 2018 to 2020. And we are committing to continue to support this funding in the next funding cycle. We are currently in the process of developing the strategic initiative for the next funding cycle, and we are committed to continue to support this pot of funding, which we think is very important. And we'll continue to work with our partners, SOCTB, USAID, but also to work with countries to ensure that this important work is continued for the next 3 years. Now, when it comes to TB, as you know, in the current allocation, in the next allocation, we have increased our funding to tuberculosis by more than 20%. This is a very good opportunity for TB to be able to use that funding to be able to scale up interventions to reach the UNHLM target and NTB target. We know this will be difficult with the current COVID situation, but we would like to ask countries together with you who are in this meeting to continue to support countries on that. Not to reduce the targets, because it's very easy to go back and look at the targets. We think countries should continue to have ambitious targets, which they've put the funding request. We have seen a lot of countries came with a very ambitious target, and we will argue and urge the countries to continue to have the ambitious target and work with all partners, with every stakeholders, to ensure that countries will meet those targets even in the current difficult COVID environment. In the current funding cycle, we have been working to support a number of countries on finding the missing TB people. We have worked specifically focusing on a few countries. In the current cycle, it was 13 countries. These are the countries with about 75% of all missing cases.
Pour ce qui est des cas manquants, c'est-à-dire des personnes infectées manquantes qui ne sont pas répertoriées pour ce qui est de la tuberculose.
Yeah. So we work with 13 countries, but of course we work with every country to be able to ensure that they are getting people who are missing from treatment. But the 13 countries were the priority countries where we provided additional funding and additional focus on those countries. Out of those 13 countries, 6 of these countries are coming from Africa. In the next funding cycle, we hope to expand these countries to 20 countries.
Dans cette optique-là, 6 viennent de l'Afrique, c'est-à-dire pour ce qui est de vraiment tout mettre en œuvre pour trouver les personnes manquantes. C'est un objectif qui nous tient à cœur. Donc, nous accompagnons un certain nombre de pays, mais dans ce nombre de pays-là, il y a 6 qui ressortent de l'Afrique.
Yeah, so we hope to expand these countries to 20 countries, and 9 of these countries will be from Africa. And we hope we'll be working very closely with you to ensure that we find all people who are missing from treatment. And most of these people, they are people who are in very vulnerable situation. They are people who are hard to reach, and where we think civil society will be best placed to find them.
Ainsi travailler avec 9 pays africains. Parce que nous tenons à rappeler que ces personnes qui manquent sont des personnes dans des situations très, très vulnérables. Donc, d'où l'urgence d'accentuer nos efforts afin de pouvoir les déceler et ainsi les accompagner dans leur accès aux soins.
Yeah. So next, on the COVID, we have seen the devastating impact of COVID on tuberculosis, and
nous avons vu l'impact dévastateur de la COVID sur la tuberculose.
Yeah, and the WHO report, which was released a few days ago, has clearly shown that countries have really been impacted by COVID. And the TB notification, for example,
mise à disposition il y a quelques jours montre vraiment à quel point les pays ont été sérieusement touchés, impactés par la COVID.
Yeah, the TB notification have really been impacted in many countries. We see this more severe, for example, in Asian countries, but also we know even in African countries, the impact has been much. Probably we don't see it now, probably in the TB notification, but we think long-term, medium-term, many TB programs will be affected.
La communauté TB a été très sérieusement affectée par la COVID, par l'impact de la COVID. Cela, nous l'avons constaté pour ce qui est des pays de l'Asie et même des pays de l'Afrique. Peut-être cela ne se remarque pas encore, mais nous pensons que dans les prochains mois, dans les prochains jours, cet impact sera de plus en plus visible.
And so I think what we have done as a Global Fund, and I'm sure our executive director has just has underlined, we have supported countries through grant flexibility through COVID-19 response mechanism, but also we are really committed to work with countries to mitigate the impact of COVID on tuberculosis. We have been working with partners to develop a guidance and information note on the catch-up plans for tuberculosis. And we hope by next week, this information note will be out in our website, which really explain how countries will be able to catch up on the loss they've suffered this year and be able to be on track for UNHLM and NTB targets. So we hope.
Travailler avec beaucoup de pays, comme je disais, mais nous comptons aussi sur l'apport de nos partenaires des différents pays afin de mettre sur pied une espèce de note qui aidera à guider ces différents pays pour ce qui est de l'élaboration des politiques aidant à rattraper le retard constaté ou bien l'impact qui a été constaté. Donc, nous pensons que dans les prochaines 2 semaines, ce travail qu'on va élaborer sera à disposition afin de pouvoir mettre sur pied, comme je le disais tantôt, des politiques ou des plans permettant de rattraper ou d'améliorer ou de réduire l'impact qui a été noté par la COVID dans la réponse pour ce qui est de la tuberculose.
Yeah. So going forward, we hope we'll be working with countries to ensure that they have a catch-up plan as part of grant implementation, but also we think also this can be supported as part of a COVID response mechanism, and we look forward to work with all of you to ensure that countries don't only reach their targets, but they are able to do modification to be able to scale up TB programs in the context of COVID. Thank you very much.
Alors, nous pensons que grâce à cette note-là et à ces financements qui seront mis à disposition, les différents pays pourront non seulement avoir des services ou des politiques pour parer à ça, mais surtout pour améliorer et pourquoi pas faire davantage pour ce qui est de leur réponse par rapport à la tuberculose et à la COVID. Nous l'espérons sincèrement et nous voulons travailler dans ce sens-là.
Thank you so much, Dr. Wandwalo, for giving us more information about the countries and I think the plans of what the Global Fund is thinking
aux différents pays et surtout ce que le Global Fund pense faire.
Especially from 13 countries to 20 countries. And
Africa, 13 à 20 pays avec 9 pays africains, c'est intéressant.
I think as civil society and communities, it is our role to make sure that we play a big role in ensuring that we are not missing anyone with TB.
Alors, je pense qu'en tant que membre de la communauté civile et des services communautaires, il est de notre devoir de nous assurer que de telles opportunités ne seront pas manquées, mais qu'elles seront utilisées à bon escient et complètement.
And thank you so much for letting us know about the COVID catch-up response plan as well.
Merci de nous avoir fait état de la politique de catch-up pour ce qui est de la COVID, c'est-à-dire de rattraper les manquements que cela apporte dans ce qui est de la politique des États et des agents communautaires pour ce qui est de lutter de la tuberculose et de la COVID.
Our session was supposed to end right now, but now we're moving on to our last and one of the most important speakers, and that is Dr. Sahu Subenant from the Stop TB Partnership.
Nous allons écouter Dr. Asao, qui est notre dernier intervenant pour ce matin et que nous attendons avec impatience.
He is the Deputy Executive Director of Stop TB Partnership.
Alors, il est le DO de Stop TB Partnership, directeur exécutif.
And we'll be talking about the progress in implementing the global plan to end TB, and will also provide us with highlights on the UN HLM targets and progress on finding missing people with TB.
Alors, il s'adressera à nous pour ce qui est des progrès qui sont faits pour trouver des personnes manquantes, comme cela nous tient à cœur, mais aussi du plan global et d'autres aspects encore.
Over to you, Dr. Sahu.
Thank you, Olive. Thank you, Austin,
Alors, Dr. Sahu,
for inviting me to speak to you in this important meeting. So in the next few minutes, I will run you through where we are currently in the TB response globally, and a little bit about Africa, talk about what we need to do. I hope you can see my slide changing.
Alors, prêtons attention.
Yes, we can see.
So we are all familiar with the UN HLM TB targets, and here are the targets for treatment.
HLM global.
You can see in the blue graph, blue part of the treatment in 2018 and 19, and what needs to be achieved 2020 to 2022.
Et de l'autre côté, donc, en ce moment, ce qui sera fait de 2020 en 2022.
And as you can see, progress has been there, but limited. We have to do quite a lot of work in the remaining 3 years.
Il y a encore beaucoup à faire pour les années prochaines suivantes.
And you can see some of these targets are even less than some others. So
nous verrons que certains objectifs sont moindres que d'autres.
I will also go into a bit more detail on the TB preventive therapy target, which you see as the lowest bar there.
Alors, nous allons prêter une attention particulière au traitement de la tuberculose, c'est-à-dire comme objectif, parce que c'est l'indice le plus bas.
And you can see the TB preventive therapy, the world, this is all global data.
Donc, nous rappelons que ce sont des données mondiales et lorsque nous regardons la prévention, traitement préventif de la tuberculose.
But not doing well for contacts, both under 5 young children contacts of TB patients, also other age group who are contacts of TB patients. We are way behind and not likely to reach the target.
Alors, nous sommes loin en arrière lorsque nous regardons que ce n'est que 5,3%, donc on n'est pas prêt d'atteindre nos objectifs.
So let us think about at a stage where the world is focused on contacts for COVID. How can we leave behind contacts of people with TB?
Alors, aujourd'hui, le monde est concentré pour ce qui est de la COVID.
Now, that was the 5-year target and progress in 2 years, 2018, 2019. But if you look at 2019, where we should have been, this is the situation.
Voici la situation.
Targets from the Stop TB website for each year. You can see some of the targets are above 80%, but the children on MDR TB are below.
Et d'autres moins.
Coming to the Africa region, how we are doing, and this is how the WHO Africa region is achieving the targets. You can
see le travail de l'Organisation mondiale de la santé en Afrique pour ce qui est de réaliser leurs objectifs. Donc, nous rappelons toujours que c'est sur une période de 5 ans. Ce qui est en bleu, c'est ce qui a été fait de 2018 à 2019. Et de l'autre côté, c'est ce qui doit être fait.
Now, as you saw, there has been progress, but not 100%. 80%.
Il y a eu des progrès.
But let us look at what the world committed to mobilize for TB care.
Regardons ce que le monde s'est engagé à mobiliser.
And the achievement is only 6.5 billion, as reported by WHO in the last global TB report last week.
Alors, de 13 millions, il n'y a eu que 6,5 millions qui ont été réellement réalisés.
For TB research and development, it is even less than half of what is needed.
Sur la tuberculose, c'est encore pire.
So with half of the funding, how can we 100% of the UNHLM targets?
Comment réussir à atteindre les objectifs?
Now, coming to what was happening pre-COVID, as Eliud mentioned, in the strategic initiative, there were 13 countries, and this is data from 13 countries. We have
les données de 15 pays avant
the number of people missing from TB care. You can see the green line there from
la ligne verte.
Years, but more sharp decline in the last few years.
C'est-à-dire par rapport à ceux qui manquent pour ce qui est de l'accès au traitement ou de la notification.
On the Stop TB website, there is a link I have put there. You can also see a very interactive graphic which shows
la tendance
people by TB,
par la
the trend in 30 TB high burden countries.
Nombre de pays affectés par la tuberculose.
More or less, you see in most countries, the people missing from care over time were reducing. There are some exceptions. Have that
gros, les personnes manquantes du traitement sont en train de réduire. En gros, parce que dans certains cas, ce n'est pas le cas.
So that was up to 2019. 2020,
Ça, c'était jusqu'en 2019.
You can see here, we always get figures at the global level, but when you look at countries in Africa and look at
quand on regarde les pays africains, c'est vrai qu'on donne des résultats sur le plan global, mais quand on regarde au niveau de l'Afrique,
on the left-hand side, the picture shows how TB deaths completely outnumber the deaths due to COVID. COVID is important.
Alors c'est clair.
Cannot be
Là,
forgotten.
nous voyons comment
In the African
les cas
continent.
ou les décès de COVID ont complètement dépassé les morts de la tuberculose.
On the right-hand side, you see the numbers, not the numbers of the two diseases. Still TB, a big morbidity and mortality for people in Africa.
Alors, montrant le taux élevé de la morbidité et de la mortalité en Afrique.
Now, this is what happened with the impact of
ce tableau
pandemic on TB, especially on notification.
La pandémie du COVID-19 sur la TB et comment cela affecte en ce que cela augmente le nombre de personnes qui manquent, le nombre de personnes manquantes.
On the left-hand side, you see from the WHO report
à gauche,
where notification was going up but declined rapidly. And on the right-hand side, I have specifically put two countries because they have live data on their website. India up to yesterday and today it is almost live, and Philippines up to the last month. And you can see that case notification in 2020, which is in red compared to 2019, where it is and how it is still declining.
OK. Donc, avec ces deux tableaux, à gauche, nous voyons bien. La ligne en rouge, c'est ce qui se passe en 2020, tandis que la bleue, c'est en 2019. Donc là, nous voyons à quel point il y a eu chute ou c'est-à-dire la ligne a décru. Les gens se font de moins en moins tester, c'est-à-dire les personnes manquantes augmentent de plus en plus.
We also did a modeling exercise which shows that if this continues unmitigated, the global TB response will go back 5 to 8 years. That's a huge setback.
Alors, ceci nous montre que si cette réponse, si cela reste mitigé comme ça, alors la réponse qui est faite par rapport à la tuberculose va reculer d'environ 20 ans.
This was also confirmed by the survey that was done by civil society in many ways.
À la société civile.
And here is a summary of that, but I would encourage you, and I hope that many of you are already aware, and many of you actually were part of this survey. So huge effect of COVID pandemic on the TB response in countries.
Alors, nous constatons une fois de plus à quel point la COVID a un impact énorme pour ce qui est de la tuberculose.
In conclusion, three things which Peter also said in a similar way. Number one, there was considerable progress towards the UNHLM targets before.
D'abord, avant la COVID, il y avait des progrès considérables pour ce qui est d'atteindre nos objectifs.
Although, even before the COVID pandemic, we were not on track, but the direction of...
C'est vrai que déjà avant la COVID, on n'était pas dans le temps, on n'était pas dans les normes.
The COVID-19 pandemic has devastating impact on TB responses and has reversed the progress.
Dévastateur sur cette réponse-là. Et c'est allé jusqu'au point de renverser la courbe du progrès.
All countries affected, but in different ways. So there is a variation there, but almost all countries are affected.
Alors, de tous les pays affectés, nous voyons que l'impact est varié. Alors, de quoi avons-nous besoin?
Now, many things will be discussed in this meeting.
De renverser la courbe pour ce qui est de la perte des diagnostics et du traitement de la tuberculose et de la COVID.
I would like to leave you with this slide, which is
thank you.
What is needed? What is needed? Number one, we have to reverse the losses in diagnosis and treatment to pre-COVID situation. But that's not, because we were, even before pre-COVID, we were not on track. So we need to accelerate further TB
Donc, déjà,
to reach the
par rapport au
UNHLM
premier
targets.
point, avant la COVID, comme je le disais tantôt, on n'était pas dans les temps pour ce qui est de l'atteinte de nos objectifs. Donc maintenant, encore la nécessité se fait plus accrue.
We also need to remodel and change the way the TB responses are operating in countries to make it resilient to the COVID-19 pandemic.
Nous avons besoin aussi de repenser et de changer notre réponse par rapport à la tuberculose, surtout tenant compte de la COVID.
So the approach is, as Eliud was describing, a catch-up plan, which should have a surge-up multi-month TB campaign. It should
C'est pour cela que le Global Fund a pensé
and increase financing for TB
de rattrapage
and use of innovative approaches and tools to restore and scale up TB diagnosis, treatment, and prevention.
Toutes les approches innovantes pour pouvoir atteindre cet objectif-là.
Thank you for your attention.
Merci.
Thank you so much, Dr. Sahu. Thank you for actual presentation, because I think what you've done is you've really set the scene in terms of us as civil society and communities, making sure that we are able to reverse, to accelerate, and remodel TB response. Thank you for taking your time, and I'm looking forward to more conversations. I know that the conversation has been long. We are 15 minutes or 14 minutes into the break time, but we may also have questions. I would like to encourage that those with questions, if you can put your questions in the chat box. We may not necessarily be able to open up conversation right now, but I would want to just hand back to Austin before we move to the break, and request that probably we keep the break to 5 minutes. So Austin, if you can just provide us with some guidance. Thank you so much, Dr. Sahu, for your presentation.
Il est possible qu'on n'ait pas le temps de répondre. Il serait intéressant d'écrire vos réponses et de les envoyer dans les conversations. Ainsi,
Art is so pleased to have you there on this platform, and we know that it's never easy coordinating these Zoom and online meetings. So we are so grateful that we are able to make it. I will be having our break was scheduled for 15 minutes, but it's going to be for 5 minutes so that we can have time to catch up with other presenters, and also because of the time. So we'll just have 5 minutes break so that we can also use the time to fix whatever technical issues that we had with the French translation, which I know that is working perfectly now. So we'll do 5 minutes and break, and then we'll come back quickly. So you can still stay connected. You don't need to disconnect because we are recording. So 5 minutes break, we'll be back again. And thank you once again for all the participants who were able to join. We know some people are still joining. So thank you, and thank you once again.
Vraiment, je suis très heureux parce que c'est pas évident
de tenir des réunions avec
cet outil. Donc, on se retrouve dans 5 minutes.
10:24 my time. That's GMT time, Ghana time. Thank you.
Oh, yeah. Okay, wannan kana da shi? Kwan mira da mucika ina irin sa ne zamu gara shi. Ka karbo mana ministry mun. Okay. Da sauran. To amma in sun kawo zamu cika fam ɗin ne shi. Okay. Okay, da me kuma higher certificate. Okay. Yana bin shi za a badina shi.
Amma ba kamar duk wani shigan da kalba
là-bas, l'exception.
Hello, everyone. Welcome back once again. I hope we are online. I want to introduce this section 2, which will be shared by Alan. You will all know Alan. Alan is the Executive Director of KELIN, Kenya. He is our champion when it comes to CRG assessment. He led the road to legal and legal environment assessment, which is now, we now have an integrated CRG assessment. He's going to be chairing this section. I'm bringing Alan in to take over from me to chair this section. Thank you, Alan. Alan, you have the floor, please.
Hi, thank you, Austin, and thank you, colleagues. Apologies, I will sort out my camera shortly, but to save on time, I would like for us to embark onto this session that would allow us to
Alan, if you are speaking, I
focus.
think you need to mute, you need to choose English under the interpretation and mute original audio so that we can hear you.
Say that again, Austin. Hello, Austin, can you hear me?
I could hear Austin and I could hear you as well. I mean, I could hear Alan and you.
Great, so I'll proceed, and because of the challenges, I'd ask that we start off with our first presenter, who is coming from South Africa and is representing those in the mining sector. So I'd like to turn over the session to our colleague Vama Jele, who's representing the South African Miners Association, to walk us through for the next 7 minutes a presentation relating to how they have worked with the CRG tools. Vama, if you're on, please proceed to share your presentation. You have 7 minutes starting now. Then from then, we'll move to the next presenter from USAID. Over.
Good morning, and good morning, delegates, colleagues, and friends. Thank you for meeting us, which means Miners Association. I'm Vama Jele from Southern African Miners Association and responsible for the coordination of the miners in 8 countries: in Botswana, Eswatini, Lesotho, Malawi, Mozambique, Namibia, South Africa, and Zimbabwe. But we are eyeing Africa as Miners Association, and we represent miners, ex-miners, families, and peri-mining communities. Our work includes the labor migration, health, especially on TB in the mining sector, social protection, strategic litigation, and financial inclusion. But my focus will be on TB in the mines project, which we implemented from 2015 to 2020, but nevertheless, we started in 2010.
Les politiques, je vais m'appesantir sur ce qui est des communautés minières de 2015 à nos jours.
It is important to note that the project, structurally, there was involvement at different levels in the Global Fund processes, and also representation of Miners Association in the RCM, including the planning and as well as implementation.
L'engagement de différents types de différents niveaux de personnes, que ce soit du Global Fund ou ailleurs.
And most importantly, some of the deliverables included the 11 operational health service centers, which was built in 10 countries, and different number of studies launched in the region, and also the involvement of civil societies and the key population in the implementation of the project, where about in the first phase, 360 people were reached to screen for TB, and a number of tools were developed during that stage, which including the screening model, the community system strengthening toolkit, task control toolkit. And also there was one challenging one, which was a transitioning of the occupational health to the government system, it's actually having the package of the screening models and the IT tools toolkit for supporting the miners associations, which is the miners, the ex-mine workers and their families, and the peri-mining communities. As you are aware that the peri-mining community is inclusive of the artisanal miners and as well as the informal miners. And then on phase 2, we have seen the number of these activities scaling up, which including the number of people, the active finding the missing cases, and also trying to implement the community system strengthening toolkit, of which we find that the community system strengthening toolkit couldn't actually materialize a lot or to reach the communities, especially addressing community rights and gender issues, which was due to the compounding of the module, where you will find that it was under TB care and prevention. And also on the reporting, it didn't actually show the issues found, which are human rights barriers and gender barriers within the module. And which then it's
La réponse était que dans les communautés minières, il fallait tenir compte déjà de la question du genre et ensuite des barrières. Et cela n'a pas été évident dû à tout ce que j'ai cité tantôt.
And the second one was around the community response and systems, where we looked at building capacity in the communities, especially to the miners association, is a key population, as well as civil society, which are community-based, where there was so much challenges, especially on the implementation during phase 2, where we wanted to see that the miners association are able to respond in a very sustainable way on implementation of the Global Fund grants, especially on the TB in the mines, which were also disturbed by the COVID-19, which came and disrupted and halted at most all of the program, including the social mobilization and as well as community-led advocacy and the monitoring of the activities at the community level.
La phase 2 a connu des problèmes parce qu'il fallait établir le lien entre la réponse communautaire, les acteurs communautaires, le problème du genre, mais aussi il fallait pouvoir trouver un moyen d'un engagement durable pour ce qui est de la réponse communautaire dans les sociétés minières. Cela n'a pas du tout été facile.
Just to run to the last presentation of my speech is the issue around all the gains that we had may be achieved on finding missing cases and the disruption of the COVID-19 came to say that how do we scale up the programs, especially on the challenge of COVID-19, because the community mobilizers are the front line, and also we have to actually give them build capacity on COVID-19 prevention, and also to start opening up to start working at the community level, which also was a delay through the processes from March to July, where travel and the lockdown was very high in our countries.
De mars à juillet, nous avons connu le problème du confinement qui ne permettait pas les déplacements parce qu'en plus, de ce problème de la tuberculose, il fallait pouvoir trouver, grâce ou avec l'apport des acteurs locaux, c'est-à-dire des acteurs, des agents de santé locaux et des acteurs de la société civile locaux, pouvoir trouver une réponse adaptée, non seulement par rapport à la tuberculose, mais aussi dû au fait que l'arrivée de la COVID a sérieusement ralenti ou impacté négativement tous les efforts qu'on avait réussi à faire pour cela, jusque-là, puisqu'il n'était plus possible de se déplacer, puisque les gens étaient confinés chez eux. Cela a augmenté donc le nombre de personnes qui ne se signalaient pas ou des cas non signalés. Or, cela, aujourd'hui, nous met dans une situation un peu problématique.
Drawing up to the challenges, maybe the first one is on the CRG, where we actually, on the write-up for the phase 3, we advocated that the human rights and gender module must be a standalone module, so then we can be able to see the work that addressing the human rights barriers and as well as the gender barriers.
So in that et du problème du genre, parce que si on ne tient pas compte de cela, notre travail ne peut pas être significatif sur le terrain.
The second one is to look at, is there any fruitful gains on the structural involvement of the key population? And we find that even though there was involvement of them at the Global Fund processes and at the RCM representation, planning and implementation, we still have a capacity issue. And also there is more advocacy work that needs to be done, social mobilization, and as well as trying to support the program, especially on the sensitive social protection.
Ces acteurs ont besoin d'avoir plus de capacités renforcées afin d'être actifs. Et cela va dans la droite ligne des objectifs qui ont été fixés.
We have noted that during the concept note writing, there was a lot of power dynamics, and also the voices of the key affected population was sometimes undermined because of the number of them participating in the processes and also being supported, especially because the whole work of the writing teams was done on web-based online meetings, of which most of the communities lack support in order to access internet and also to join the meeting. And also the capacity of accessing these web-based meetings was also a challenge.
Parce qu'avec ça, la plupart du travail a été fait en ligne, ce qui impacte aussi le résultat.
The fourth one is on, we still, note that stigma associated with TB and COVID-19 is still at a high note, especially to the working population, which are migrant mine workers, and as well as you will note that the ex-mine workers are not actually left out on this.
Surtout dans la communauté minière et même les ex-miniers.
The fifth one is finding the missing cases versus the investment disruption by COVID-19. We still need to look at how we can actually change the game and work within a very safe means, especially for the community mobilizers, to ensure that they don't actually get infected by COVID-19, and as well as you will know that there is no treatment disruption.
Non déclarées dans ce contexte actuel, parce qu'il est aussi question de protéger ces acteurs de santé communautaires, les acteurs de santé locaux, de peur que dans la recherche qu'ils effectuent, des personnes non déclarées qui eux-mêmes ne se retrouvent contaminés, que ce soit surtout par la COVID.
And the last one is the increase of informal mining and spreading of dust into communities. It's actually covering the region. You'll also note that there is a lot of minerals in Africa, of which the issue of the dust control is very important because it actually affects the lungs, and it makes the lungs to be prone to diseases like TB. And now when it comes to COVID-19, it's becoming a very serious challenge. And you'll also note that because of the nature of work, migrant
celui de la régularisation, parce que vous avez remarqué qu'il y a beaucoup d'exploitations minières qui se répandent en Afrique. Et si cela n'est pas fait dans le cadre, cela rend vulnérable. Cela rend vulnérable et ceux qui y travaillent, et cela rend vulnérable même la communauté, le pays. Et cela devient donc un lit favorable pour ce qui est des maladies telles que la tuberculose et la COVID. Cela est un défi majeur auquel il faut faire face aussi.
And you will also note that TB and HIV, and especially when the weak immune system, it becomes more killing to miners because of the dust exposure, which most of the miners have silicosis or coal workers, pneumoconiosis, and asbestosis related diseases. And then you come up with COVID-19, it becoming very fatal to them. So it is one of the communities that at this time, they are most affected.
Mais la combinaison entre et le VIH et la tuberculose, ajoutée à cette poussière à laquelle ils sont exposés, les rend encore davantage vulnérables.
So we need to wind up. Just the final point, please.
Thank you. Maybe just to add, to say that going forward, we would like to see capacity empowerment for key population, CBOs and community-based organizations to scale up activities on the missing cases. And as well as you are aware that in South Africa, we actually took TB as a human rights issue in the sense that we had the TB which resulted to 5 billion settlement. And within that settlement, it's one of the areas that we can say that the issue of TB, it's a human rights issue. But maybe we need to look at how we can scale up the TB sensitive social protection to ensure that those missing cases that can be found in communities are able to reach the health facilities.
Nous devons nous assurer que ces cas non diagnostiqués ou répertoriés qu'on trouve dans les communautés, nous devons nous assurer que ces cas-là puissent effectivement avoir accès au centre de santé.
Thank you very much, Vama. Thank you very much, Vama. Very detailed conversation. I request for those who are still tuned in, please type in your questions in the chat box, put in your comments. He has raised very important issues relating to miners, relating to the current funding process, relating to the application of current Global Fund grants that I think many of us relate to. Allow me to move to our next speaker, who is the Chief of the Infectious Diseases Division at UNAIDS. I invite Sherry Vincent to please make her presentation and can also use this opportunity to raise her remarks that should have raised in the keynote. Over to you, Sherry.
Okay, thank you very much. I'm going to share my screen to put my presentation up. Can you see my screen?
Yes, we can see it.
Yeah. Okay. So just, I think you said UNAIDS. I'm from USAID. So thank you very much for inviting me to participate at this meeting. I'm sorry I couldn't be here earlier, but as you see outside, it's still dark here. I'm very happy to join, and I thank Austin and the other organizers for inviting me. So I'm going to talk about the USAID Global Accelerator to End TB and how that relates to communities and local organizations. Okay. So first slide, just to familiarize you with our US government TB program, we have 23 priority countries, and then we have another 32 countries that are more light touch, that we provide technical assistance to. So we have a total of 55 countries that we work in, as you can see, many of them in Africa. So our USAID Global Accelerator to NTB was launched at the UN General Assembly in September 2018. And it was focused on meeting the targets of the UN General Assembly. So the 40 million people enrolled by 2022.
À l'Assemblée générale en septembre 2018. Alors,
and it was to better align with local
missions de
communities and partners to deliver performance-based results towards the global target, and using our funds more effectively and efficiently.
C'est-à-dire
it was really
des résultats basés sur la
performance. For us. So the accelerator, just to sum it up, focused on locally generated solutions. So really looking at what can local partners do in the country? How can we shift our efforts to empower local organizations?
Aidant pour le traitement, le diagnostic et la
So when I say
prévention
not business as usual,
par rapport aux personnes et aux communautés tout en combattant la stigmatisation.
Not just our focus, but also shifting our funding to local organizations. It was looking at direct support to civil society and private sector, and directly linking our funding to mobilization of domestic resources and accountable results. So in a summary, it was about commitment by the government,
qui sont générées
building
en
capacity
partenariat
of
avec les
local
entités
organizations.
locales. Nous supportons ainsi les gouvernements, la société civile et le secteur privé.
So one of the first things we did was to build
La
local
première des choses que
organization
nous avons
network
fait, c'était
response.
de mettre
So
un
we put out a
réseau
request for
de
proposals,
l'organisation
and
locale.
we were shocked to see, sorry, how many proposals that we received from local organizations. Only local
Nous
organizations
étions
apply.
étonnés du
And we had
nombre de
over
réponses que nous avons
300
eues
local organizations in 6
des
weeks
organisations locales.
respond to our request. And as a
Qui ont
result of this,
répondu à notre
we have
requête.
shifted
En
our
résultat,
resources from 2 years ago, before we started the accelerator, before UNGA, so a little more than 2 years now, from 5% of our funding going directly to local organizations to now almost 45% of our funding going to local organizations directly. So meaning we are funding directly
les
these local
allocations sont passées de
organizations from
5% à
USAID. They are
45% de
our
notre programme
partners.
qui
We're
vont
working
directement
hand
aux
in hand with those
organisations
local
communautaires locales.
organizations and really making a shift in empowering local communities. So the progress that we've had so far, as I said, building commitment is one key piece of it. And so we have signed partnership statements
Objectif principal, il était
between our mission
important
directors
de mettre sur
and
pied des
ministers of
engagements.
health
Alors,
in 18 countries
comment cela s'est passé?
that
Nous avons par
demonstrate our
exemple
commitment to
18
UNGA targets
partenaires.
and the government's
Nous
commitment
avons
to those
35
targets and our
partenaires
commitment to each
locaux.
other.
Et enfin,
We have,
60
as I said, in terms of the
conseillers
shift
des
of the
ministères de
funding,
santé.
we now
Et
have
ensuite,
35
nous avons
direct local agreements with
des
partners
feuilles de route
for
de TB
delivering
au
services.
niveau national.
We support many other local partners through other initiatives, but this is direct awards. And then we've embedded nearly 60 advisors within ministries of health. That's another part of building our commitment and capacity. And we just launched in September at the second year anniversary of the Accelerator and an UNGA event. TB country roadmaps, they're on our website. We've started to roll them out. I think there's 7 now on our website. The partnership statements are also on our website. I welcome you to go and look at the commitments that have been made and hold us accountable to them. The country roadmaps have the funding and data, as well as a summary of the support that we provide in those
Là,
countries.
nous avons
So I
par
welcome you to
exemple
go
un
and look at
résumé
those as
de
well
ce que nous faisons,
to
du
get a better
support que nous
understanding of our
apprenons,
programs.
de nos fonds, etc., etc.
In terms of our achievements overall, so in the countries that
Ce
we
que
work
nous
in,
avons
we've
fait
seen a
globalement,
29% decline in TB incidence since
39%
2000,
de réduction
47% decline in
pour ce
TB
qui est de
mortality,
la
and
tuberculose.
126% increase in case notification. We've seen an increase this last year of 5% in TB case notifications. That is definitely not enough. And this is in 2019, and we know in 2020 we will see further declines.
Alors, ces figures
So I
nous
want to
montrent
talk a
clairement
little
que
bit
c'est pas
about TB and
suffisant.
COVID. We did a survey in our 23 countries
Alors, nous avons
with
fait une
our
enquête
USAID
dans ces
missions, and we had
pays.
100% response rate. We did the
Déjà,
survey
nous avons
between
eu la
August 27th
participation
and
de tout le
September
monde à
10th.
100%.
We looked at
Donc, du
guidelines,
27
policies, and then the
septembre,
effect of COVID on
du
services,
27 août
TB
au 10
services,
septembre
inpatient
2020.
care,
Alors
resource
ici,
allocation, meaning staffing and funding, and collected information on notifications. And we
cette
plan to
enquête
repeat this survey
concernait
periodically. I do want to
les
say first,
politiques qui
before I
sont
go into the
développées,
results,
l'effet
that
sur la
the TB community
tuberculose,
have
surtout
been
pour ce qui est la
the
prise de soins des
heroes of
patients,
the
la
COVID
réallocation
epidemic.
des ressources
It is
et
clear
ensuite
from what we've
les
seen
données,
here and what we're seeing in countries
collection de
that
données.
all
Et
of
puis,
you are on the front lines, and the TB platform that has been built by local organizations and communities
l'engagement a
has
été
been
pris
critical to
de faire
addressing
cela à
COVID.
une
We see
certaine
time and time again,
périodicité
governments and
parce
communities
que
have relied
cela
on
concerne
those resources
là-bas
to
sur le
actually
terrain les
succeed in tackling
premiers à être
COVID.
en contact.
So we know that the
Cela nous
TB
aidera
platform
donc
is the
à savoir
platform to build
comment
on if you want to
davantage
address COVID or any other emerging pandemic. And it's something that we need to support and further build.
Alors, nous
So
voulons continuer
in our
à
countries, we've
supporter
seen expert machines
tout
diverted
ce que vous avez
exclusively
comme
for
priorité ou
COVID-19.
comme question pour ce
Again,
qui
this
est
is
de
a
la
problem
COVID ou
because
bien
we would like
de
to
la
actually
tuberculose.
see every person that is tested for COVID would be tested for TB. And so it's really important that these machines not be diverted, but more machines be added. And so it's a concern that we're not expanding access for COVID, but also for TB. In many countries, countries need to do, like, let's say in a country, in I think overall in the Africa region, there is 18 times more people in deaths due to TB than there is to COVID. And so I think the systems that we need to develop need to be actually built on the TB platform, not replacing the TB platform. As you can see in these countries, this is the up to the percent of the number of expert cartridges that have been diverted away from TB to COVID. Again, we want to see them actually working together. Here's some of the things that we heard from our missions, that it's actually very concerning of these reassignments, just confirming that these machines were reassigned and that they're no longer available for TB testing. In terms of inpatient care, we saw in many countries, 57% of our countries reported a reduction in the number of beds that are available for people sick with drug-resistant TB for inpatient care, and those beds were diverted for COVID. Obviously, this is important. Many of the DRTB wards have infection control prevention measures that are useful and important for COVID, but I think we need to think of how these services can work in tandem. In addition, we saw, again, 83% of countries reported that TB staff and healthcare workers at all levels were reassigned for COVID. Again, we need to see how actually COVID can build on top of TB and not be a replacement. And we saw 52% of countries reported that budget was reallocated to COVID. And again, we need to see funding be put on top of the TB funding. We already know there isn't enough resources for TB, so diverting it for COVID isn't particularly helpful for either disease. And then lastly, this is just kind of an illustration of the % change that we saw in TB notifications in 12 countries, looking at January to June in 2019 and then January to June in 2020. And as you can see, there's a number of countries that are seeing significant drop in TB notifications, particularly concerning when you see more than 10%. It's really hard to bounce back and work harder to find those people. Obviously, the communities play a huge role in that. So that's my last slide, but I just want to say that communities play a very important role. The work of CRG, we've doubled our support to the Civil Society Challenge Facility grant. And we continue to support that effort. We're making more and more shifts to empower local communities, to increase the capacity. Unfortunately, TB doesn't have the funding that HIV and malaria have, but I think we try to do what we can with the funding that we have, and making those shifts is really important. So I thank you for your time, and I look forward to hearing the rest of the presenters. Thank you.
Thank you very much. And I want to appreciate the issues you have highlighted around TB, COVID, and what needs to happen, and the expectations on your end, but also the investments that you've made thus far. I want to remind colleagues around posting your comments and questions in the chat box. I see a lot about audio, but I want to see more about content. And as we turn to Dr. Tandy, who is also with the Stop TB Partnership and has been doing work on CRG, I request that you remember there have been 2 presentations on the minors, on the work that USAID has done in terms of TB and accelerating CRG work. Please post some questions in the group so that the participants and the presenters can have a conversation. I pass it over to you, Tandy. Good luck with your presentation. You have 7 minutes.
Donc maintenant, nous allons écouter Tandy Katolo.
So thank you so much, Alan, and the organizers for giving me the opportunity to share
Merci de m'avoir donné la possibilité de partager
as well as how we support the regional projects. I'm being challenged. I can hear the French speaker. Can somebody give me guidance? Is it me, my settings are English, and mute original audio?
Sandy, I think you need to choose English and then you mute original audio.
Okay. Alors, nous rappelons pour les utilisateurs des différentes langues que si vous choisissez une langue, vous mettez
I would like to share. I've prepared a presentation for this so that I can clearly explain other things. I would like to share my screen.
Alors, je vais partager mon écran.
Can you see my screen now?
Yes, we can.
Yes, Sandy.
Yeah.
So
we can.
We see.
Right.
Alors, ici, nous parlons
So
de
my
la
presentation
communauté,
is focused
des droits
on CRG
et puis du
tools
travail pour ce qui est du genre.
Over the last 4 years, as well as the technical assistance that we provide specific to community rights and gender approaches implementation. My name is Tandy. As you can see, I'm a program officer, and within that, the Stop TB Partnership, I work for the community and country support for impact team. So that is the team. So the team is actually led by Dr. Vero Saltin. I'm not sure if he's in the meeting today. And we have like 3 others, and one of the actually are covering Africa, Enos Massini, as you can see him there. And then we have, I work very closely with Kiva and James as they cover other regions in terms of CRG as well as Challenge Facility for Civil Society implementation. So the reason why we have a CRG unit within the country and community support is that our aim is basically to amplify the voices of the community and to ensure that CRG concepts are integrated within the national and policies. So we do that because we realize that there is a weak legal and policy environment. All these challenges are actually like mentioned within the global plan 2016 to 2018 or 2018 to 2022. Our rationale is basically to provide community rights and gender-related TA, which is community-led, people-centered, red-based, and gender transformative to ensure that we reach the UNHLM targets. Initially, it was about the global NTB target as well as the 1990 global plan, but we are now working towards the UNHLM targets and commitments. So as you can see, a lot of our community rights and gender work started to be very visible in 2017 as tools were published, and we are now in 2020 in Q3, and we are now in full scale in terms of implementing challenge facility and civil society projects in priority countries. So our unit is guided by the three big documents, which is the WHO NTB strategy, the global plan to NTB. As now I say, there is a second version, which is 2018-2022, and then we are also in alignment with the investment that are prioritized by the Global Fund strategy. We know that we do have some UNHLM quantitative targets, but we also know that we have the NTB of 95 reduction in death, 0% catastrophic costs. But in CRG, we mostly focus on the middle 90 that is clearly described by within the global plan. So the middle 90 allows us to ensure that we generate data for key population. It also allows us to make sure that we use that data as the community to design and target our interventions to make sure that these key populations are not left throughout the spectrum of TB care. So as the other speakers and our executive director has spoken, we had a first high-level meeting on TB in 2018. And this high-level meeting on TB came up. There were commitments from the heads of states, which were very specific and has been simplified by the Stop TB Partnership. And these two ones, transforming the TB response to be equitable, right-based, and people-centered, as well as the combating the stigma and discrimination. All forms of discrimination are explicit within the commitment that were made in 2018. We've seen a follow-up meeting which also the UN Secretary General reaffirmed his commitment to ensuring transformation of TB services to be right-based and gender-sensitive or transformative. And within that meeting in September, there were 10 priorities that were recommended by the heads of states. Again, within those commitments, there were 2 recommendations that are specifically and explicit about communities' rights and gender. Not necessarily meaning that the community rights and gender approaches do not impact other recommendations. It's just that these ones are very clear and loud. And the report can be found here. So throughout my presentation, I will be showing you the links to where you can find the information that is on my presentation. And I hope that the organizers will share this presentation moving forward. So as I said, within our unit, we work, we are directed by 6 objectives. The first objective is to support countries to overcome barriers to access for TB
Le premier objectif est de soutenir les pays afin que les barrières soient abolies. Le deuxième objectif, c'est d'étendre le monitoring de la communauté sur la société.
In national structures and partnerships are happening are meaningful, and to also provide and coordinate human rights
des nouveaux outils pour
and most importantly, we the global nexus to ensure that they also support implementation of the national networks as well as the
nous voulons
groups
nous
within
assurer que
countries. So we do
l'engagement
that through two
communautaire
mechanisms.
et les structures
We have a
nationales
grant mechanism
et les
called the
différents partenaires
challenge facility for civil
travaillent
society
tous
that will be
ensemble.
presented today. And I don't want to preempt
Ensuite, nous
most of the
voulons
presenters'
coordonner
sessions.
les
And we
droits,
do also have tools that we have
les droits
developed
de
to
l'homme
either guide countries to adopt to be able to enhance
pour
their
ce qui est de la
activities on the
réponse
ground.
CTBA.
In terms
Nous
of
allons
processes,
renforcer
we've been
la
doing
mobilisation
trainings either through request or trainings pledged
dans les
through our
dialogues
strategic
régionaux et
initiative for
globaux.
finding missing people with TB. And we've also
Alors,
been
pour en revenir au
supporting other
premier
strategic
point,
initiatives,
l'environnement,
NTSAFAC, and the human rights breaking barriers to make sure that they
les notions de
implement
genre et les données
with
par
global
rapport à la
commitments and
stigmatisation,
targets.
les évaluations.
So
Voilà
having
les
said
outils
that,
que
I will
nous
start off
utilisons.
with the
Alors,
first
comme
tools,
activité,
which were basically developed in order to help countries to assess and generate data. And this was to make sure that the communities lead on
voici les
generating their
outils qui
own
nous
data
permettront
and
d'évaluer
also
ça.
recommending what they feel is right
Voilà.
for them, and as well as disseminating and advocating what they believe is their priority.
Alors, ce
So
travail va permettre à
we
ce que
had
ces
the gender
communautés
assessment
puissent
tool,
générer
the data
eux-mêmes leurs
framework,
données
and
et
the
ainsi, en
legal
utilisant ces
employment
données,
assessment.
pouvoir
These tools
revenir
were
avec une
implemented
solution ou
separately in the
alors
first 6
avec
countries
des voies
to
qui
benefit
sont
from
plus
strategic
appropriées à
initiative.
leur
But then with
communauté.
lessons learned, we realized that there were so many overlaps and interlinking in terms of concepts as well as to save money. So in the last 7 countries, these tools were implemented in an integrated manner. And we are now using all the experience that we
Alors,
saw in
quand on
the last
utilise, on a
the
remarqué que
13
ceux
to
qui ont
17
utilisé
countries
ces
that completed
différents
assessment to make sure
différents
that we
outils qui ont
develop
été
a
cités plus
comprehensive
tôt,
integrated one with
alors,
the view that countries outside the strategic initiative who have applied for the global fund and
ils ont
included
développé
will be able to use a comprehensive tool.
types
And we also want to make sure that as we
d'investissement,
do a
c'est-à-dire
process evaluation in the 3
de
countries, we also use
qui
these tools to
permettaient
make sure that there's
ainsi
clear
de
guidance.
soutenir
So
les
in
pays pour
addition
ce
to
qui est de
that, we
l'application
developed another tool
de
and
la
published it
réponse
in
des plans stratégiques de
2019.
la TB.
So the difference between the stigma assessment tool and the CRG assessment tool is that the CRG assessment tool basically gives you a qualitative background of who is being stigmatized and where the stigma takes place. And then the stigma assessment tool will now say, okay, let's see whether where the burden is. Let's measure the burden of stigma in this community, or let's measure the burden of stigma in this setting. So this tool is accompanied by the data collection instruments as well as the data analysis and can be found on the links that I've shown here. So the reason why we're also doing that is that at the same time, the Global Fund with other technical partners and the Stop TB Partnership developed 3 indicators specific to stigma, which countries can now, after they know their levels, they can now start monitoring and tracking whether their stigma interventions are actually working and whether stigma is actually reducing.
Alors,
so
CRG permet
at
de
the
voir
third
si
time, in
effectivement ces
2020, we saw a lot of
stigmatisations
countries,
réduisent,
window 1
les
and
politiques qui sont mises en place
for the Global
arrivent à
Fund,
toucher
as well as
effectivement
doing program reviews, as well as
ce problème de
developing national strategic
stigmatisation.
plans. So we decided to simplify all these tools and make some investment packages. So these investment packages can be seen in that website here, and they basically outline what activities are required and how much you can budget for it, and basically give you a snapshot of what is required in terms of the objectives or the outcomes that you get from the two assessments. Moving forward, this is where we are in terms of rolling out these assessment tools. For CRG assessment tools, we've completed these globally in about 17 countries. And the reports can be found in the website that I've provided here. And then we know that they are ongoing assessment. They are also supporting it virtually Myanmar, Cameroon, Niger, Benin, and Cote d'Ivoire, Zimbabwe, Vietnam, and Uganda. So the Benin, the Francophone countries are being funded by the 5% initiative, thanks to the French government, and we've been supporting them throughout. And we should be seeing that report very soon before the end of this month. And then Zimbabwe is being supported by the LON, thanks to presentation by the LON USAID. And then I'm aware that I think Uganda and Vietnam and Myanmar is being supported by our challenge facility, and I think Vietnam and Uganda are being supported by the local projects. In terms of the assessment, to make sure that these recommendations are implemented, so countries went further to develop actions, right? And the actions are developed in an integrated manner on a document
Alors,
called
pour s'assurer
CRD
que ces
Cost and
politiques ont
Action
été
Plan.
effectivement
The aim of this
implantées,
document is to make
alors
sure that we
cela a
have
été
every country
divisé
have a
de
systematic
manière à
way
ce
of
que
implementing the actions, and to also make sure that
chaque
we know
pays
how
ait
much
une
money we
manière
actually
bien à
need
elle
to
et
ensure that
systématique de
the full
mettre en pied
spectrum of
ces
CRD
politiques-là.
approaches is being implemented. Ideally,
Donc,
message to
toutefois,
take,
nous
here,
recommandons
to take
vivement
home here is
l'approche
that
CRJ.
the 6 of that I explained before that our team is actually directed by is that every country should be able to cover all those 6 objectives, to be able to say that they have a robust CRG approach and to meaningfully contribute to UNHLM targets.
Il faut aussi noter
So moving
que
forward,
chaque
we do
pays
also
devrait
have
être
another
capable
support
d'avoir
that is, I think
validé
some
les
of
6
you have already
différents points pour
spoken or
pouvoir
have been in
dire
touch with Enrica,
qu'effectivement,
one of
elle
the team
travaille selon
members.
l'approche
So
CRJ.
this is where we actually support countries to either
Alors voilà les
establish or
plateformes
make
nationales
sure
et les
that
outils de partenariat.
their
Donc
national
nous avons
stop TB
globalement 30
partnership are
pays
functional. So the national stop TB partnership
qui
are
sont en
different from
contact
the
avec
other
nous. En
platforms
Afrique,
that I
nous en
know
avons 11,
that
parmi
were
lesquels le
established
Cameroun,
within the national
Nigeria,
TB
etc.,
programs because
etc.
they are basically led and
Alors,
hosted by
nous
the civil
initions
society.
des
And
projets
the chair and everybody
régionaux,
is
comme par exemple
everybody
au
who provide
Botswana.
oversight to this
Et la
those national
plateforme
platforms is
engage
basically
différents types
chosen in a
d'acteurs
democratic way
dans
with
le
involvement of
TB et
the
des
people
réponses aussi,
affected by TB.
s'engage à
We
mobiliser
are
les
hoping that
ressources
this kind of
et à
national
impacter ou à
platform
influencer les politiques,
will now
coordonner
amplify
les
the voices
efforts
of the
pour
people
un meilleur niveau
living
de
with
plaidoyer.
people affected by
Ensuite,
TB, but
on
ensure
s'engage
that there are synergies from
à
all the expertise
utiliser
that we have
les
in the countries
célébrités
in relating
afin
to
de
community rights
pouvoir
in general.
rendre conscient ou
So in Africa
d'augmenter
so
la
far, we
conscience
are in touch with,
populaire
out of the
par les
30
médias sociaux.
country level stop TB partnership
Généralement, les
platforms that are
informations
in
de ce
touch with us,
concept
are reporting to
sont,
us or are
en
being
général, les informations
supported
par
by
rapport au
us.
concept
We have
CRJ sont
11 in Africa.
valables ici. Vous
And these
cliquez là où c'est
platforms
écrit
usually
hier,
share
là
the
vous pourrez
stories.
avoir
As
le
you can
reste
see,
des
those are the pictures
informations.
from some of the
Si vous
African
êtes, si
stop
cela vous
TB
intéresse,
partnership that has recently in the last two months shared that
un
story with
partenariat
us.
national
And then
dans
if
votre
you really
pays,
do
voilà
want to
l'adresse
start
email
a
en bas
national
que vous pouvez
partnership,
utiliser.
you can actually reach out to us on the partnership.tv website or on Enrica's email that I shared earlier on. So within the challenge facility, Act Africa, we're able to support other countries outside the priority 13 or 14 that we supported on the challenge facility through our regional project. And one of the countries that I'm aware will be establishing a national partnership is actually Botswana, supported by our Act Africa
Comme
project.
par exemple au Botswana.
And then, as mentioned before, the challenge facility and civil society is growing because we've learned more. There's a lot of appetite out there, and then we understand more on what we need to do. We believe that our approaches will work. So in Africa, we have 14 civil society that received the small grants, and then we have 3 regions. Yeah, 2 in focus mostly in Anglophone and 1 in Francophone Africa, which is BASSE, Wasi Health, and Act Africa. The original scope, as I said, has evolved. So now most of the intervention are based or informed by the CRG assessment results. We are hoping to expand it to other additional 7 strategic initiative countries in the next cycle. So the other tools that we have are policy guides. These ones I think everybody knows about. They were the first to be published before the CRG tools. And then within our challenge facility, our project at the moment, Nigeria is targeting refugees based on their previous round 8 experience of the nomads. The minors are mostly being reached through the Teams project, and Mozambique is actually scaling up some of the Teams project activities within the challenge facility grant. Then we have Nigeria as well that is also targeting the slum dwellers in terms of assessing stigma within those. And then Stop TB partnership further through their human rights discussion group to develop an investment packages for the which basically elaborated more on the activities described by the
Comme par exemple au Nigeria, des
We
exemples
need
nous
to
avons
wind
au
up.
Nigeria,
Time is
nous avons
limited. Please
le
wind up,
document des
Tandy.
réfugiés, par exemple au
this morning is
Mozambique,
that it's
nous
very,
avons
very
le projet
important to
Teams.
monitor and evaluate our efforts, and also to monitor and make sure that nobody is left behind or nobody is experiencing human rights or gender
Alors nous voulons nous assurer à travers tous
So
ces
we
efforts qui ont
developed
été
a
faits que
tool, a
personne
digital
n'est laissé pour
health
compte
solution
et
tool.
que personne n'est
Its
ignoré.
aim is basically to enhance the efficiency of the community-led monitoring projects or community-based monitoring projects on the ground. So this tool is available for free and has about 4 minimum components. So the first component is to ensure that whoever is the user who's primarily a TB patient is able to access recent information and relevant to their disease.
Le but étant que
The
même
next
la personne dans la communauté rurale qui est infectée par qui a la tuberculose doit avoir accès aux
The third one is that it provides a platform for the TB patient to be able to engage and be provided with psychosocial support with other platforms that are already on the ground. And then also it's also provide an opportunity for them to report on the issues that they are experiencing so that we can be able to respond in real time to address them, or so that we can also be able to use that to evaluate, to use that feedback to evaluate and ensure that our policies and advocacy efforts are targeted. So in terms of accountability, this tool has got what you call a dashboard. So what it is that it accumulates individual reports so that the national program and the community group can prioritize on which issue to attend to in terms of advocacy or in terms of changing their policies or their practices. So this
Pour ce
tool,
qui est du changement de politique ou bien des réponses communautaires, nous voudrons utiliser tout ce travail qui a été fait pour pouvoir mettre
our
en
One
ligne
Impact platform has been
la
rolled
cible,
out in several
c'est-à-dire
countries,
la
and most of
population
them
et la
are at
communauté.
different, and these countries are at different stages. So, but we have had like some achievements with Mozambique, Cambodia, Tajikistan, Ukraine, and DR Congo.
Alors
and
ici,
then
nous
the ones
voyons
that you see
un peu
in
ce qui
red
se
that
passe
are
dans
actually
certains
now
pays.
covered by
Par
the
exemple,
current
ce qui est
challenge
des besoins
facility.
et de la
And there's a lot of
faisabilité, ensuite de
varieties in there,
l'adaptation
especially the Kenya one where they'll be
et des
looking at
solutions,
financial
ensuite de la mise en place ou de la mise en vigueur.
Sorry,
Sandy, we need to wind up. Time is way gone. Please, I know there's a lot and very good achievements, but let's summarize. Thank you.
Sorry, can I continue?
Okay. You have
so we
2
also
more
now
minutes.
have tools that countries can adopt to make sure that a better understanding of human rights and medical ethics.
Voilà quelques
and then we also have the tools that we've developed to even better to help our civil society to be able to advocate better at country level. We do recently have the TB
les outils de plaidoyer. Par exemple, nous avons le premier, là, TB and Human Rights Discussion. C'est une plateforme qui a été mise sur pied en 2018 et qui se retrouve chaque mois. Alors, quelles sont les étapes suivantes? Continuer de donner des financements pour la mise en place de la CFC, soutenir les pays. Alors, voilà les barrières auxquelles il faut s'attaquer, la réalité, l'égalité et la libération.
Thank you again. Some rich information from Dr. Tandy. We'll quickly move to Kate Thompson, who heads the Community Rights and Gender Department of the Global Fund, who will be our final presenter. Again, I recommend that...
Alan, we can't hear you if you are talking. We can't hear you.
Thanks. I hope this is clear now. I want us to move forward to Kate Thompson from the Global Fund, who leads the Community Rights and Gender Department, to take us through the last presentation. Tandy, you already have a question in the chat box where someone is asking for what your advice would be on CSO's applications. Please, if you could respond with it, that would be appreciated. Over to you, Kate, for your presentation for the next 7 minutes. Thank you.
Thank you, Alan, and it's great to be here with everybody. Thank you for inviting me to present. I'm going to
de m'avoir invité.
Oh, this translation is quite difficult. I haven't found a way to switch off the French, so
sorry.
I will do my best to speak despite. Can you tell me if you can? Oh, I don't know. Can you see my screen? Can you see my screen? Okay. There's something strange going on here. Can you see my screen here?
Est-ce que vous voyez mon écran?
Not yet. Something's frozen here, so let me just see if I can get out. Oof. Can you still hear me?
Yes, we can hear you and we can see you.
Okay, I seem to have lost the ability to actually click on anything in my Zoom. I don't know what's happening here.
Austin, if you have the presentation, could you share it from your side?
Alors,
everything's frozen from my side, so I don't know what's happening.
On attend que cela se mette sur pied.
I don't know if we had the presentation, I can actually share it from my side or from our IT.
Okay, I can't even now. My laptop seems to have frozen. So, can you find the presentation, or is Austin? Could you try and see if you can? I'm really sorry. I have no idea what's happening here.
Voilà.
No, we have it.
Do you have it? Okay, thank you very much, because I actually can't see anything I can hear though, so apologies for that. Okay, so
if we could move to the next slide, please. Global Fund. Alors, l'objectif primaire des droits communautaires et de la stratégie basée sur le genre.
Sorry, there's okay. I think there's someone speaking in French, but basically, so okay. So as the CRG department through the strategic initiative supports the engagement of TV communities and civil society in global fund related processes. And after the CRG special initiative in 2014 to 16. The CRG strategic initiative, the current one will end in December, and the CRG strategic initiative for 2020 to 22 will start next January. Could we go to the next slide, please? So, as you'll see from this slide, the strategic initiative implements 3 mutually enforcing components for engaging communities in global fund-related processes. The first is technical assistance, and then also we have the second one, which is long-term support for organizations and networks. And then the third is original civil society platforms for communication and coordination. And all 3 of these components engage civil society and community organizations that are active in the area of TB. Could we go on to the next slide, please? The external evaluation of the current strategic initiative formulated several key recommendations related to TB. And the first is strengthening coordination between the CRG strategic initiative and the Finding Missing People TB strategic initiatives.
avec d'autres initiatives.
The second was a careful differentiation of roles and results for future TB grantees through the initiative.
Avec soin, les rôles et les résultats.
The third is regional platforms continuing to engage TB in civil society and to focus on generating TB-related technical assistance demand. So these recommendations through the review are being taken into consideration during the current planning phase for the CRG strategic initiative that kicks off next year. Could I have the next slide, please? So the following three slides are going to provide an overview of the key achievements related to TB in the 17 to 19 SI, as well as an outlook of adaptations moving forward. So during the CRG-SI for the current period, just under 160 eligible TB requests were received, with 11 requests focusing on TB and 59 requests focusing on HIV-TB combined. One example included the support to a regional ex-mine workers association to adapt an existing community-led monitoring scorecard for TB. And you'll see that in example one. Another example is the situational assessment of barriers to TB services for women and the development of recommendations on how to address them, which is example two. The CRG-SI will continue to provide TA to TB civil society and communities moving forward in three key areas. The first is situational analysis and needs assessment. The second is engagement in country dialogue.
Alors, pour ce qui est du soutien par rapport du
And
soutien
the third is in supporting design and implementation arrangements.
L'analyse situationnelle et l'évaluation des besoins. Deux,
Going forward, the principle of peer-to-peer TA provision, as well as the focus on expected TA outcomes, will be strengthened. We really want to ensure that we're embedding the principle of peer-to-peer provision and South-based provision. South-to-South is something that's key and essential. Can I move to the next slide, please?
Okay. Nous devons renforcer ce principe de pair, c'est-à-dire
during the current implementation period, 5 key and vulnerable population organizations and networks received what we call long-term capacity strengthening and support. TB community-led activities were implemented in 19 countries, all countries with high TB burden and high numbers of people with TB. One example included the organization of a TB community forum in Tanzania with support from ACT-TB and ENASO. Going forward, the CRG strategic initiative will continue to support selected TB and TB key and vulnerable population organizations and networks with a stronger focus on country-level impact and complementary roles.
Ce sont des organisations que vous connaissez.
If we could go to the
ça, c'est pour ce
next
qui est
slide,
l'exemple des
please.
réseaux. Alors,
During the current period, 6 regional communication and coordination platforms were hosted by regional civil society organizations such as ENASO. And these have played a key role in coordinating TA demand for enhancing knowledge of communities on the Global Fund. And going forward in the next period, the CRG strategic initiative will continue supporting the platforms to strengthen TB community and civil society engagement in Global Fund processes, as well as to generate advice on TB-related TA.
Voilà.
And then if we can go to the next slide, which is my last slide, Alan, you'll be happy to hear. So the session also aimed to look at progress towards achieving
Stop TB and Global Fund strategy on CRG, as described earlier. So the Global Fund, together with the TB expert working group, which included representatives from communities and technical partners and academics, developed 10 key program areas to address human rights and gender-related barriers to TB. And the Global Fund's Breaking Down Barriers strategic initiative was launched actually in 2016. Out of the 20 countries included in our Breaking Down Barriers initiative, in 14 of those countries, there's a specific focus on TB and human rights. And in the current period, 50 countries, many of them in Anglophone Africa, and 4 regional grants invested in programs to reduce human rights related barriers to access. So if we look at the progress made on investments, the investment is overall just 1% of all of Global Fund investments. However, this is nonetheless great progress from the baseline where we started, which was 0.08% going to human rights programs in NFM1. So I think this shows that clearly we have a long way to go to achieve the Global Fund key performance target of 2% of TB investments going to programs to address human rights related barriers. We're making progress, and I think we're making progress because of the activities and the partnerships that we've really heard talked about in this current session. And I really want to stress as I end and thank everyone for the really productive and important partnerships, including very much with civil society as well as our technical partners and communities on the ground, because it's only collectively that we're going to continue to make progress in these areas. And next slide, please, which is just a big thank you to all of you. And I'll stop there, and apologies for the technical glitch here, but I hope you got a sense of what we're doing. Back to you, Alan.
And despite the glitches, we got you loud and clear. We also received the slides well. Colleagues, I thought I would save more time from the earlier session, but I've gotten us late, so we may not be able to take questions. But I think the take-home message here is that we have very important tools around moving forward work on community rights and gender issues in the context of TB. We need to identify ways on how we make use of these tools. In certain spaces, USAID, Stop TB, and Global Fund are providing funding where you can be able to make use of the funding available through various country grants. To take forward some of these tools, we need to explore that, especially for the countries that are eligible for Global Fund funding. I know there may be more questions in the chat box. I request the presenters, when they have time, to check through. And there's an important comment from Roger around the dire need for organizational development for the grassroots community-based organizations. I think that is something the facilitators will be able to respond in the chat. I'd want to end the session here so that we can move on to the next one and turn it over to Austin, who will then flow us to the next session. Thank you to Kate, to Vamal, to Tandy, to Sherry, for your very insightful presentations. And Austin, as requested, please ensure this is available, the slides, to everyone who's on the call today, because there are people who have requested for the same. Over to you, Austin, and thank you for the opportunity to moderate.
Thank you, Alan, for chairing this session. Great section. We always love to listen to Global Fund, Stop TB Partnership, USAID. This is awesome. I'm going to, we are running short of time. That is why we are not allowing any question at the moment. But let me say that you have the chat platform. You can actually share your questions in the chat platform, and it will be answered as we move on with the presentation.
Alors, je continue de rappeler que pour des questions éventuelles que vous
And
avez,
again,
vous avez
let
la
me
rubrique
say that
conversation, vous pouvez
in terms of
continuer.
the translation,
Le manque de temps
because I
fait à ce
can
qu'on n'a pas
see
encore
how to
pu
make
vraiment
it
commencer à répondre à ces questions-là, mais continuez de
If
les
you go
poser.
under the bar, the toolbar, you will see for the Zoom, you will see interpretation. You choose your language, either you choose French or English.
Alors, sur la barre des tâches, il y a l'icône interprétation. Et là, vous choisissez soit l'anglais ou le français. Et d'après la langue que vous avez choisie, vous mutez l'autre.
I will be handing over to Carol to share the next section, section 3, which we'll quickly jump into now before we have lunch. I'm sure that people are getting a little bit tired, but let's do this section quickly and then jump into.
Je vais passer la parole à Carole qui va animer la section 3.
So Carol, please, you have the floor. Thank you.
Okay, thank you very much, Austin. And thank you, Alan, for chairing the last session and also the presenters. Actually, the last presentation from Kate was a good segue for the presentation, for the session that we are going into now, because now we are going into the actual sharing and learning from our colleagues who are the implementers of the challenge facility
était très intéressante parce que c'était une introduction à ce qu'on
They'll
va
be
faire
sharing the
maintenant, qui est
experiences of the effective
vraiment
engagement
de
in
partager
human rights and
les
gender.
différentes
So they'll share with us
expériences
the
et
key
de tirer des
successes
leçons de
that
ce
they
que d'autres
registered, the
personnes ont
challenges
fait.
faced, and the way forward.
Donc, ils
So we
vont
can learn, and
partager
then
avec nous
as we have heard, we are running out of time. We might not be able to take
leurs expériences telles qu'elles ont été
send all your
conçues,
questions in the
mises en
chat,
œuvre, de
and we
sorte
can
que nous aussi nous
go through
puissions
them
en
at the
tirer
end
profit.
to have a bit of time. So our presenter, I think our first presenter is actually going to be Austin, who doesn't need any introduction.
Alors, notre premier
Augustine is the
présentateur
technical
sera
director
Austin.
of ACT,
On n'a pas
I
besoin
think the first presentation, and I'll introduce
de
the
le
others as they
présenter.
come on. But as they come, please, I request them to introduce their organizations because the information I have
Alors,
here is
chacun va introduire
so Austin,
présenter
please
son
go ahead with your presentation.
Alors, nous commençons par Austin.
Thank you, Carol.
Merci, Carol.
Okay, Rodrick is already sharing the screen. That's fine. I'm the technical director of Africa Coalition
Je
on
suis le
TB,
directeur
and I'm just going to
technique
share
Coalition on TB, ACT.
our challenge facility implementation, and also probably talk a little bit about our global fund implementation. Rodrick, can you go on to the next slide, please? ACT is a regional network, and our vision is TB Free Africa. Rodrick,
est un réseau
move on to the next
régional.
slide.
Alors,
Next again, please.
OK.
So our aim is actually to promote
Notre but est de promouvoir l'approche basée sur la personne
in
pour
African region,
la TB
so that
dans la
we
région
leave no one
africaine.
behind and also practice
De
what we preach,
construire et
and
de
also building
renforcer
and
et le
strengthening the
plaidoyer
advocacy
et les
and
outils
strategy through
ERG, leur implémentation,
PHOs
leur
and
technique
including the
pour la
vulnerable
société
population.
civile et les communautés,
Again,
tout en
you
incluant
listen
la
to
population
Andy's
vulnérable.
presentation that we need
Et nous assurer aussi
our
que
proposals,
pour ce
our
qui est
implementation and our decision making to be
de la prise de
evidence-based.
décision,
So what it
l'approche
means is that
basée
we
sur
need
les preuves
to
sera
have all this supportive implementation capacity in terms of operational research, and also in, having a CRG assessment in countries to inform our implementation capacity. Next slide, please. So within this, the challenge facility implementation, doing as a regional network, we identified a weak capacity in the implementation of CRG assessment and recommendation. You will hear in a subsequent presentation from INASO how they're able to do that in terms of having a CRG assessment and also having a work plan. You know, it's not about having the assessment, it's also budgeting, costing, action plans to be able to reflect what the country has done in terms of the assessment. And we've also seen inadequate, meaningful involvement of communities and TB survivors in decision-making processes and accountability mechanisms.
des mécanismes inadéquat.
So the objective is actually to strengthen the organizational capacity and advocacy capacity of our TB affected communities and civil society, and also to engage major stakeholders in making sure that we fertilize regional and global dialogues on reaching the TB UNHLM targets. We know that our continent is not on target in terms of reaching this, coupled with COVID-19. It makes it even more precarious for us to be able to reach the target. But we need to do things differently if we really want to get there. Also, another objective is also to develop and implement regional community monitoring tools. INASO is leading this in our region, and we will also be discussing that in a subsequent meeting, and supporting it with all our capacity in terms of the rich knowledge and technical assistance that we will provide moving forward. And also to conduct regional advocacy campaign and advance priority TB issues identified by TB affected communities, also through the strategy assessment as well. Next slide, please. So the milestone that we've actually achieved in doing this, Sandy mentioned that even outside the priority countries, that we also seen that ACT is supporting other countries, including where she mentioned Botswana. We're also supporting Ethiopia, supporting Eswatini, some of our projects, not only the Challenge Facility project, but also from the Global Fund project. We supported Mozambique. They all have now strong national networks that can actually work as an umbrella network to support the country advocacy. We also provided an advocacy platform for national and community level TB networks to share good practices, as we are doing now. This is something that is really needed within the continent, and also for us to do a strong, a very clear, meaningful mapping of our networks and national and community level organizations to be able to offer targeted support to these institutions. To improve the advocacy capacity of CSOs and communities in the African region, and most importantly, increase their knowledge in the CRG assessment. So these are tangible things that we're already doing, and we are engaging a lot of our partners, not only at the national level, but also at the periphery, to make sure that they really understand how these things are being done. So we are making sure that we leave no one behind. Next slide, please. So our next step is actually to continue to build and strengthen the capacity of national TB networks in Africa. We are going to see a lot of networks springing up, meaningful networks that will stand the test of time. We're also providing sustainable advocacy platform for TB CSOs and in Africa. We're going to be seeing the launch of a strong campaign, sustainable communication response on TB, which is called TB. This will lead a very strong advocacy campaign that we want to do for the Global Fund, to make sure that the Global Fund actually look at the disease split, and something that we really need to do strongly coming from our continent, which is hit hard by TB. We also develop, and we are going to disseminate CRG to campaign. We've seen that we have so many documents, scattered all over. We want to make sure we bring it as a one-stop shop so that people can easily access, these documents at one spot, and not just going around looking for different documents. But it's going to be shared with all the participants and also people who are not able to participate in this meeting. We continue to represent the voices of CSOs and communities in Africa, and also to advocate for more resources like for TB, like I said earlier. Next slide, please. So please, this is our platform that you can join our Facebook platform. You can you can go to the website and also see what is happening. If you have any issue or any information that you need to share, these are our email addresses. You can send to me directly, or you can also share through the organizational platform. Next slide, please. Thank you, merci and obrigado to everyone who has joined. We are so grateful that we have all of you on this platform. The numbers are still increasing. Thank you so much. Carla?
Yes, thank you very, very much, Austin, for your presentation. I think in the interest of time, can we quickly please have Bertrand Campuer? I always fail to pronounce the surname. He is the technical director from DRAF TB in Cameroon. Bertrand, please, the floor is yours.
Yeah, thank you, Carol. I sent my presentation yesterday. Can you use my presentation? I made my presentation in English so that I can speak in French.
Austin, can you support with that?
Austin,
with putting up his presentation?
Austin, can you show?
You have a draft TV presentation.
I sent my presentation. Yes, I sent my presentation yesterday. So, maybe I can start. Bonjour à tout le monde. Je voulais, au nom de TrappedTB, dans un premier temps, remercier cette opportunité qui nous est donnée de partager notre initiative dans la région Afrique francophone dans le cadre du projet Challenge Facility for Civil Society. Je voulais aussi souhaiter la bienvenue aux membres de TrappedTB qui sont connectés sur cette formation qui durera 3 jours. Donc, dans le cadre de l'initiative de Stop TB Challenge Facility, TrappedTB met en œuvre un programme qui vise à autonomiser la communauté et les survivants de la tuberculose pour le suivi de la déclaration politique de la réunion de haut niveau des Nations Unies et les différents jalons qui sont associés au CRG. Suivant. Donc, dans ma présentation, je vais vous parler un peu de TrappedTB. TrappedTB, c'est un réseau, c'est une plateforme des réseaux en Afrique francophone qui couvre actuellement 13 pays dans la région Afrique de l'Ouest, Afrique du Centre. Et notre mission est effectivement de contribuer à une approche centrée sur le patient et des services communautaires de prévention, de diagnostic, de traitement pour des personnes qui sont particulièrement vulnérables en essayant d'autonomiser les communautés et les survivants de la tuberculose pour qu'ils puissent mieux participer à la réponse en Afrique francophone. Comme je disais, aujourd'hui, nous sommes un réseau de plus de 200 organisations membres dans 13 pays, je reviendrai en Afrique francophone, et 2 réseaux de survivants de la tuberculose, notamment au Burundi et au Bénin. Notre modèle de gouvernance est basé sur un comité directeur, une coordination régionale avec son secrétariat qui est appuyé par une organisation membre de la plateforme. Et dans chaque pays, nous avons des points focaux pays et des points focaux pays qui, à leur tour, coordonnent des organisations. Voilà pourquoi je disais qu'on documente environ 200 organisations qui sont membres de cette dynamique. Next, please. Notre programme prend essence sur 2 moments importants. Il y a le moment important, premier moment important est la déclaration de Cotonou de 2018, où les directeurs de programmes tuberculose en Afrique centrale et en Afrique de l'Ouest réunis autour de la plateforme One Account TB ont fait la déclaration de Cotonou en 2018 pour sonner pour envoyer un signal fort à tout le monde entier en mettant en exergue les faibles résultats de la tuberculose dans cette région-là. Et également, nous sommes aussi inspirés par le rapport du bureau de l'inspecteur général du Fonds mondial en mai 2019 qui essayait aussi de soulever la sonnette d'alarme pour dire qu'il y a un déficit important en termes de détection dans la région en Afrique centrale et de l'Ouest. Et ces données ont effectivement, c'est vrai que ces données ont été présentées par Saou, mais je reviens encore pour dire que les données en Afrique centrale et en Afrique de l'Ouest sont particulièrement préoccupantes par rapport au reste de l'Afrique. Nous avons les décès qui ont augmenté de 5% sur la période 2010-2016, alors que sur la même période dans le reste de l'Afrique, ces données, ces décès ont diminué de 8%. En Afrique centrale, en Afrique de l'Ouest.
Bertrand, if you can speak up a little bit, we can hardly hear you.
I speak in French so that you can have the translation in English. And my PowerPoint is in English. I don't know if those... Est-ce que vous me suivez pour les francophones qui sont connectés?
I think Bertram also, I think the speaker sometimes they have
Oui, on te suit.
On suit. Okay, merci. So Francophone are listening, so Anglophone can have the translation, and then also my PowerPoint is in English. So the incidence, l'incidence de la tuberculose en Afrique centrale et de l'Ouest a augmenté de 10%. Dans le reste de l'Afrique, elle a chuté de 6%. Les personnes qu'on n'arrive pas à diagnostiquer toujours dans cette région augmentent de 8%, alors que dans le reste de l'Afrique, c'est stable. Donc, il y a également des données comme ça qui sont inquiétantes, notamment par rapport à la co-infection TB-VIH, qui est supérieure de 50% par rapport au reste de l'Afrique. Les enfants et les adolescents dont on n'arrive pas à détecter environ 3/4, et également les cas de tuberculose multirésistante, on arrive simplement à diagnostiquer environ 20%, diagnostiquer et détecter environ 20%. Donc voilà ce qui nous oriente et on arrive sur notre problème prioritaire par rapport à ces données dont je venais de présenter. Next, please. À ces données que je venais de présenter, voilà, notre région, notamment la partie francophone, nous avons deux problèmes prioritaires. Une faible redevabilité dans la réponse tuberculose et un engagement et des réponses communautaires qui sont également faibles. Et pour gérer, pour adresser ces deux problèmes prioritaires, next please, pour adresser ces deux problèmes prioritaires, nous nous sommes focalisés sur la déclaration politique de la réunion de haut niveau. Donc, le programme que nous mettons en œuvre a trois principaux objectifs. Le premier objectif est d'abord de faire un suivi de la mise en œuvre de la déclaration politique dans 12 pays francophones afin que les cibles et les engagements de cette déclaration politique puissent être atteints. Et ça, nous faisons ça en relation, nous faisons ça en partenariat avec le Global Caucus, notamment le caucus francophone. Le deuxième point, c'est de renforcer les capacités de plaidoyer sur le CRG des communautés affectées par la TB et des réseaux de survivants pour que la réponse dans notre région soit plus sensible aux droits humains et au genre. Et le troisième objectif est plus contextuel. C'est dans 4 pays, nous avons pris l'ambition d'évaluer les barrières qui sont dues à la discontinuité des services de COVID-19 dans 4 pays en Afrique francophone. Donc voilà les 3 objectifs que nous avons dans notre cadre de subvention Challenge Facility. Next, please. Et pour atteindre cet objectif-là, nous avons en place 5 principales interventions. La première principale intervention est le suivi de la redevabilité en utilisant des listes de contrôle de l'OMS dans le cadre de le cadre de redevabilité. C'est la première intervention stratégique. La deuxième intervention, c'est une intervention de renforcement de partenariat avec les parlementaires pour pouvoir mener le plaidoyer efficace sur la redevabilité dans la région. Renforcement du partenariat avec les directeurs de programmes tuberculose pour ensemble adresser les défis associés au manque de redevabilité dans la région. Et le troisième modèle de partenariat, c'est de renforcer le partenariat entre les communautés affectées et les survivants pour apporter une réponse plus efficace dans le cadre du suivi de la redevabilité. La troisième intervention, c'est une intervention de renforcement des capacités, notamment sur le CRJ, parce que dans notre région, les capacités ne sont pas encore optimales. Et voilà pourquoi l'une des initiatives, c'est la très grande participation de nos points focaux dans cet atelier de formation que nous avons aujourd'hui. Le quatrième point, c'est le plaidoyer communautaire. Le plaidoyer communautaire qui doit permettre aux acteurs, au réseau de survivants de la tuberculose dans notre région, au réseau de communautés affectées, de mener un plaidoyer pour l'atteinte des engagements pris dans la déclaration politique. La cinquième intervention, c'est une recherche opérationnelle pour essayer d'analyser la discontinuité des services de tuberculose dans le contexte de la COVID-19. Comme je disais, nous avons 12 pays qui sont ciblés. En Afrique de l'Ouest, nous avons 6 pays, notamment le Bénin, le Burkina Faso, la Côte d'Ivoire, la Guinée, le Sénégal et le Niger. En Afrique centrale, nous avons également 6 pays, le Cameroun, le Tchad, le Congo, la RDC, le Gabon, et nous avons un pays en Afrique de l'Est qui est le Burundi. Suivant, please. Next, please. Donc, à la fin de notre intervention, le programme que nous mettons en œuvre aujourd'hui, il est de 12 mois, notamment de juillet 2020 à juin 2021. Il vise 4 objectifs. Nous espérons à terme avoir 4 effets qui vont matérialiser la réussite du projet. Le premier point, c'est que les efforts nationaux en termes de CRG sont soutenus et sont alignés dans les 12 pays francophones ciblés, que les capacités des communautés, des acteurs communautaires soient vraiment renforcées pour qu'ils puissent de manière stratégique contribuer à l'atteinte des engagements de la réunion de la déclaration politique de la réunion de haut niveau dans la région. Également, nous espérons ou bien nous visons que l'engagement des communautés affectées par la TB et des survivants soit plus renforcé pour que les barrières de genres et droits humains soient réduites dans la région afin de faciliter l'accès aux services pour toutes les personnes dans le besoin. Et le quatrième résultat, c'est un partenariat renforcé entre la société civile, les communautés affectées, les survivants, les directeurs des programmes nationaux et les parlementaires dans la région Afrique francophone. Next, please.
2 minutes, Bertram. We are running
les partenaires, comme je disais tantôt, nous avons en première position le caucus mondial, notamment le volet caucus francophone, qui travaille avec nous sur toutes ces étapes dont j'ai mentionné. Nous avons le programme mondial de l'OMS et le groupe spécial de la société civile de l'OMS. Nous avons le réseau des directeurs des programmes tuberculose en Afrique de l'Ouest et le réseau des directeurs des programmes TB en Afrique centrale. Je vous remercie.
Thank you very much, Bertrand. Yes, thank you very much, Bertrand, and thank you for at least trying to help us by putting the presentation in English, though we didn't hear most of the things that you said. And before we continue, just to ask Austin, so the translation is only from English to French, and there's no one translating from French to English, or what was the plan?
Not at all. It is translation being from English to French. People were complaining about a lot of interferences, so I thought that maybe it would be easier for you just to read his PowerPoint. I'm sorry.
Okay, I think the next one you do it, because some of the things he was explaining, we couldn't get it, but at least we got a bit of that. Thank you, Bertrand. So our next presentation is from Rosemary Mburu, who is the Executive Director from Waki Health from Kenya. I don't know if I've seen Rosemary on the list. I don't know who's maybe presenting on her behalf. Waki Health. Do we have Waki Health? I saw Nombasa. Are you the one presenting? Or we don't have a presentation from Waki Health?
Rosemary is joining soon.
Okay. So I think while we are waiting for Rosemary, who I think is on another call, could I have Ingrid Schumann, who is a project coordinator from TB Proof from South Africa, to give us a presentation. Then when Rosemary comes, maybe she could just alert us and then we can put her back on the rota. Ingrid, please, the floor is yours.
Rodrick, I think you have an Ingrid presentation, if you can.
Yes, I'm seeing Ingrid, but I think she's still muted. I don't know if she can unmute herself. Ingrid, you're on the line?
Joindre les histoires et la science. Utiliser ma voix pour éradiquer la TB. Renforcer les capacités des communes.
Ingrid, I'm not sure what's happening, but I'm seeing her. But I don't know, maybe she's moved off from the computer.
Does she have her presentation is on now? I think Rodrick is, Rodrick, the audio is not coming on.
Oh, okay. Oh, she recorded. Oh, okay. Maybe just you can sort out the technical issues and let us know. But I think while we're waiting for the technical issues to be sorted out, just to say that it's great to hear how from both presentations we can see how there's still support
Melinda Gates Foundation, Community Health Worker, TB
from everyone to support the survivor network. Do we have volume now?
The group Stop TB project builds on our work started in 2018 through the Bill and Melinda Gates Foundation Community Health Worker TB Champion project in Hammanskraal. We offer TB advocacy, communication, and media skills training workshops to community health workers to support them in their advocacy for policy implementation. We formed strong partnerships with representatives from Department of Health and TB-affected communities. Community health workers identified stigma as a barrier in the TB care cascade through using a card deck informed by principles of human-centered design, and they co-developed interactive theatre plays in partnership with a local television star to address stigma. This project aims to address TB stigma through a gender-responsive stigma reduction intervention and advocacy campaign based on the identified rather than the perceived need. In Q1, TB Proof appointed a core group to include patient advocates from TB Proof, researchers based at Harvard and Stellenbosch University, and representatives from the National TB Think Tank. A research protocol is being developed by the research team for submission for ethics approval at Stellenbosch University coming this week. In order to add to limited existing literature on TB and stigma, a formal scoping review on TB and stigma is also underway. A key stakeholder list with contact details was developed to ensure that representatives from affected communities and the Department of Health National TB Program were included in multi-stakeholder meetings to review the topic of stigma, TB care, and plans to validate Stop TB Partnership stigma assessment tools and to inform our protocol design. Community health workers reported that metaphors used by the community are descriptive words based on your physical appearance or illness symptoms. Some of the words included IZ3, meaning that a patient is HIV co-infected, or upelele, describing something that is wasting away or being finished. Community health workers highlighted that TB is not only limited to what people say, but extends to body language, how they look at you, moving away from where you are sitting, or refusing to use the same household items. Community health workers emphasize that the community mainly associated TB with HIV, informal settlement or overcrowded living conditions, alcohol abuse, poverty, poor living conditions, and witchcraft. Anticipated stigma was a concern to community health workers because in some cases, people didn't want to go to the clinic that is close to them for fear of being seen by people that they know. Community health workers reported that when they visit someone with TB, the patient will ask the community health worker not to wear their branded uniform, as they were worried about what others would say about them. They said that dots were stigmatizing, as people are already ashamed to go to the clinic. Reflections from the high-level key stakeholder meetings attending the inception meeting were focused on gender-specific barriers to care, which they addressed through men-only clinics in Khayelitsha, how patients are being treated at health facilities and by health workers, and a lack of resources causing patients to transfer to other clinics if they felt overlooked, or that health service providers are not being able to provide the care that they need. Stakeholders reported high levels of anticipated stigma at community level, and they recommended for stigma interventions to be placed at community level, since people are afraid to disclose their TB diagnosis to others for fear of stigmatization and the potential consequences it may have on their living and their working conditions. We are facing a challenge to get provincial approval to work in Gauteng province, as the Provincial Department of Health still needs to sign the Memorandum of Understanding. Our next steps include adaptation of data collection instruments and preparation for fieldwork, the fieldwork analysis and validation of the stigma assessment report based on analysis of data collected from the stigma assessments, empowering communities through dissemination of findings, development of a communication strategy and framework for developing TB stigma reduction interventions. Thank you.
Is that the end of the slides?
Yes.
All right. Okay. Thank you. We are sad that Ingrid could not join us, but at least we're able to go through our presentation. And I really liked where she talked about the anticipated stigma, which can really be problematic. I'm sure most of us have seen it now in the light of COVID, where people are really scared of the unknown and they don't even want to go and get screened or tested because of what people will say. So it's good to see that they're covering that. So I'm not sure if Rose is back. If she is not, then I'll invite Dr. Roland Igbignadu, sorry if I failed to pronounce it properly, who is the Executive Director of the Real Housing and Urban Development in Nigeria. Please, the floor is yours. You can tell us more about the organization and your presentation.
Hello, my name is Dr. Roland Igbignadu, the founder, Roland Igbignadu Real Foundation for Housing and Urban Development. I'm going to be sharing with us this morning one of the best practices and lessons learned on TB stigma assessment in urban slums in Lagos State, Nigeria. This assessment is being carried out by the CFCS grantee, the Bridge Health Development Center, and the partner in the consortium, the Roland Igbignadu Real Foundation for Housing and Urban Development. In Nigeria, the incidence of TB stigma, it's something that is continually becoming a concern. The highest amount of TB cases in Africa is seen in Nigeria. And this has given us a background to looking at this study and has necessitated 5 problem statements. The first is the fact that Lagos State has 8.4% of Nigeria's TB burden. And what we notice that as the TB incident drops, TB is becoming more and more concentrated in key and vulnerable groups. The CROG assessment recently done for Nigeria also reveals that stigma exists in different settings, and it impacts accessibility to TB services and adherence to treatment. In fact, the current COVID-19 is being perceived to worsen the TB stigma. Currently, with significant inroads made towards ending TB in Lagos State, the state does not yet have targeted actions for awareness and providing psychosocial support for those experiencing TB-related stigma. The fourth problem statement is the fact that even though Lagos is working with the Global Fund and combating stigma in urban slums, the levels of stigma in the different settings are not known, and it makes it impossible to track stigma performance indicators. Also, there is limited data, which is the final point, at the level of the national stigma policy, especially in the plan of the National Human Rights and Gender Plan 2021 to 2023. And so the work that we're doing, broadly around 3 objectives is aimed towards focusing on the problem statements that we have just identified. The first broad objective is to understand the level and dimensions of anticipated stigma, step stigma, enacted stigma, and observed stigma among people diagnosed with TB. The second broad objective is to develop a context-specific TB stigma reduction advocacy and communication toolkit that will help in addressing TB-related stigma, especially in the slums. The third broad objective is to understand to which extent are the laws and policies would harm or protect the people diagnosed with TB. And in making this happen, right from the onset, something that we identified was that we need to take stakeholders' engagement with high priority, utmost urgency, and seriousness. And as a result of this, we've broken down our stakeholders' engagement into about 5 or 6 buckets, starting with the very first one, which is the civil society organizations, where the DHDC and RIFOD comes into play. The stigma assessment and survey and the development of the specific intervention plan will be done by DHDC and RIFOD. Additionally, DHDC will provide some high-level commitment and buy-in at the national level, while RIFOD will be doing that at Lagos State, in addition to mapping the urban slums and regeneration. The second stakeholders group as the national and the state TB program stakeholders. Here we have engaged them, and the engagement is ongoing around approval of protocol, around permission to carry out surveys, around nominating members of the core group, and also helping in the stigma contest specific intervention communication plan. The third group are the respondents, and here we have the TB patients, the caregivers, the healthcare workers, the community stakeholders, and the legislators. What we have done here is to engage with the respondent, not just as study objects, but to hear their perspective and know exactly where it hurts, and them lending their voice to TB stigma. The legislators will help in providing data that will help us inform policy. So in speaking to the legislator, that's what we are looking at. Another critical set of stakeholders group is the core group and the multi-stakeholder group. Now, while the multi-stakeholder group will be responsible in validating the final report as we go on and in the coming days, the core group, our expert group, who will be helping and they started to provide input into the protocol and the study instruments. The last critical stakeholders that we have engaged are the CFCS focal person, the ART focal person, and the WASSE focal person. Of course, the CFCS focal person will be responsible in all our communications and feedback from DHDC and RIFOD, and also helping the overall guidance and project implementation. The art focal person is going to be helping with ensuring that the United Nations high-level meeting and commitment targets are met and fulfilled by some of the things that we'll be doing in this assessment, while the WASSE focal person will be helping in providing technical support in communication activities. In looking at the respondents group, what we decided to do was to take a community rights and gender approach to the selection of the respondents group. And what we have done is working with Lagos State government to identify 20 slums across 20 local governments in Lagos State. Another critical thing that we did in looking at the selection of respondents was to ensure that we are taking into cognizance the issue of gender to be able, so that we can speak to as much men as women. And so all through the people diagnosed with TB, their family members, the healthcare workers, the community leaders, and even the multi-stakeholder group, we have ensured that this approach is being enshrined in how they were selected. We can come back to that later in details if I have some time to look at that. Also, in terms of the respondent side, what we did is to ensure that we deployed the STOP TB segment assessment tools for the study, which has provided us a framework for what we are doing. And so from the people living with TB, the 425 people living with TB, to the family members, to the community members, even up to the DOT centers, the DOT centers, all of these have been done working with the Lagos State Tuberculosis Program and helping to ensure that the dimensioning of the 1,814 respondents follows the input of some of the work that they have also been doing. And this really it's brought us to a point where we've achieved certain things based on the best practices that we have employed. And to just run through that again, some of the things that have ensured that we are where we are today is the fact that right from the onset, critical stake engagement was a high priority for us. And so advocacy visit was paid to the team, to the chairman of the AIDS and TB and Malaria Control Committee at the National Assembly. And he's also helping to speak to the Lagos State House of Assembly Health Committee. We are working with the Ministry of Health, of course, through the Lagos State Tuberculosis and Leprosy Control Program, who has helped with mapping of the DOC centers. Also, through the Ministry of Health in Lagos State, the State Bureau of Statistics has also helped in mapping urban slums. We've gone ahead to share the study protocols. We've received input from the stakeholders. Now we're at the point where the pilot study is going to commence, and we have also identified the 3 local government areas where we will start. Another interesting thing in terms of what we have done that has helped us to achieve some result is ensuring that the core groups and multi-stakeholder groups formation had the input of the National TB Program and also the Lagos State TB Program. And like I mentioned before, we have ensured that gender representation was optimum across all levels. And as a result of that, we've gotten go-ahead from the state government, Lagos State government, and permission has been granted for the surveyors to visit all the DOT centers for stigma assessment. On our part, we have also signed a memorandum of understanding between the Debrecen Development Center and the Global Foundation for Housing and Urban Development. All relevant stakeholders have been met, and a lot of them have even promised technical assistance that will ensure project implementation. Celebrities and influencers have also been engaged. For example, one of the celebrities, Daniela Mokachi, the video that he did in flagging up our work has garnered close to about 15,000 views on RIFOD's handle on Facebook. And we have also created a campaign on Mass TB Stigma NG and NTB Stigma NG. And this is how we're going to be communicating a lot of the work and intervention that we'll be doing in this program. Having done all of this, we're not taking away the fact that there have also been a few challenges in terms of the work that we are engaged in. For example, currently there's a civil unrest in Lagos, and that is slowing things down at the moment. Not just at the civil unrest, it's in the whole country, but the core is at Lagos. Also, the Lagos State Ethics Committee sits once every month. So because we missed the previous month, we're having to wait for the new months to be able to get them to approve the protocol. And so that's where we are in terms of our experiences and what we have seen on this project. Because of time, I'll just wait and sit back and hope that there will be questions that will be asked in the detail in terms of how we are making this happen in Lagos State. Thank you very much.
Thank you very much, Dr. Roland. So like we said, in the interest of time, if you have any questions, please use the chat room, send your questions in the chat room, then and indicate clearly who you are directing the question to so that they can be picked up. So it was really great again to hear from your presentation, Dr. Roland, how you are looking at the different levels of stakeholders in the stigma work that you are doing, because stigma can be looked at a different way. So not just looking at the patients or the TB survivors, but also the way you've taken it at different levels, something that I really liked. And also the fact that you had gender representation across all levels. Again, that is helpful. As we know, in most cases, stigma has the face of a woman. So that was a great presentation. So just to find out if Rose Mburu, Madam Rose, are you back? Are you on? She's our last presenter. Numbasa, is Rose back, or are you presenting on her behalf? Any feedback from Waki Health? Numbasa or Rose? So I seek your guidance, Austin.
Carol, I think we can go on break now.
Oh, okay. All right. So maybe
I think it's supposed to be lunchtime. We don't want to eat into people's lunchtime, so that when we come back.
All right. Okay, then. No, just for me to say thank you very much to the presenters, especially looking at.
But Carol, we can't hear you. Sorry to interrupt you, Carol. I don't know if other colleagues can hear you. Personally, I can't hear you, Carol.
Oh, my mic is unmuted. I think Austin can hear me. I don't know who
I couldn't hear her. I couldn't hear her as well. This is Dr. Roland. I couldn't hear her at all.
Okay. If you can choose,
I hear very well.
Interpretation, English as your language, and then mute original audio. That will be easier.
Yeah, I think that's what I've done.
Online, so you can allow her to.
But can you hear me now? Because my mic is unmuted.
Yeah, so Chief, I can hear you, but I can't hear Carol. Is Carol inviting me to make a quick presentation?
Yes, it's inviting you to make a presentation. If you can share your screen.
Yeah, so I don't have PowerPoint. Thank you so much, colleagues. It's a pleasure to be here and to share with you the work that Waki Health is doing under the Challenge Facility for Civil Society. Many colleagues have spoken, and there are many intersections between what we are doing at the regional level and what colleagues are doing at the national level. For us as Waki Health, we are honored to partner with Stop TB Partnership and the other regional networks to support and facilitate regional advocacy. Together with ACT and also with the drafts in Francophone region as the regional partners. Our work mainly focuses on creating the political will that is needed at the regional level, using the regional political mechanisms such as the African Union and the other regional economic communities. First of all, for two things. One is to ensure that African governments keep the UN high-level meeting on TB, the targets and the commitments, as a priority. So our experience so far has been that we are implementing this project just at the time when COVID has hit. And one of the agendas we are advancing is that TB gains and TB programs and investments must be safeguarded even in the time of COVID. And within that, our conversation and the agenda we are advancing is to see how can African governments ensure that the political commitments and targets are met, even in the context of COVID. We know the report is out, and maybe some of us have interacted with that report, and we have seen that as we have a long way to go in terms of having our countries meet the targets as promised within that UN high-level meeting on TB. So that's the first approach, the political will to deliver on this. And the second approach is partnering with colleagues at the country level. We have 10 priority countries where we are having conversations with colleagues around the priority areas within their work and their country. For example, Nigeria is one of the priority countries that we are focusing on and we are partnering. So Dr. Roland in his presentation made mention of the TB assessment. So as Waki Health, we are coming in to partner with this piece of work around ensuring that the report from the TB assessment actually is presented to policymakers. While our partner in Nigeria is pushing that at the national level, we are supporting to push that through the regional mechanism, making sure that the messages that come out of there are heard by African Union member states, making sure that those messages are also heard by members of the Africa TB caucus. Other partnerships within this context include our partners in Botswana, who are doing an amazing work towards ensuring that a network of TB affected communities is established. So that's another area. And you then have countries like Eswatini that are working on raising awareness on community rights and gender. So within this piece of work, partnership at the country level is really perhaps the best practice and the lesson that we are learning, that basically we have to work together and it has to be country driven, and the process has to involve TB affected communities at the country level. So we are looking forward to seeing how it unfolds and to see how it contributes to the broader agenda of ensuring that we meet the TB global goals by 2030, and we ensure that this particular challenge we are facing right now does not distract us and that the gains are safeguarded. So, Carol, this is just a short overview of our work from a regional point of view and how it links with partners at the country level. Just very quick highlights. Thank you very much.
Thank you very much, Rose. At least we had all the presenters, and for me, I don't want to keep people away from their lunch, just to say thank you very much for all the great presentations. And also noting that we are all working the same line, looking after the affected communities and supporting the TB survivors. So for now, I think I'll hand you back over to Austin to give us the information for the next sessions and the next activity.
Thank you, Carol, for sharing this session, and thank you to all the presenters. You've done so well, and we've seen all you've been doing in the region, which is so good, and we hope you continue to move further in terms of making sure you achieve your targets as related to challenge facility, and also making sure that you engage partners at the country level. We'll be going for lunch now. Sorry for keeping you so long and also eating into your lunch time. Now I will be going for lunch. We still have our 40 minutes time for lunch. I hope that works well, so that we'll come back and have our 2 last sections for today. you all the participants, you've been great in terms of staying on for this. So we'll be going on break now, and we'll be back at why don't we just have a 30 minutes lunch? We can come back at 1, but I was suggesting 1:10 will be fine anyway, 40 minutes. So 1:10 we'll be back at 1:10 GMT time. That is what we are working on. So please let me not talk much again and eat into your lunch time again. Please have a great lunch. We'll be back. Some community organizations who also joined here, we are finding a way to get you to have some data, sharing that information as well, so that you can have something for your data connection. And thank you very much. And let's come back here at 1:10. Thank you.
I am the translator and I have an issue, please. I know that you are working on the schedule, but please, can you ask those who are having presentations to slow down a bit so that I can capture the idea and make sure that some people are having the main ideas? Please. Yes, you have a lot. No, that's my main issue. Yes, thank you very much.
Welcome back, colleagues. Good afternoon, good morning, depending on where you are. This is Rosemary Mboro with Waki Health. I'm going to be your moderator for this session that is just starting. We will start exactly at 10 past the hour. I just wanted to check my audio and to check that the translators can get me.
Hi, Mburu. I am also checking my microphone if it's working. How have you been?
Hello, Austin. Oh, we can hear. Okay, so if colleagues can hear me, thank you so much. Let me know if there's an issue with me coming through for the translators. So this is session 3, and we are going to continue learning from our experiences. We are going to have country level presentations, and the purpose of this session is very similar to the one we just had before lunch. We are aiming at understanding key engagement opportunities and challenges for civil society and community groups in challenge facility for civil society. This is a very brief segment. We have allocated only 20 minutes to this segment. It would be great if we can even save more time here without compromising the quality of what we want to share with colleagues. We will have 3 presentations. One is from our partner colleagues in Mozambique, Amino, and Moses is going to make that presentation. We have a presentation from DRC, Damien, Maxim Lunga will make that presentation, and we have a presentation from Nigeria, from the Jana Foundation, and Dr. John Stephen is going to make that presentation via a pre-recorded video. So colleagues, join me now as we start. We will be very quick. We have less than 20 minutes to hear the presentations and to raise questions or input. For the presenters, kindly, if you could give us the big highlights of your presentations, that would be very much welcome and helpful, given that we are now racing against the clock. Welcome. So colleagues, I now want to invite our colleague from Mozambique, Moses. Kindly share with us your presentation. So Moses, are you here? Let me just do a quick check.
Rosemary, I'm not seeing Moses online, but we have his presentation. I think what we can do is to go on with Maxim and Dr. John Stephen. Probably he will join while the other presentations are happening.
All right, is Maxim online?
Yes, Olive, I'm online.
Awesome. This is Olive's sister, Rosemary. Okay, so we will have your presentation, Maxim, and then we will follow.
Okay, Rose.
We will have.
You can share your screen if you want to.
Yeah, and then we will have a video from Dr. John. If Moses will be online, then we will quickly move into his presentation. So Maxim, you have the floor, please.
Thank you. I present in French. Merci beaucoup pour l'opportunité que vous m'accordez pour échanger avec vous sur l'évaluation RDC en 2018. Je suis Maxime Lunga, survivant de la tuberculose et responsable du Club des Amis d'Amiens.
I am Maxime Lumba.
Je partage avec vous mon écran.
I'm sharing my screen with you.
Est-ce que vous voyez mon écran?
Oui, maintenant.
Oui, Maxime, nous voyons ton écran.
Bien. Donc, la République démocratique du Congo, c'est l'un des pays à forte charge de la tuberculose dans le monde.
It's one of the highest country burden TB in the world. Hello? Hello?
Mais aussi les indicateurs en rapport avec la connaissance des statuts sérologiques des personnes pour la tuberculose pédiatrique et la tuberculose pharmacorésistance restent faibles.
The indicators due in link with the cognizance of the statistic to multi-resistance drug TB is very low.
La RDC compte plus de 40% des personnes manquantes atteintes de la tuberculose.
RDC has more than 40% of people missing.
Alors, la mise en œuvre de la riposte de la tuberculose en RDC ne tient pas compte systématiquement des obstacles des droits humains et des genres qui exacerbent la vulnérabilité à la tuberculose et qui entravent l'accès aux services de santé de qualité.
The implementation of the TB response in RDC does not take into consideration the gender issue and the human rights issue. Therefore, it is completely difficult. It is really difficult for us to get to the objective that we want to attain.
Alors, pour adresser ces problèmes, il faut premièrement identifier les obstacles. C'est ce qu'on a fait avec l'évaluation CRG.
We had to
avec
identify
comme objectif général,
challenges.
Il faut effectuer.
This is an
avec
approach
objectif général d'évaluer les
human rights based.
aspects juridiques inhérents à la tuberculose, ainsi que d'identifier
The main objective being to assess
et de ressortir
the juridical aspect or the legal aspects due to TB and to identify key populations to bring out their specificity in regard of the fight against TB.
À l'issue de cette évaluation, donc on peut passer à l'étape 2 qui est de surmonter les obstacles. Cela doit être coulé sur un plan d'action opérationnel CRJ qui s'aligne dans le plan stratégique TB pays. C'est ce que nous avons fait maintenant.
So
Alors,
the second step was how to overcome those challenges. So we had a policy that is aligned on the CRG objectives in the level of the country. That is what we are doing now.
Notre évaluation CRJ s'est portée sur 4
Our
objectifs
CRG
spécifiques.
objectives.
Nous avons premièrement examiné le cadre politique et juridique de la riposte à la tuberculose, qui nous a permis d'évaluer
So we
sur
had
le
4
terrain.
specific objects.
Voilà,
So
donc le niveau.
first thing, we had to look into the political and the juridical framework in the response of TB in RDC. So this was based on conventions of international directions and regional and sub-regional directives. And
Déterminer
secondly,
quels sous-groupes
we had to bring out the subgroups of key population that should be considered
populations clés devaient
considered
être
as
considérées pour être
vulnerable
prises en compte dans la riposte,
and not well deserved.
évaluer les façons dont les aspects liés au genre impactent sur la vulnérabilité à l'infection, à l'accès aux services et aux résultats de traitement de la tuberculose, ainsi d'élaborer les recommandations pour surmonter ces obstacles.
We had to assess the way that the gender issue has an impact of the vulnerability of people infected with TB and their access to services or health facilities and their access also to treatment in DRC, sorry. So finally, we had to elaborate recommendation to overcome those challenges linked or due to the issues and key populations in the objective of our response to
nécessite une approche multipartite. L'évaluation CRJ nécessite une approche multipartite.
Multi-approach strategy.
Elle est pertinente si elle est conduite par la communauté, mais elle est significative quand elle est portée par le ministère de la Santé.
If it is community-led, and we also need the Ministry of Health to put
Voilà pourquoi nous avons fait porter notre évaluation au niveau du secrétariat à la santé sous les orientations.
That's why we put this assessment to the Secretary General of Health Ministry.
Et nous avons tenu la CRJ de juillet jusqu'en décembre 2018.
This CRJ held from July to December 2018.
Pour identifier les obstacles, l'étape la plus importante, c'est la collecte des données.
To assess, to identify challenges, the most important step will be the collection of data.
Que nous avons réparti en deux temps, la revue documentaire et la descente sur terrain.
We did it in two steps. First one was the documentary review, and then the second one was the document we used.
La revue documentaire nous a permis de consulter qu'au niveau international en termes de...
So the documentary review helped us to collect data on existing information based on national documents or international documents in terms of human rights, stigma and key populations.
Et au niveau de terrain,
on the field, hello. Hello.
We can't hear Maxime.
Hello.
Not sure if he's still on.
Hello.
On mener des interviews avec les personnes qui travaillent pour ou à côté des malades de la tuberculose et aussi des interviews à...
Hello. Okay, from his PowerPoint, we can see that he named some few documents, and then he said they had an interview with key informants, and then they had thorough interviews with key populations. So they had also what they call focus group discussions. Those are all the things, the tools they use to collect data.
Hello. Hello.
Hello. Hello.
Hi, Rosamar, you hear me?
Yes, we can hear
you. But the connection is so unstable.
You hear me?
Yes, loud and clear.
Oh, hello, I hear you. You don't hear me? But my connection is very good today. Ce que nous avons pu avoir, c'est que la tuberculose est profondément enracinée dans la pauvreté en RDC.
Okay, so these are the major remarks that we did, that in DRC, TB is profoundly linked to poverty. Judicial barriers and political, sanitary system, the health system, the community involvement,
Donc,
as
les
well
obstacles
as
qui exacerbent la vulnérabilité à la tuberculose et qui empêchent l'accès aux soins sont d'ordre juridique, de politique sanitaire,
to healthcare,
système de santé, de l'engagement communautaire et des déterminants sociaux. Ce sont ces aspects-là qui ont constitué aussi l'analyse pour sortir les recommandations. Et donc, pour s'attaquer à ces obstacles à l'accès,
for those who are considered as key population and vulnerable,
qui portent en tête aux droits de la santé, il y a nécessité de droits de l'homme face à la tuberculose. Voici les obstacles de manière synthétique, mais un peu en détail.
Sorry, Moses, to cut you mid
So these are
presentation.
the challenges.
Just make it faster so that you can wind up now,
First of
please.
all is legal environment. And the second challenge is this health system, that is the political
Nous avons constaté
environment.
que les législateurs, les décideurs ne savent pas que la
Information
tuberculose est une
systems of
question
data, information, the service offers,
Au
and
niveau des
then the
systèmes de
community
santé, nous
involvement.
avons
Those
5
are what we
problèmes
can
que
play
nous
the
avons
soup
relevés
of
en termes
the
d'environnement
health
politique.
system, those
La directive
problems.
nationale qui est
For the
dictée par
political
le parti 5
environment,
en RDC ne dit
national policy
pas de
don't have a
instructions claires sur
diagnosis,
les diagnostics,
but
à
just put
part
in
les
place.
traitements qui est clairement dit gratuit. Au niveau des systèmes d'information
Okay, so
des
the
données,
treatment is
les
aimed
fardeaux de
to
la
be free, but there's no diagnosis.
tuberculose
And the other hindrance is that the burden of TB is not known
parmi les
among the
populations clés,
population.
ces populations par manque des évidences. En termes
So
européens, n'arrivent
Maxime,
pas et ne touchent pas.
Information-wise,
Yeah.
the key
Maxime,
information
sorry,
do
I'm
not reach
cutting
the
you
key
mid
population.
presentation. I don't know how many more slides you have, but if you could summarize, that would help a lot. Sorry to cut you mid presentation, please.
Give me 2 minutes.
Alors, elle souhaiterait que vous fassiez juste un bref résumé parce que le temps imparti est court.
Voilà, en résumé, c'est que je dis ceci que des gens qui vont adresser ces obstacles et qui ont été même coulés dans le plan stratégique national. Donc,
Hello. Hello.
L'évaluation CRJ qui ont renseigné le
CRJ
plan
assessment. Hello.
Hello, go on.
Hello.
stratégique national.
Hello?
Yes, hello. I'm not getting him at all.
You're not getting the presenter?
Yes, I'm not getting Maxime, just bit by bit.
His line is broken up.
Au plan stratégique national de la tuberculose en RDC. Alors, à partir de ces CRJ, l'évaluation CRJ, la RDC dispose aujourd'hui une planification programmatique adressant les problèmes des obstacles liés aux droits humains.
So sorry. So I'm struggling to hear Maxime, but Maxime, we need to close you now. Maxime, I can't hear you, but also we are running very, very much over time. So if you could perhaps just take 1 minute to wrap it up.
Maxime, est-ce que vous pouvez résumer votre travail en 1 minute? C'est vrai qu'on a des problèmes d'écoute. Moi, particulièrement, je vous entends pas. Je ne sais pas si c'est une connexion. Je vous entends pas. Par contre, les autres participants vont entendre. Donc, vous avez 1 minute pour essayer d'aller juste à l'essentiel. Allô?
All right, so I don't know if I've lost Maxime, but kindly allow me to move to the next presenter. And these presentations will also be made available. Thank you so much, Maxime, for reminding us the need to ensure that key affected populations and communities, and the fact that we cannot win any global health response without communities, without addressing stigma, without addressing gender barriers and human rights barriers. So now, allow me to invite the presentation from Nigeria. Jana Foundation, Dr. Stephen, I understand it's a video, it's a pre-recorded presentation. Kindly, Rodrick or Austin, share the video with us.
I wish to thank the ECT for this opportunity to share our experience on community-led approaches to reaching underserved key populations in Nigeria. It's known that there are over 315,000 cases in Nigeria, and a high proportion of these cases are found among key populations. Research has also shown that there's high rate of TB among this population, mainly due to poor access, low level of awareness, poor nutrition, low vaccination coverage, among other factors. Jana Health Foundation is targeting refugees with this current challenge facility project of Round 9. The aim of the project is to expand TB services in an innovative and highly collaborative manner, including involvement of key stakeholders to ensure ownership and sustainability. These communities face various challenges with respect to availability. Formal health services are hardly available, and because of this, these communities have preference for alternative care. Of course, they also patronize pages. So you can see that the right to availability of health services and the right to information is an issue. With respect to accessibility, the communities are located in a room. They have very borrowed networks, and for those that try to access formal health services, they spend a long time traveling. So the right to access of health services is an issue. With respect to acceptability, the low level of awareness services, the misconceptions that drives these particular communities, and language barrier, also exploitation by healthcare workers whenever they have health services are serious issues. They have they lose resources for utility costs because they are mainly farmers, so they have to leave the farm to access health services. Also, the fear of the unknown. So looking at this, the right to participation, right to privacy, right to non-discrimination are issues. We have quality problems also. Delays, especially for women and girls at the health facility, and the high turnaround time when the samples are submitted. So this takes time. So what strategies, what interventions do we bring to this particular new project of refugees? First, we are leveraging a multi-sectoral approach from various projects we have implemented in the past We have systematic active TB screening as the key component of this particular intervention, where we deploy a house-to-house screening in communities and a 10-to-10 mass screening in communities and urban areas where suitable target places. We also bring strategies that will address institutional constraints, for example, social correction and transportation of lives for diagnosis, result treatment, linkage to care, and covering school. These interventions are punctuated by contact investigations and we have conducted various advocacies in the past in our other projects in our own way, but now we have contacted the Africa Regional Advocacy Organization to support us by coming up with our advocacy toolkit that will help us make our advocacy more impactful. Collaboration of communities nested within this intervention, and we are collaborating with ECT to actualize this. What are our achievements? Over the years, we have successfully engaged key stakeholders with a lot of this experience.
The presentation is not loud, it's very, very low.
So Rodrick, is there a way to turn it up a bit? The volume is at 100%.
That's the maximum.
66 TB cases, which is 180 des personnes déplacées internes, infectées par le TB. Nous avons pu augmenter aussi le nombre de notifications de cas de TB, c'est-à-dire nous avons pu avoir 266.
Can I share my screen and take it up from here?
Ensuite, nous avons 13%, c'est-à-dire 17 qui sont des enfants.
45% étaient des femmes ou sont des femmes. Alors, nous avons
Let me share my screen and take it up from here.
Pour voir
Okay, can you hear me now?
Better.
Can you hear me? Good. So the key strategies are as follows. First,
alors, nous revenons sur les
we
stratégies
leverage on
marquantes, les
multi-sectoral
stratégies
approach
clés.
from previous projects that we implemented in collaboration
Alors,
with ministries, departments, and agencies of
nous
government.
avons pu
And
ainsi
key in
mettre
this
sur pied une
intervention is
approche
systematic
multisectorielle
active
qui
TB
était basée
screening,
d'ailleurs sur
where
des
we are
projets
using
passés.
a house-to-house in community,
Ensuite, nous
and a
avons
10 approach in camps, also mass
l'examen
screening on
systématique et
market days
actif.
and also in communities. So the strategies that we
Ensuite,
also
nous
built to
avons
address
des
institutional constraints is like, for example, sputum collection and transportation. We all know that sputum samples were collected usually at facilities, but we made sure that our volunteers are going to be trained
Alors,
in
pour
this
contourner
So Rodrick, we
les
can
contraintes
no longer
institutionnelles,
hear
nous
any
avons
sound
pu
from this presentation. Maybe if you could quickly go through the slides, yeah. So we can screen quickly and go to the next slide.
Okay. Let me go to the achievements. We successfully engaged stakeholders in the past, and that led to improved government commitment in our intervention,
Alors, nous avons
which has
pu
made results
amener à notre bord des acteurs
very,
majoritaires, y compris le
impactful in our
gouvernement,
community.
avec
We have
succès dans notre lutte.
successfully
Nous avons
improved
amélioré les capacités
capacity
des
of the
personnes nomades
communities
et des
within which
déplacés
we
internes,
implemented
y compris les
activities.
femmes.
For example, the
Ensuite, nous
nomadic
avons pu
communities that
améliorer
we
les
work
cas de
with are
notification de
capable of
TB,
identifying
c'est-à-dire que,
presumptive TB
par
cases
exemple,
and referring them
266
in
cas
after the
venaient des
intervention.
écoles
Okay,
nomades.
next slide, please.
Alors,
Communities.
13% étaient des
And then
enfants,
we have
45% étaient des femmes,
case
c'est-à-dire
finding also
118.
in all
Alors,
the
nous
areas
avons pu
that we have
disséminer
implemented,
aussi les
and
résultats
all
des
the
projets à
strategies
tous les
bring it
niveaux,
now
de la
to
communauté
this
jusqu'au
particular
niveau
current
international. Alors, nous avons aussi pu
and now
inclure
we have also a scale-up
l'intervention
of the previous
TB pour
interventions
NSP
in
et
by the
d'améliorer
Global
le
Fund
niveau
to 3
aussi
states from
dans
just
3
one state
États.
intervention, and this is what we hope to achieve with this refugee intervention. And let me go to the last slide.
Alors, le dernier, on avait les défis et
We
puis les
don't have an
leçons
appropriate SOP
acquises.
at the
Alors, on
national
n'avait
level,
pas,
so we are cashing on our
on n'avait
experience
pas des
with the
lignes ou
engagement of key
une
populations
guidance
all around
appropriée.
the particular
Alors, la
intervention.
leçon, c'est
And
que
a lot
les
has been
leaders
said
communautaires,
about
l'engagement
challenges
des
of
leaders
engaging community.
communautaires, il
Strategic
faut
engagement of
l'engagement des
stakeholders is
leaders
key to the
communautaires.
success of this particular
Alors,
intervention,
le
and we are mindful
processus
of that.
d'engagement aussi est
Topography had to reach
lent,
area.
il est
This is the
faible.
location of the
Alors,
refugee. But
comme
we are
leçon,
already
nous devons
experienced
utiliser
in
la
this
jeunesse
particular
nomade
area,
comme
and we've already
volontaire.
started engaging the
Et pour
refugees
cela, il faut renforcer les
appropriate
capacités de la
We
communauté.
have
Alors,
inadequate
troisième
access to
difficulté,
expert
ce sont les
equipment
difficultés
because
d'ordre
there's only one
topographique, c'est-à-dire
equipment right now
difficiles d'accès.
to target population.
Alors,
Thank you,
nous
Rodrick.
devons, comme
Maybe we could
leçon,
quickly go
continuer
through
de
the
plaidoyer
last two.
pour
Barrier is also
des
a problem, but we are
plaidoyer
engaging
stratégiques
volunteers
et
from the
partager
refugee.
les
About
résultats.
80%
Et
of our
enfin,
volunteers are registered
ensuite,
health,
nous
so
avons
that
un
will
mauvais accès
mitigate
à
against this problem.
l'équipement Gen
And
Expert.
of course, traditional
Alors,
healers are playing a key role in service
nous avons
delivery
aussi
in
la
this
barrière
particular
de la langue.
community. But
Et
we are raising
enfin,
awareness
nous
as
avons
to how
Rodrick, I
les
wonder
soins
if you could
alternatifs,
just
c'est-à-dire
show us the
précisément
next two slides. If you could just click,
les
we just take
guérisseurs.
a look, and the
Ça,
following
ce sont les
slide,
challenges. De l'autre côté,
and
on a
then
pu amener à notre
last
can
two
go
bord,
to the
on a
next one.
pu
Yeah.
pictures from
les programmes étatiques de la lutte contre la
All
tuberculose
right, this is
dans
Victoria,
notre
and the next one is
réponse.
Victoria. So thank you so much. We want to thank Dr. John Stephen from Jana Health Foundation for recording this presentation, even in his absentia, and ensuring that we get a view of what the work he's doing and his team is about. And really, it's about engaging communities. I've seen from the best practices and lesson learned, talking about working with young people, so youth engagement, and especially when they also get to learn, and you also use that as a pathway to strengthen their capacity in terms of advocacy. And so I will move quickly to the next presentation if it's there. I do not know if our colleague from Mozambique is here. If Moses, you're here, kindly we request you to just give us the key highlights of what your presentation is about, because we need to be closing this session, after which I'll invite Batra to take us very quickly through the next session, which is around regional advocacy priorities including UN high-level targets, UHC activism, and empowerment. So before I call upon Bertrand and hand this over to him, Moses, are you here?
I can see that Moses is connected. Moses, please take up the floor.
Not supposed to lose.
Hi, Olive.
And so Moses, if you could just give us a quick highlight without going through all the slides.
C'est qu'on ne peut pas aller tout au long du PowerPoint. On veut juste les idées principales.
Really because of time constraints. Welcome, Moses.
Parce que nous avons des contraintes de temps. Donc, juste les idées principales.
Thank you very much. Actually, we are going right through.
Choose English under the interpretation. I can see that you're talking, but we can't hear you. Choose English under the interpretation and mute original audio, please.
Key successes that have been registered in the implementation of this CRG. Oh, okay, that's fine. Okay. I was just saying that, okay, we have been one of the piloters of the CRG assessment.
Les organisations de communauté civile et l'engagement des communautés dans les régions, les leçons apprises et les opportunités pour le futur. Voilà le thème.
No, I know. Not today. I just want to let you know that.
And actually, what my presentation is.
Okay.
What my presentation is bringing have been registered in the implementation of this. So, the first 3 slides are.
Les 3 premiers tableaux
are talking about launching the program. Can I continue?
Parle de la mise en œuvre ou de l'inauguration.
If you are not speaking, please, can you mute your microphone if you are not speaking? There's a lot of noise, please.
I was just explaining. So, there was this interruption in terms of call. So I was.
Hello.
Wow. Hello.
Okay, I'm hearing you.
Hi, Moses. We can hear you. We can hear you.
It is clearer now. Mm-hmm.
Okay, so I was briefly saying that we were the first to conduct the CRG assessment in Mozambique, and
nous étions les premiers à conduire l'évaluation CRG.
We want to bring the key that have been registered. Now, the first 3 slides in the presentation are showing the launch of the project meetings that took place, the political, which is from the ministry, from the provincial directorate,
l'apport des politiciens, c'est-à-dire des ministres jusqu'aux délégués professionnels.
Looking at what were the main objectives of the project, there were suggestions that did not touch the main of the project.
L'objectif principal du projet,
but they have helped to bring the project to the furthest areas where are the hard-reach areas.
C'était d'amener ces initiatives dans les régions les plus éloignées
down to the affected communities on TB.
Pour que nous puissions toucher les personnes, les communautés des personnes affectées.
You will start understanding that the project has been welcomed from the district and to the community leaders level.
par les
And
leaders
we
de
started
communauté.
Selecting the activists that would
Nous avons choisi des
implement the
activistes
project,
pour mettre en œuvre le projet.
them already, and now they are all this week they are presenting the credentials so that from next week they start to address the messages on stigma, discrimination, and the rights of the people affected with TB.
Sur la stigmatisation que
Now,
subissent les personnes affectées par la tuberculose.
The challenges that we are facing in rich areas
que nous
to get
avons
there,
dans ce domaine,
it is not easy to conduct.
C'est pas facile de combattre.
It is not easy to conduct it's not easy to conduct the monitoring, the evaluation. Now we have changed the proceedings in terms of looking at what had been designed in the. Then we are now capacitating the coordinators, the local coordinators, so that they can conduct the monitoring project
pour qu'ils puissent conduire le monitoring local.
So that we keep the communication following through on the project. Another issue that is coming in
un suivi communicationnel tout au long du projet.
Services to the vulnerable population in hard to reach, the road infrastructures in the target communities is very impossible.
Alors, pour ce qui est d'atteindre les populations cibles, alors l'autre difficulté aussi, c'est l'état de route qui rend pratiquement impossible l'accès à ces populations qui sont affectées.
Due to the COVID-19, these communities, to these communities where the project is implemented are funding the World Health Organization guidelines and the actions.
Alors, à cause du
COVID-19, and
les
they are necessary to
les
slow down and advancing COVID-19, meaning
ces projets sont implantés.
There is a need to pass always messages in the prevention of the COVID-19, because people, although we say prevention, every day, it is very difficult at the scattered communities to find them wearing the masks, always washing hands and keeping the prevention methods. So that to redouble efforts, the message for TB prevention and COVID-19 prevention can rest at the community forever. This is what in summary I can bring to share in the presentation. Thank you very much.
Merci beaucoup.
Thank you so much. That was fantastic and very much to the point. I want to thank you for sharing with us your thoughts. For me, what stands out very much from all these presentations is the fact that any global health response is going to be won or lost at the community level. That is true for COVID-19. That is true for TB. And so I think as we move forward, for me, one of the biggest key asks or advocacy messages based on what we have heard from colleagues is that the fantastic work that communities and civil society are doing at the country level need to be supported, which is why this session on challenge facility for civil society was very important, to see how such kind of programs can continue to be supported and how civil society can continue to be involved in a meaningful way. It is the same for the challenge facility for civil society. We need it resourced. It is the same for community rights and gender initiative at the Global Fund. We need it and we need it resourced. And you could say the same about the other initiatives, including missing people initiative, between the Global Fund and Stop TB partnership. So I think this has really brought forward the need for us to continue with the work
Ceci a fait
around ensuring that the national programs are reflective of gender, human rights, and community responses. I want to thank you very much and to say that even though it was a rushed conversation, there was very rich input that came out of what the amazing work of civil society and communities is at the national level. Allow me to quickly hand us over to Batra Kompa, who is going to moderate for us the next segment, which is looking at regional advocacy priorities, including UN high-level meeting targets. On the chat group, I did see one comment from Sierra Leone, Reverend Paul of CISMAT. Your comment is noted and we'll forward it to the Secretariat to see if that is possible for tomorrow. CISMAT was asking to be given an opportunity to share their experiences from Sierra Leone. So I think the Secretariat and organizers will need to consider that. Thank you very much. Over to you, Bertrand.
Thank you.
Bertrand, sorry, before you start, I just want to ask everyone to mute their microphone. If you're not speaking, please mute your microphone so that we can reduce the noise that is conflicting with the speakers when they're speaking. And the translator needs to also have a very good audience so that you can be able to speak to the English. Thank you. So Bertrand, please, you have the floor to chair this section. Thank you.
Thank you, Chief. Thank you, Rosemary. This is really amazing what you are doing in Africa. Bienvenue à tout le monde.
Petra, it's very low. We don't understand you.
Bienvenue à tout le monde sur cette 4e session où nous allons discuter du plaidoyer régional, y compris les cibles de la réunion de haut niveau, la couverture santé universelle, l'activisme et l'autonomisation. Dans ce contexte, nous allons suivre plusieurs expériences, notamment l'expérience de GFAM. Nous allons suivre l'expérience de la délégation des communautés au conseil d'administration du Fonds mondial et de Stop TB. Nous allons suivre nos amis de Global Caucus et nous allons également suivre une présentation de l'Union. Donc, nous avons 5 présentations au total. Les participants, les panélistes, ils vont réviser les progrès et les défis réalisés pour faire avancer les droits de l'homme et le genre dans les investissements ciblés du Fonds mondial en faveur des ados, des populations clés et les personnes manquant sur la TB. Donc, nous avons très peu de temps pour cette session, 30 minutes, dont je vais donner à chaque 5 minutes avec une marge de 2 minutes. Malheureusement, nous ne pourrons pas recevoir les questions ici, donc je vous encourage à poser vos questions sur le chat. Notre première intervenante, c'est le docteur Edmund Rita de l'USAID, conseiller technique sur la tuberculose à la division TB de USAID. Please, Dr. Ruta, you have the floor. 5 minutes, please. Dr. Edmund, you have the floor.
Hello.
Yeah, please go ahead. Yes, go ahead, please. You have 5 minutes.
Edmund is speaking, but I'm not sure we can hear him. If you can unmute your mic and choose English if you're going to present.
Better?
Yes, I think it's better.
Can you hear me now?
Yes, I can actually hear you now.
Okay, good. All right, so thank you. Thank you for the opportunity and thank you for inviting USAID, my name is Edmund Root. I work with USAID, supporting some of the program in the region and elsewhere. And as I said, I'm going to build up on what Sherry presented on the TB accelerator. So just not to repeat, but just highlighting a few things. There are 7 components within the TB accelerator, which is our new model for our TB programs around the world. And I think one of the component which is relevant for this meeting and for this group is the engagement or direct funding of the local organization, the one we call TB loans. So I think one of the most interesting thing that has come out of that effort, which we started last year, is some of the recipient of this direct award in the countries that we were working were part of the former TB Reach grants, or they were part of the sub-grantee within the other USAID program and projects. So why that is important? I think one of the discussion I had this morning and today is this capacity building for local organization, for civil society organization, so they had the ability to, grant management, proposal writing, and I think we've seen that. We've seen that some of those recipients, some of the direct recipients we have right now under TB Accelerator were previously under TB Reach or some other funding mechanism. So I think any opportunity that will come with the work that you guys are doing, whether you are, part of the consortium or you're part of any project, I think is really, really important because that builds the capacity and I think will allow the organization to be recipient in the future for direct funding. So we have seen quite a few of the recipients that we currently have. Some are patient organization. So I think for us, it has been a very good, and we look at this work as a very critical for the capacity in the country, but I think in the future, if we have the opportunity, we can partner the same organization. So I wanted to say that very upfront. The second thing I wanted to say, I think the work you are doing and the training that is coming on day 3 for me is very, very important. You are the voice on the ground, and as much as we learn, we know so much about the statistics, the report that we received from the national program and everybody else. But I think it's the stories from the patient, their experience, their success, their struggle. I think those are the stories that we need to continue hearing. And as long as you bring them up to the national level, you bring to everyone, to the partner, those are very important stories that we want to hear. Numbers have to be attached to the faces, to people's struggle, to people's success. And so I think if you can do that, if you can continue doing that, please know that we pay attention to those stories. We pay attention to those success stories and the difficult and the struggle. And I think that's very, very important in the current environment where there are some limitation in terms of access. There's a lot of apprehension around people who are suffering to access service for, either being stigmatized for COVID or for other things. We know TB stigma continue to exist. So I think as much as you can raise that voice, you can continue to bring some of those limitations in terms of people accessing service, in terms of people getting quality service. I think we want to hear those stories. My appeal very, very strongly, everybody speak about COVID and what it has done to TB progress, so I'm not going to repeat with that. But I think I also see the opportunity for most of you who are working on the ground, the kind of work you've been doing to address stigma. Stigma for TB, some of you have worked on stigma for HIV. Please bring those same experience, the same lesson to bear on the stigma associated with COVID and TB. It is going to affect TB negatively, as we have heard, because everybody will think every cough is a COVID and vice versa, and we may be able missing the people we want to identify. So all the work and the experience we have done, if there's any innovation that we can do to forcefully address stigma at the community level so that we don't exacerbate what is already there for TB patients, that will be very, very important going forward. I think in contributing to the, to the surge of campaign, to everything that we need to do, to all reprogramming, some of the catch-up plan that I think colleagues have spoke to, make sure that you bring that to the table as well. One of the things that I was very pleased to hear, and I know it's going to be part of the training going forward, is the tools that you already have in place, the tools to assess stigma, and some of you presented some of the work you've done, the tool to address once you've done those assessments, how do you carry, how do you use the result from this assessment to actually implement? So anything you can continue to do in that space, that would be very, very important. I was, as you Stop TB partnership was presenting, Dr. Tan, I learned of this one, the app. I don't know how widely applied it is in many of our program, but it sounded to me that has a lot of component that will be really useful to expand, scale up, but also give it to a wide range of organizations and the community, so that we get that's exactly, as I said, the what is happening on the community, the data, the voices, and I think we can use it to improve our program. My last comment is to just to thank you for the opportunity to participate, but I think as we look forward to doing a lot more in this area, I am more than happy to continue to. I've worked with some of the organizations I think that are in this meeting, but I think from USAID, we value this work and the work you're doing on the ground. We'll support it to the best of our ability. And if there's anything that you like to learn more about the program that we are supporting in your country or any other country, please be free to reach to us, and we're happy to provide us and share as much information as we can. So thank you so much, and I will end up here.
Excellent, Dr. Edmond. So you still have 1 minute. I will give you 1 minute at the end of the presentation, because I have so many questions to you. Maybe you can still prepare for the question in terms of the engagement of TB Accelerator in the Francophone Africa region. Maybe you can prepare, and then last, I will give you 1 minute after the last presenter. Now I'm happy to welcome one of my best friends, Rosemary, on her capacity of GFAN Executive Coordinator for Anglophone Africa. So Rosemary, you have the floor for 5 minutes, please.
Thank you so much. I had my name mentioned, but I didn't have the English translation, so I'm assuming it's my turn now.
Yes, actually you have 4 minutes.
Oh, thank you so much.
Welcome.
Okay. So I'm here to very quickly and briefly speak about the Global Fund Advocates Network. What Waki Health is the Secretariat of GFAN Africa. And in terms of the conversation we are having here today, one of the key priority advocacy work and messages at the moment is to ensure that the gains we have made on TB, HIV, and malaria are not lost during COVID-19. And we know that for us to achieve that, we need additional domestic and international funding. At the moment, from a GFAN perspective, with the Global Fund work, we do know that the Global Fund's COVID-19 recovery mechanism needs to be fully funded. So right now we are involved in the work around ensuring that we get so that will ensure that we continue to scale up country responses on COVID-19, but also to mitigate the impact on HIV, TB, and malaria. And at the same time, we are engaged on the ACT Accelerator, the ACT arm, which is access to COVID-19 technologies. And within that, as you might know, there are 4 streams of work. You have the work on diagnostics, you have the work on therapeutics, you have the work on vaccines, and you also have the work on health systems connector. And then across all that, you have access and allocation work streams. And I recognize this is perhaps a lot of information to give in such a simplistic way, and perhaps we will have to find a time for us to actually sit and unpack the act up. But what I wanted to say for this, yeah, I think what is important to mention now is that there's a resource need which will go into ensuring that we scale up screening of COVID-19, contact tracing, and access to vaccines once they are available, and also yeah, once we have a vaccine. But also that work is important for us as civil society and communities, because we must ensure that our voice is part of the discussions that are happening at the ACT Accelerator level. To ensure that the products, and whether it's for vaccine, whether it's for therapeutics, or whether it is around diagnostics, are accessible by anyone, anywhere in the world where they need it. So it's an issue of equity.
Rosemary?
Yeah, we will send a presentation on the ACT Accelerator and also on the work we are doing on GFAN Africa in terms of priorities for advocacy. Thank you, Deborah.
Thank you so much, Rosemary. Thank you so much for this wonderful presentation and comment. Yeah, actually, we have Deborah Ogoshe, who is the next presenter. Deborah is the regional coordinator for the Global TB Caucus. She is the regional coordinator for Africa, for Francophone Africa. And it's a pleasure to welcome you, Deborah. So, Deborah, you have 8 minutes, because parliamentarian, what you are doing is really great. And then we need so many people to be aware of what the caucus is doing. So you have 8 minutes, please.
Thank you very much. Can you hear me? Okay, good. Thank you very much to ACT for having me. The Global TB Caucus is a unique network of parliamentarians, over 2,500 parliamentarians we support in over 150 countries in the world. And before and this would not be possible without the support that we get from civil society organizations. The UNHLM on TB was a very important event in history, and then we saw that based on the reports that we've been receiving, we are still very far from achieving the targets that were set. In the lead up to the UNHLM, parliamentarians from the Global TB Caucus took countless actions to ensure a strong delegation. However, we are still far, and worst case scenario, COVID-19 happened. Despite the fact that we are still far from achieving these targets, we need to give ourselves a pat on the back because there are several actions that are going on in countries. For example, Côte d'Ivoire had a joint restitution meeting, formed partnerships in order to achieve these UNHLM targets. Also, Nigeria contextualized the project. Zambia, for example, surpassed some targets. We also saw that donor countries work together to ensure the full replenishment of the global fund in the last cycle. Yes, there are several countries, donor countries worked together to ensure the full replenishment of the global fund cycle, the last replenishment of the global fund. La reconstitution du Fonds mondial. Where okay, so of course there are challenges, and for me, I think that some of these challenges to achieving these targets are information, for example. Coordination. There is need for more sensitization on the UNHLM commitments and targets themselves. There is need also for this in terms of universal health coverage. This is also important. There is also great importance for strong coordination between the regional and at the coordination both at the regional and at the country level. I think there are priorities, to go straight to the point, there are priorities that I think we opportunities for the region in Africa to prioritize. And these opportunities include purposeful and strong partnerships between regional caucuses and regional CSOs, like ACT, for example. Regional caucuses need to partner with regional CSOs to support national caucuses and CSOs to follow up on the UNHLM targets. Through strategic initiatives like the CFCS within the framework of very clear milestones. For example, through projects like the CFCS, for example. I'll give you a practical example. The Francophone TB Caucus right now is partnering with Draft TB through these projects of CFCS in order to support parliamentarians to follow up with the UNHLM in 12 Francophone countries. I think if such partnerships is replicated in Anglo-Africa, it will go a long way in coordinating accountability in Africa. The collaboration between partners is important, but the collaboration between parliamentarians and CSOs can never be overemphasized. This is because parliamentarians will bridge the gap between resource mobilization and policies, and CSOs will bridge the gap between the affected communities and the policymakers. A key barrier that we have is, in terms of achieving accountability, in terms of achieving this target, is that many people see oversight as a threat to their sovereignty. They see it as a threat to their sovereignty. However, in this space, if we need to move forward, we need to see each other as working towards a common goal. We need to support each other in the midst of the limited resources that we have through the power of leverage. Accountability should not be seen from one side. CSOs need to hold themselves accountable for their actions and inactions as well. And I'll give you, just to finalize, I'll give you a justification for why I am pushing for collaboration between the region and the national level. We have seen increase in budget in 24 out of 48 countries, which have been listed by WHO. 19 of those countries, from which form 80%, have members of the Global TB Caucus, and 11 out of those countries have national caucuses.
Hi, Deborah, can you summarize, please?
We have members of Global TB Caucus in those countries with increased budgets. Seven high-burden countries are on to achieving the TB SDG countries, and 4 out of those South Africa. 26 countries increased their pledges to the Global Fund compared to the previous cycle. The Global TB Caucus has 22 out of has members in 22 countries out of 26 of those countries. The countries that increased their pledges to the Global Fund. The countries that increased their pledges to the Global Fund.
Hi, Deborah, you still have 1 minute, please.
À la reconstitution du Fonds mondial, only 3 countries, the UK, the Philippines, and South Africa, have met their fair share of spending 0.1% of their overall research and development budget on TB research. These countries are countries where we have members. And South Africa. And in these countries that I've just mentioned, there are countries where in our biannual analysis and annual analysis of MPs' activities, we know that MPs in those countries have consistently been taking meaningful and impactful political actions. And this wouldn't have been possible without collaboration with CSOs. So I really look forward to a strengthened collaboration between, especially between the regional coordination body of CSOs in Africa and the Africa TB Caucus to support focal points in the region towards the achievement of the UNHLM targets.
Deborah?
Thank you very much.
Thank you, Deborah, for this wonderful presentation. And you make it very clear with facts, data, and I will come back with some key points later. Very amazing presentation, wonderful presentation. I enjoy the presentation. So we still have two presentations. We have, I don't know if Toko is on board. Toko, are you around? Toko, my friend, are you around? If Toko is not around, maybe you can have the representative of the Union Africa region, Ivan Anthony.
Good evening,
Ivan?
good afternoon.
Okay, thank you, Ivan. We have 5
Good
minutes
afternoon.
Yes, please go ahead.
All right. Yeah, thanks very much for the opportunity. I sincerely hope that you can hear me.
Yes, please go ahead. It's okay.
Thanks. Thanks for the introduction. I'm Ivan Anthony, and I'm the current president for the union in the Africa region. I believe that the union in this specific region of Africa is also focused on dealing with tuberculosis and, of course, the lung diseases challenges that we have. And, of course, our new friend called COVID. And I think the previous speaker or presenter has already touched on many things that we need to do. And those are the issues. A key word here is collaboration. Now, within the Africa region, we have lots of different organizations, as well as countries, as well as individual members that ascribe to the union. The union, the International Union Against Tuberculosis and Lung Diseases, which is a global union, have many membership in different forms from the Africa region side. And they, of course, are focused on many things. So I'm sure most of the colleagues are aware. They're looking at scientific research. They're looking at the TB challenges and programs that we can come up with. They're looking at innovation. They're looking at how we can share and learn from one another so that we will be able to achieve the things that needs to be achieved within our region. To that extent, we have, of course, a regional sector, which is a committee that exists within Africa. And I'm sure that there is an opportunity for proper collaboration with the CSOs and, of course, the TB caucus within the region of Africa. We have the different platforms in place for engagement. And therefore, I believe that whatever the previous speaker has said, we can actually start playing a part and a role to ensure that that proper coordination really are being realized within the confines of Africa. We have lots of ways and solutions that we have in Africa that we need to be able to share with one another. And through the platform of the Union Africa region, we have therefore established conferences in Africa, which allows for some of these learnings and sharing to happen. And to an extent, we also had made sure that in even our charter that we have as an organization, that we make sure that we have representation from CSO in Africa. Now, our common goal is quite clear. that we would like to see that we end TB or zero TB at least, in line with the Millennium Goals that has been set and the UN targets. And therefore, it is important that we really need to take hands. We will not be able to achieve universal health coverage if we don't actively involve civil society, but also in that, also the coordination part that needs to be played. We really need to come to the understanding that we cannot be in competition with one another. But the competition that we face is to eradicate tuberculosis and also dealing with the new stigmas of TB and also COVID. And I think if we really take hands and become responsible towards these specific issues, then sincerely we'll be able to make that specific difference. Now, to that end, I think from the Union Africa region side, as I indicated, we plan conferences on a year-to-year basis. And we have, unfortunately, due to COVID, we have not done the conference this year, but we will have a conference next year. And it will be, of course, in one of the Francophone countries. And we sincerely hope that it's these platforms that we are creating and the rest of the other organizations creating platforms that we will be able to start working in unison with one another, so that we can start dealing with the current challenges that we face within Africa. We believe that the Africans' challenges is also possible if we take hands to deal with those challenges by making sure that we share with one another. And therefore, the platforms that we need to create and that we have created thus far is there so that we can actually collaborate much better than we did in the past. But once again, I want to say that we are not in competition with one another. And therefore, it's important that we need to be able to share our learnings, share our research, share our resources where possible with one another. Because one of the critical things that we have is the lack of resources within Africa. But I believe if we collaborate and then we coordinate properly, then we'll be able to achieve the things that needs to be achieved. So it goes without saying then that the numerous different organizations that we have in Africa really need to be able to start speaking to one another more effectively so that we can address the challenges of tuberculosis and all the other lifestyle diseases within Africa. The solutions for Africa is not somewhere else, it is within Africa. And therefore we believe that we can make that difference if we want to actually work together. I think key word that has also been expressed is the issue pertaining to accountability. It is good to say that we are a CSO and we're doing our work and we're keeping all governments and parliaments responsible and accountable. But it's also important that we, as the CSOs, needs to be able to also account for ourselves. We need to be able to give answers where answers is due, and also ensure that we make sure that we become the eyes and ears of those that is in need, the vulnerable in society that is actually looking up to us, that we really play that part per se. I am therefore supporting and that wonderful presentation that has been done just now, because I think most of the issues that needs to be addressed within the region has been stated. And I think that if we really take hands, then we'll be able to achieve the ultimate result. And that is to scale up the actual health coverage within Africa, but also to advocate to different parliaments that is not actually adhering to the program. Can you hear me?
Ivan, we can hear you. We have 1 minute
Yes,
more.
yes, we can hear you.
Okay. I think it's important that we just need to make sure. I thought I'm lost, but be that as it may, I think it is important that we really need to just ensure that the global network that we have, that we take hands with everybody globally, but also in Africa, that we actually work together in achieving our ultimate objective. Let me stop there. Thanks.
Thank you so much, Ivan. So we are going to close our session in 2 minutes. But I need also find some final words from 2 people. Maybe we can have Deborah for 1 minute. And Deborah, for example, what do you think is the shortest path to universal health coverage? Deborah, if you can have 1 minute, and then the other minute will be to Dr. Edmund. If Dr. Edmund can elaborate on the USAID TB accelerator in Francophone Africa and how French organization can be involved in the process. So each of you have 1 minute, please. 1 minute. Deborah first, please.
Can you hear me, Bertrand?
Yes.
Okay, merci beaucoup. So I think the surest path to achieving universal health coverage, time will fail me to go over it again. But like I said earlier, effective collaboration with partners such as CSOs and parliaments. There needs to be strong budgetary provision for CSOs within the national TB programs. We need more trainings for healthcare workers. We need more advocacy to go out to parliamentarians on health system strengthening. If our health systems are strengthened, especially through TB, because through TB, you can access a lot of health programs. Right now we have COVID with us. So with COVID, the integration of TB services into the COVID response is very important. And this cannot happen without effectively carrying civil society organizations along. So like I said, increased advocacy, increased trainings, especially to healthcare workers, and also a close-knit coordination. I repeat, coordination between all partners, relevant stakeholders. Like Ivan said, we do not need to see ourselves as being in competition, but leveraging on the scarce resources that are available. Thank you very much, Bertrand.
Thank you, Deborah. Amazing. Dr. Edmund, please. 1 minute, please.
Thank you, Bertrand. So in terms of the TB accelerator, for now, the program is targeting the priority countries, the TB high burden countries. So we have it in 23, and in Africa, we do, I think some of the Francophone countries that are participating is DRC Congo. We don't have it in the rest of the Francophone because they are not part of the priority countries. However, I think as Sherry pointed out in the presentation, we do have support through TA mechanism that go to those countries, but they are not part of the accelerator. So that's what I can say. Over.
Okay, thank you so much for all my presenters. So our takeaway is that maybe if we need an impact in terms of the UNHLM or universal health coverage, the first principle is to have in mind that you are not in competition. And then some key strategic points that we need to advance in terms of information sharing, coordination, partnership, collaboration, mostly coordination between the regional level and the country level. Make sure that you are on the same direction. And this is the only way we can work together to achieve the impact in terms of universal health coverage and UNHLM. So thank you very much. It's also my pleasure to introduce my brother Abdullah for the next session. Thank you, guys. Over.
Thank you, Bertrand, for chairing this section. Thank you all panelists and presenters for this session. This This has been a wonderful session as well, especially a presentation from USID, from Deborah, Global TB Caucus, and Rosemary as well, and everyone who presented. We are moving on to the next section. Please use the chat box to also ask your question. Rosemary, if you can go and address a question from Lynette on the chat, that would be good. With the time, because of time constraint, we cannot open up for more questions. We have to move to the next section. Actually, we are supposed to be closed by now, but we're eating into the time of the participants. The next session will be chaired by Abdullahi, but I'm not sure whether he's connected here. If he's not connected, I can easily chair the section for him. Pastor Paul, can you please mute your mic so that we don't have any feedback coming from. So I will quickly chair this section on behalf of Abdullahi since he's not around. We will start the presentation with Alan is supposed to move with the presentation, but we will start with Mazim. At the end of the presentation, we'll bring in Heyon Lim from Global Fund just to share. She's going to support looking at the breaking down barriers around some of the CRG assessment in Ghana and also Congo DRC. I'm not sure whether she's online now. So Maxime Lunga, if you can just speak. This is a panel, you don't need to do any formal presentation, but if you have a presentation, we can share that later with all the participants. If you can speak on this section, is about bringing TB CRG assessment to scale in Africa, lessons and opportunities from the implementing countries. I know that I know that the CRG assessment, when we started, we were having the assessment in silos. We had a legal environmental assessment. We had a gender assessment. So now we have an integrated CRG assessment. But again, it's good for us to learn from our experience because it's coming from learning from what we are doing that informed the CRG integration assessment, which is really, really good. So Maxime, if you can take up the floor and speak, just 5 minutes because we are out of time. I don't want to keep all the participants here because we still have 2 days more to go. Thank you. Maxime.
Thank you, Chief Austin, for the microphone. I must again to speak in French, and I think that for now we cannot have the technical issues for the interpreter. Et vous nous accordez d'échanger de notre évaluation CRG. D'abord, j'aimerais dire que l'évaluation CRG était une bonne opportunité pour la RDC. Vu qu'elle est parmi les pays à haute charge avaient un gap en rapport avec l'évaluation CRG que nous avons conduit en 2000. La RDC, donc, sur les obstacles qui exacerbent la vulnérabilité à la tuberculose et entravent l'accès aux services de prévention, des diagnostics. Aujourd'hui, le pays se basant sur ces évidences des CRG assessments, appuie, élaborer les plans stratégiques nationaux avec un accent de la communauté des droits humains et des genres dans la TB. Et c'est là pour améliorer les taux de notification qui restent faibles, mais aussi pour améliorer les taux de succès thérapeutique. Ce qu'on a pu retenir dans cette évaluation CRG, c'est que le fait qu'elle était multipartie prenante et portée par le ministère de la Santé et les programmes nationaux de lutte contre la tuberculose a été constaté, bien que conduit par la société civile, c'est que le CRG reprochant de l'écriture, mais aussi de l'écriture du VIH. Donc, c'est là, après l'évaluation, c'est l'élaboration des plans d'action opérationnels des CRG, avoir une planification programmatique basée sur des évidences, et cela a été annexé dans le plan stratégique national TB-pays, qui nous a d'ailleurs permis à bénéficier du financement des challenges facilités, mettre en œuvre la surveillance à base communautaire, mais aussi ça a permis à ce que la demande de financement du Fonds mondial soit alimentée avec des activités claires en rapport avec les droits humains et genre TB, ce qui est une première pour la RDC. Donc, l'évaluation de la stigmatisation dans la TB, stigma assessment, qui est incluse dans la demande de financement NMF3 TB-VIH Fonds mondial. Donc, ce que je
Maxime, if you can round up, if you can be rounding up, we'll have 1 more minute, please.
Demande à tous les pays que l'évaluation
Okay, thank you, Maxime. I think we've lost Maxime here, but thank you so much for...
CRG permet de produire.
Thank you, Maxime. Thank you very much. I think we've lost him. Just to also use the opportunity to acknowledge the participation of Paul Pierre from USAID. Thank you for participating, Lynette Mbote and all. I will now invite Jerry Amualabi, the National Coordinator for TB Voice Network, Ghana, and also a member of TB People, to make an intervention on stigma assessment, that's an ongoing stigma assessment. Jerry, please, you have the floor. You have 5 minutes. Just go straight to the point in terms of the intervention and how you are doing it. Thank you. I know you haven't completed yet.
All right, thank you very much, Austin. And then Good evening and good afternoon to all. Basically, as you already said, we started with the TB stigma index in Ghana, which is being supported by Stop TB Partnership Geneva with Global Fund, and then WAPCAS, and then Ghana Health Service. Currently, the study is titled Assessing the Stigma of Tuberculosis in Ghana, the Consequences to Assessing and Provision of Services. We have two main study aims for the project. One is to assess the extent to which and how TB stigma acts as a barrier to both assessing and providing services. The second is to support the development of recommendations to address the stigma so that quality of TB services are available, accessible, and acceptable to all, with special consideration given to the need of key vulnerable and underserved populations. The study also objectives of the assessment. We are using the assessment that was developed by the tool that was developed by the Stop TB Partnership. So we're also looking at the 6 objectives of the assessment, and the tools that we are using is from the Stop TB Partnership TB stigma assessment tool that we are using currently. So the objectives were shared early in the morning by one of my colleagues from Nigeria. The protocol, the development of the protocols and ethics submission has already been done. We've already gotten the approval from the Ghana Health Service, the Ethical Committee. We also have the Scientific Advisory Committee that also making sure that all the activities are well coordinated from the Scientific Advisory Committee, which is also chaired by a civil society, and also have a government representative on it, and civil society and community members. The sample size for the study, we're looking at in all 4,220. We're looking at TB patients, 981. We're also looking at the family members, the caregivers. We're looking at the community. In terms of community, we're looking at opinion leaders, the chiefs, the imam, the pastors, also making sure that we also assess them in terms of the stigma within the community. We're also looking at the health worker who also provide services to these TB clients at the dot. So far, we've gotten the approval. We've started data, we've trained our data collectors. Let me say that majority of the data collectors are also cured TB patients who are of sound mind and also can read and understand. So in all, we have about 25 data collectors. Out of this, we have about 10 of the TB community members participating actively in the data collection. We've trained them on data bias. We trained them on how to assess and use the stigma study tools currently. So far, we've done quite a number of the activities in terms of, we are in week 2 of data collection. This week is the 3rd week. By the end of 30th of October, we'll be done with the qualitative, and we do the quantitative within 2 weeks. We are also doing this not only with Ghana Health Service, but we also have key stakeholders from the National TB Program Control. In fact, even though TB Voice Network is a community which is currently leading the stigma index study in Ghana, we are doing this in collaboration with the PR for civil society with WAPCAS, and we're also doing it in collaboration with the National TB Control Program, the Ghana Health Service, and also the Ministry of Health as well. So we've gone through the trainings has been done, data collection has begun within 6 regions in Ghana. And we're also looking at making sure that by the end of this month, which is 30th of October, data collection will be done. And then we'll do the analysis and then the report will be out. We're using a software called the RedCap, which is an electronic data capturing software, which makes things very easy, which can work offline, where the research assistant can use in terms of where they are to be able to gather their data. Some of the challenges that we've been faced so far has to do with some of the facilities not receiving the letters from the Ghana Health Service. So it has been very difficult for some of the facilities giving us the access. But in all this, I think what we've been able to do is to also make sure that whenever we are going to the facility, we hold a hard copy of the letters from the Ghana Health Service, and then one from the region, and the other one from the letter from the ethical committee approval for the study to be done. Aside that, we're looking at another challenge has to do with the geographic of some of the areas that we need to go to. Some are very hard to reach areas where you need to journey for 4 hours in and out before getting the community as one of the issues we've been able to identify. We're looking at disseminating the results with our international partners, the Stop TB Partnership Geneva. We're looking at also with MOH, Ghana Health Service, all stakeholders, Parliamentarian Select Committee on Health, and also peers in other networks like the PLHIV community, and also the SAC members that we need to disseminate the information on. We normally have a weekly report and an update with our partners, both the MOH, WAPCA, TB Voice, and also the National TB Control Program. We're looking at developing the first draft, as I said, and then action plans by the second week in November. And then we have a stakeholders meeting to discuss the content of the action plan and also present in terms of the representative from all the stakeholders and the community leaders also playing a critical role in this assessment. So, Chief, that is a brief of what we are doing currently. And thank you very much, and over.
Thank you, Jerry, for that wonderful presentation. Let me acknowledge that you shared your slide earlier, but it's good that you actually went through this without a slide, because maybe you could have taken more than the time. But we shared the slide with all the participants. It's a wonderful slide that he had to use for the presentation. Let me acknowledge that Timothy will be presenting on behalf of Alan, and also Rodrick will be presenting as well. But before we go on to their presentation, I want to bring in Heyon Lim from the Global Fund for a quick intervention. Heyon, if you can also, you have a short slide. If you can share your slide, if you can share your screen with this, for the slide, that's fine. You will have 5 minutes for this presentation, this intervention, so you can just go on and share your slide and move on.
Thank you very much. First of all, thank you so much for having me on the panel. And it's so nice to hear from you, Jerry and Maxime, the two great the TB activists that we are working with at the Global Fund. So without further ado, I'm technologically inept, but if you can just confirm whether you can see my slides. I have actually shared.
It's perfect. We can see you. We can see your beautiful face and your slide as well.
Great. So since I have only 5 minutes, I will probably move on some of the slides relatively fast. So I'm sure, oh, sorry, I'm trying to move my slides. Okay, I'm sure you have seen this slide time and time again, but any respectful Global Fund presentation cannot start without introducing the Global Fund strategy. So as you know, Global Fund strategy, we have a strong focus on human rights and specific focus on increasing investments in concrete human rights programs to address human rights and gender-related barriers. As you know, that focus on really increasing and galvanizing the support for human rights at the country level is not new in the Global Fund. We have seen that in our previous strategy. But the difference is in the current Global Fund strategy, NFM2, and hopefully we will continue with the NFM3, that we are encouraging, certainly encouraging countries to invest in programs to address human rights related barriers beyond the advocacy. So in order to, in a way, implement this Global Fund strategy, we have launched in 2016 Breaking Down Barriers project. I'm sure many of you are already familiar with the terminology Breaking Down Barriers project. We have launched in 20 countries with a specific aim to understand the rights-based, rights-related barriers that our key communities are facing in the country level for HIV and TB, but also to understand what are the existing programs that we can build on. And most importantly, how we can support the country to develop a comprehensive human rights response to address the rights barriers, gender-related barriers in a multi-year plan, but in a comprehensive way, that we are not only focusing on advocacy or law reform change, but in a way that makes an impact. So in 20 countries, as I mentioned to you before, we have a human rights focus, HIV focus in those 20 countries, and we have selected 13 countries where we really want to devote more focus on TB. And we have discussed it a lot, when we were launching the BDB process, the discussion on human rights, and especially human rights programming, has really been on a nascent stage. We haven't really identified the great programming experience or the great examples in the context of TB at the stage of launching the BDB process. So we selected 13 countries where we saw the opportunities with a strong TB communities and CSOs, where there were willingness and commitment to really follow through this process. So through the Breakdown Barriers project, we have identified the human rights and the related barriers in the context of TB in those countries, but also identified key community partners and civil society partners. They are pushing for human rights and patient-based the services in country. But what we have also learned is that we don't really have a concrete clear set of human rights programs that we can push for in our Global Fund funding request. So in 2018, together with the TB Technical Working Group, the expert group, where the civil society, TB community representatives were part of it, technical partners were also represented, we have sat down and really looked at what are the key human rights programs that we would like to see in the context of TB to be able to comprehensively address human rights and gender-related barriers. And these are the 10 key program areas that we have come up with. I'm sure you're all very familiar with these programs. Maybe you have coded differently. Stigma and discrimination reduction programs or medical ethics programs, or the programs to increase awareness on your rights, patient rights. So these are programs that we have included in the modular framework. We also have indicators in our the Global Fund modular framework, the performance framework, to really track how the countries are implementing, following through these programs. So let me just share some of the good examples and what we mean by comprehensively programming for human rights in the context of TB. So for instance, in Ghana, as I mentioned to you before, I'm so glad that Jerry is on the call. So in Ghana, we are working with our country partners, including TB Voices Network and WAPCAS and civil society that implements the key population human rights programs, to really develop a comprehensive human rights response. So in Ghana, we are supporting TB champions to not only do a service delivered for TB, but also be the advocacy agent to do the know your rights for their communities. We also be part of the community-based monitoring of understanding where are the issues, where are the human rights violations in the context TB, and also linking up with the pro bono lawyers and also the legal aid that is available through the grants. So also in DRC, and Glad and Maxim have spoken about the really wonderful role that the organization is playing, that we are supporting implementation of a One Impact tool, and together with the TB, HIV communities, that we are hoping to build a comprehensive rights response that includes know your rights for the TB communities, linkage to legal services, and understanding the service quality issues. That includes not only the stock outs, but also stigma, discrimination, breach of confidentiality, and other breach of medical ethics in the healthcare facilities. And also in Ukraine, we are building in psychosocial support and stigma reduction approaches, and also the legal support in the DOT programs. And we are hoping to continue to do that in NFM3. We are already seeing some progress in many of the countries where we will, for instance, Ghana, again, we will continue to support the TB community paralegals to be able to do a community legal empowerment programs. In Indonesia, we are working with the communities to build their capacity around the access to justice issues. And DRC, absolutely, we will continue to support and work with Maxim and his organization and communities to really inbuild the Know Your Rights and Access to Justice programs as part of the, naturally part of the TB response. And we have made great progress. You know, our starting in NFM1, I'm sure you remember, NFM1, we were investing less than 0.1% on human rights programs. To be precise, we are investing 0.08% of the Global Fund TB grants that are going to the programs to address human rights and gender-related barriers. And this is the very rough results that are coming from the NFM2 cycle. We have looked at all the signed grants, and maybe in the session 2, I think Kate has also briefly referred to this slide, maybe. So from 0.08%, now we are investing around 1.1% of the TB allocation on human rights and CSS programs. So around 50 countries where we are supporting the TB response are including TB responses. However, considering that, the majority, the absolute majority of the TB funding requests are identifying stigma and discrimination as a major issue to accessing TB services. Confidentiality or the loss of education opportunity or the work opportunity as a major barriers in accessing TB services. 1.1% of the TB allocation going to the TB, the HIV, human rights responses. It's just not going to be enough. And of course, your role in getting engaged in the Global Fund funding request processes and really advocating, pushing for the more investments on quality and comprehensive human rights response is absolutely, absolutely essential. And as you know, through the CRD SI, we are making supports available to the communities and CSOs to better engage in the Global Fund, the processes from the funding request development, but also throughout the grant making and implementation and monitoring accountability of our program implementation. So this is just my final slide. This is kind of fun slide. It just kind of shows where those 1.1% of the investment, human rights investment is going to. So as you can see, the big chunk goes to the stigma reduction and assessments. And there are many different elements that we are supporting. For instance, the sensitization meetings or the gender and human rights related advocacy. But here, what I want to highlight is that while we are supporting a wide range of the programs, which is a comprehensive, we need to think about the scale of these programs. If we do not fund the programs in the scale, we will not make an impact with all this variety of the programs and also the quality. We should avoid investing in stigma reduction programs that are done once a year, maybe around the World TB Day. We need sustainable, integrated, the human rights approaches that are part and parcel of a TB response. And your role in pushing that advocacy at the country level and help us to figure out what works best for the country is absolutely essential. And we are very proud to support you. And I'm very happy to be in this meeting. Thank you very much.
Thank you very much. Let me also say that the campaign that we are going to launch tomorrow, which is called Sustainable Communication Response on TB, will take care of this gap that we have in advocacy around TB and also components in like human rights and all the rest. So it's not just about having TB only during the World TB Day. So thank you so much for bringing that out. I will move quickly. Please, if you have any question, just go into the chat box and have the question there, because I will have our panelists will all be answering the question from the chat box. I will now move quickly to Timothy, who is going to step in for Alan Maleche to speak about the traditional legal environment assessment that they did in Kenya. Please, Timothy, if you are there, if you can move quickly so that, thank you. You have 5 minutes, please. If you can do it in less, that would be wonderful. You have a tip from me.
Thank you. Okay, thank you very much. I will quickly be stepping in for Alan and just sharing on what we did with the TB agenda data in Kenya. Kelly, with support from Stop TB Partnership, rolled out or piloted the conducting the TB legal environment assessment, the TB data and assessments, and all these assessments were guided by the tools that are the CRG tools that were developed by the Stop TB. So just noting that these legal assessment, I think, was one of the major trying to look at what are post barriers and the process did with comes to what are some of the existing legal barriers, what are some of the key vulnerable and underserved populations who
Timothy, I think your network is a little bit bad, and if you can speak slowly for the interpreter to also interpret for the benefit of people listening in French.
Oh, I'm sorry. So I hope I'm clear. I'm to go slowly. Maybe proceed, noting that this legal assessment, the aim was just to get to know and have a consultative process to understand what are some of the barriers that exist at the country level in relation to TB, being the legal barriers, gender barriers, and also issues to do with the key vulnerable and underserved populations who are not who have not been catered for within the. So just for today, we just wanted to share maybe some of the maybe results that arose out of these assessments. So one thing that maybe we can share is that through the assessment process, we did ensure that the country had a moment to reflect and just to have a conversation on TB conversation of that exist that need to be addressed. And a good thing due to these assessments was that during in 2019, as the National TB program was developing its national strategic plan, the assessments did play a major role, and the findings were incorporated into the strategic plan as some of the issues that the plan from 2019 to 2023 should address. So now we have as one of our strategic plan or objective being that the National TB Program has one of the focus areas to remove legal, human rights, and gender barriers that hinder access to TB services. And also they have put in a focus around just working around monitoring and having a conversation on laws, regulations, and policies that are relating to TB. They also have as one of the focus areas issue around sensitizing lawmakers, law enforcement agents, and healthcare workers. And all these were in line with the findings of the assessment. So another issue that we can say has been a major result of this assessment was that a national TB isolation policy, which was one the recommendations from the assessment, and provides guidance management teams at the national and county levels in relation to isolation for eligible TB patients. So with fast tracking of the disease, I think this addressed the challenge that we previously had, whereby TB implementation of measures to implementation of some TB measures with TB, whereby they'll be taken to prisons, was a good step. And I think at this time now, it's been an issue. The issue is now just more advocacy to have all the policy now implemented at the national level. So we can, and also another aspect that we can report from the assessment was that most of the findings of the assessment were very critical as a survey for the global fund. So in having that conversation for the baseline assessment, findings of the both assessments were very critical in informing issues in the baseline and stirring up debates on TB and human rights. So we can say to a good extent that both at the community level and the government level, these findings did provide like a blueprint.
Timothy, if you can be concluding, you have 1 more minute to conclude, please. Okay, just be rounding up and conclude. Thank you.
Okay, thank you. So maybe in conclusion, we can say that these assessments did provide a blueprint for both civil society and government now, just to ensure that issues of human rights of people affected by TB at both the community, county, and national level are taken care of. So yeah, that's just quickly around the assessments, and we'll be sharing our presentation with the team in a short while. Thank you. Austin, over to you. Thank you.
Thank you, Timothy, for that wonderful presentation. Let's have Rodrick to speak about the action plan, because once you finish the CRG, if you finish the CRG assessment, you need to a plan. You need to have a plan to move forward. That will be our last presentation for the day before we go into a party. Thank you. Rodrick, please, you have the floor now.
Thank you, Austin. I think I'll share this. I just have a few slides. Just to mention that Tanzania is one of the countries that did the assessment in 2017. And in 2019, 2020, that's when we came up with the CRG action plan. So I think one of the reasons that we had to come up with the action plan, one is around, because we did review through the assessments, we realized that the national strategic plan did not have any CRG components. So having an action plan was just to inform that, to inform the new strategic plan that has been developed, the upcoming one, so that it makes sure that it has all those components, but also we know that the global fund applications as the country submitting application, so having the costed action plan was the key to that. But I think it also not just the CRG assessments, but also looking at there's some other initiatives that we realized that were done in the countries. For example, civil society had their own priorities that needed to be included in the action plan, but also there are some other studies that were conducted in the country that we needed to look at in combination with the assessments, so that we come up with a consolidated action plan, taking into consideration of other processes that have taken place in the country. So in terms of the process, how the action plan was developed, it was coming up with it was done joint between IANASO and the National TB Program, where we came together and went through all the assessments to look at the recommendations, but also looking at the other processes that have taken place in the country, the studies, and also the civil society priorities. So through that, we came up with the priority actions, the consolidated priority actions and recommendations. And then based on those recommendations, we identified the key stakeholders, because developing the action plan, we need to have one stakeholder workshop so that we can develop the action plan together. So based on the key findings and recommendations, we identified stakeholders for those actions, and then that's when we came up with the stakeholder workshop to validate those findings and recommendations, and then use that to develop the action plan. In terms of we had the stakeholders, we have that's the National TB Program, we had the AIDS Control Program, and also we invited we had the Gender Department, representative from the Gender Department, we had the Legal Sector Commission Reforms, also had the representative from the TB Caucus, the National TB Caucus, and also other implementing and development partners. But of course, more important, on the civil society, we had representatives from the people who use and reject drugs. We also have PRHIV. We had the TB community. We have the TB network community, and also have network of TB survivors and some other civil society that I've not mentioned there. So it was a very big stakeholder team. So through the action, we came up with around 6 interventions, and one which was focusing around reducing gender barriers to TB services and addressing stigma and discrimination. We advocate for reforms and policies. Also, we also looked at promoting multi-stakeholder collaboration and accountability for TB response, mobilizing and empowering communities, and then scale up of innovative approaches to increase the access to TB care treatment among the key population. But also we had one that was around monitoring and evaluation. So especially because we had developed the action plan is for 4 years, and we needed to monitor how it's progressed. So had intervention around that. So the total cost for the action is around $1.6 million US. And of course, the funding comes from as I mentioned, that we have the strategic plan that has been developed which is informed by action plan. So if you look at the new strategic plan that is to be, I think, at the end of this year, you find that most of the things that have been included in that around CRG, they have just been derived from the action plan. Then it has also been used to inform the country grant, the funding request that was submitted. So all that intervention around community rights and gender are derived from the action plan, but also as the challenge facility for civil society that we are implementing in Tanzania by UNASO and Family Welfare Foundation, or our intervention that we have in the challenge facility, they are also been informed by the costed national action plan. So you can see that even beyond that, it's not just on that. What we discussed was that because the National TB program has a coordinator of all TB interventions, wherever there's an implementer that comes in the country to do any TB interventions, so the action plan is already there to share with them, so that as the plan intervention, they also see on what things that can be done. So there's that coordination around the action plan. And also in terms of civil society, it's also coordinated by the Tanzania TB Community Network, which look at the overall implementation and the monitoring of the action plan. So those are the key outcomes of the action plan. Of course, in terms of lessons, we see that a good working relationship that we had with the National TB program, civil society, I think it has been very key in terms of coming with the national costed action plan, especially in terms of having the ownership from the Ministry of Health and also from the civil society, because so that it doesn't look like as if it was maybe IANASO or Stop TB Partnership agenda. But it's also, in terms of moving forward, I think it also, as those that will be going into developing the action plan, I think take consideration of engaging the global funds, the CCMs and country teams is also important. In terms of financing the action plan, I think I see, because there's a lot of money and only the country grant and challenge facility they are not enough to provide that 1.6 million. So as a country, we continue mobilizing resources, also through engaging with the members of parliament through the domestic resource mobilization. So I think next year what we are planning up is we'll be having an advocacy plan that are focusing around domestic resource mobilization, which we hope to help in terms of getting more resources to finance the action plan. I think that's all I can share.
Thank you, Rodrick. Thank you so much for sharing. Thank you to all the panelists. Thank you so much. Let me first of all use the opportunity to say thank you, merci beaucoup, obrigado. I want to share one experience that I could have actually invited the Guinness Book of World Records to be here, because this is the first time I have actually been on Zoom for more than 7 hours. This congratulations to all of you, to our partners, USAID, to our Stop TB partners, to our Global Fund partners, to all our colleagues from Anglophone, Francophone. This is so wonderful. Thank you to Tapiwa. I recognize you from Patam. Thank you to Eram from TB People. Thank you so much. This is just wonderful. I must have to say that I have never been on a Zoom call for more than 5 hours, and this is something that is so great. We will be starting tomorrow at 8:30 in the morning. Tomorrow is quite a short program because we are anticipating to end at 1 o'clock. So it's just about 4 hours to 5 hours program for tomorrow. And on the third day is just for 3 hours. Today, I acknowledge that it's so loaded, but we're able to achieve. So this has shown that civil societies can also do it. Communities can also do it with the support of partners, these great partners on board. I acknowledge the presence of Dr. Ruta and also Dr. Pierre Paul from USAID. So much thank you to you staying on the call from morning till this evening. Tomorrow, I'm going to provide a virtual lunch because one of the participants was asking me, where do we go for lunch, like what we usually do in our meetings. We should find a way to provide our virtual lunch. And also for communities, for community members who are also on the call, we have your list. We are trying to provide data for you through our country partners. So you will hear from us soon. So thank you to Tandy. Tandy stayed on from morning till this evening. Thank you so much for helping to coordinate and also shape what is happening here. We are so happy and grateful for all of you, especially the participants who stayed on. You all deserve a round of applause. Thank you so much. Thank you so much. A round of applause to all of you. Thank you. So meet you tomorrow. Draft TV, I see you. We'll meet tomorrow again to have a wonderful section. Thank you to all the participants. Thank you so much. And thank you to the interpreter as well for supporting. Thank you, Hayon. I see all of you. Thank you so much, Mrs. Augustine. Thank you.
Bye, Chief.
Thank you, Deborah. Thank you, everyone. Thank you.
Thank you, Austin. Thank you all.